Hi everyone, a very good afternoon to all of you. I hope all of you are doing really good. So welcome to LRR session of Psychiatry. So quickly let me know in the chat box if I'm audible and visible to all so that we can get started. A very good afternoon. I hope the preparation is going really good. So now in this LRR session of Psychiatry, what we're going to do is we're going to discuss some important topics. Now this LRR Psychiatry session will be useful for all the students who are preparing for be it INI-CET, be it NEET PG or be it FMGE exam, yes. So it will be useful for all the students. So what I've done in this LRR session is we are going to discuss all the important topics. So we are going to discuss all the important topics of all these exams, and also we'll touch upon some important previous year questions. Again, a very good afternoon everyone. And what I've done is we'll also talk about FQs. You know, FQs, I say these are future questions. So I'll also cover some of the questions which can come as potential new questions. Now, as we are seeing that there is no clear cut boundary when we are talking about the questions, you know, be it INI-CET, NEET PG or FMG. So you'll see a lot of the topics are being inter-exchanged in various exams. So in fact, I'll show you also so many questions of one exam has been asked or the topic is repeated in another exam. Of course, there are some topics, you know, which I'll specify especially for INI-CET students. So I'll tell you some topics. Of course, the boundary is very blurred. You know, other students preparing for other exam can also listen to those topics, but I'll tell you some important topics for INI-CET also in the end, you know, when we'll give the slides. So please don't worry, all of you will be, you know, getting the PDF. So don't worry about the PDF. We'll share the PDF at the end of the session. So what I'm going to do is when I'll, you know, share this PDF, I'll also add some extra slides so that, you know, those who are preparing especially for INI-CET exam can go through those slides. So let us start the session again. You know, in the start, you know, I would like to make a point. You know, all of us might have heard about, you know, Sunita Williams. She went to space for few days mission, but she was stuck and she had to spend nearly more than 9 months in space. But she returned, you know, along with the crew member, she returned, you know, safely. So it's very important. You know, one of our previous quote is, don't get bogged down by the notion of limits. There aren't any. So anybody who's preparing for any of these upcoming exams, you know, even if you think that, you know, you're not prepared well, please remember you have time. And in this time, you know, anything is possible. So carry that positivity with you in the upcoming days and you'll see that you'll do really well in the exam. Now, before starting, let me come to these bubbles. You know, I always say in psychiatry, you should know some of the important topics. Once you are clear, you know, the question has come from which topic, many times you will be able to solve the question easily. So what we are going to do is we are going to start with the basics. I'll discuss, you know, a very important topic, that is MSc, very important, especially for NEET PG and FMG exam and also for INI-CET. Then we'll talk about organic mental disorders, that is delirium, dementia. We'll talk about those disorders. Then we'll come to psychotic disorders like schizophrenia. We'll talk about mood disorders, that is depression. We'll talk about bipolar disorder. Then we'll come to the neurotic disorders. Again, we'll talk about all these important neurotic disorders such as anxiety disorder. Again, OCD, a very important topic we'll cover, PTSD. We'll talk about, you know, topics from child psychiatry. A very important topic for your exam is the substance use disorder. Substance use disorder, you know, you'll see so many questions being asked. Then we'll talk about some smaller topics like eating disorder, sleep disorder, personality disorder, sexual disorders, and some of the miscellaneous topics also we'll cover. So remember these important headings so that you get an idea, you know, that what are the topics being asked in the exam. So let's start with the first question. The question is, a 30-year-old male presents with a diagnosis of schizophrenia. Family members report that he doesn't show change in emotions in any happy or sad event at home. Which of the following is a false statement? So try to identify what is the phenomena asked in this question and then answer the question. So let us see if we can answer this question. So I've made some of these questions so that you get an idea. You know, again, very important, you know, point I would say, especially in NEET PG and FMG exam, they are not repeating the question. You're getting newer questions. In INI-CET still, I would say, you know, previous year questions are getting repeated. Very good. The correct answer is, the phenomena which we are seeing here is, can you appreciate, this is flat affect. Very good. The first option is correct. You know, again, I always say, remember the names and you will understand psychiatry. Just see the name, flat affect. Flat affect means, you know, when we do ECG, we get such waves. What is the ECG of a person who is dead? It is flat line. So flat affect means as if the emotions are dead. So here, positive emotion, you know, event is coming, negative event is coming, the patient is not showing any changes in emotion. So it is affective flattening. Is it a negative symptom of schizophrenia? Yes. In fact, this question was asked in January 2025 FMGE, that flat affect is a negative symptom, also sometimes referred to as blunt affect. So remember this. Also very important, remember that it is associated, negative symptoms are associated with decrease in dopamine in the mesocortical pathway. Again, we will talk about this. It is not labile affect. Yes, so the incorrect statement is it is not labile affect. So what is labile affect? Again, see the name. Labile means something which is not stable. So labile affect is rapid and abrupt changes in emotion. Now can you tell me where would you see labile affect or lability? So labile affect means we are talking to a patient and suddenly without any reason patient starts laughing, then he starts crying again, then he starts laughing. So can you appreciate rapid and abrupt changes in emotion? Very good. It is seen in mania or bipolar disorder. I'll take both the answer. One more condition I want you to tell me. Very good. Yes. Another important condition, remember, it is organic mental disorder. So in these conditions you may see labile affect. So again, very important, affect is a very important topic. Also I'll just briefly tell you two more important terms. I hope all of us know what is inappropriate affect. So we are talking about certain abnormalities of affect. What is inappropriate affect? Can anybody tell me? When the affect is not matching with the situation, remember. So the affect is not matching, is not according to the situation. Suppose a patient goes to a funeral, everybody is sad, but at the middle of the funeral he sees the dead body and starts laughing. So can you appreciate the affect is not matching with the situation? One more term I want you to remember is incongruent affect. Can anybody tell me what is incongruent affect? So remember some of these terms. What is incongruent affect? Very good. Yes, all of you are answering correctly. When the affect is not matching with the mood or the thoughts of the patient. So the patient, when asked, how is your mood? See what the patient says. Patient says, sir, my mood is very sad. So can you appreciate, he is, his affect, he's smiling, he's laughing, but he says that the mood is sad. So can you appreciate the mood and affect are totally opposite. So this is incongruent affect. Again, you may find these abnormalities of affect in conditions such as in schizophrenia. So I hope the abnormalities of affect are clear to everyone. Very good. Let's come to the next question. See this question. A 25-year-old male reports his neighbors are planning to harm him despite being given contrary evidence. He suspects strangers are talking about him. He also believes that he is the king of the world. Which of the following you have to see is the false statement? Again, when I'm discussing psychiatry, I'll also discuss, how to approach MCQs. Very important is you see some of the important terms, keywords. So I'm highlighting some keywords. Also remember they have asked false statement. So tell me what is the right answer? False, fixed, firm idea or belief held with extraordinary conviction. It is correct. In fact, we are dealing with delusions. Very good. It is correct. Delusion, we know it's an abnormality of content of thought. Very good. So can you appreciate what all delusions are there in this case? He's suspecting neighbor is planning to harm him. This is delusion of persecution. He also says that strangers are talking about him. This is delusion of reference. He also is saying he's the king of the world. So delusion of grandiosity. Yes. So this is also correct. Is it explained by social cultural background of the person? No. Delusions are not explained by social cultural background. So can you tell me, if there is a belief which is false, held with extraordinary conviction, but it is explained by social cultural background, can anybody tell me what is this known as? Sometimes this may be asked. So what is this phenomena which can be explained, which is very similar to delusion but can be explained by social cultural background? Many societies, many cultures have certain beliefs. For example, some people believe that if a black cat crosses your way, something bad will happen. है ना, काली बिल्ली ने रास्ता काट दिया, कुछ अपशगुन हो जाएगा. So much so they will wait for half an hour, 1 hour till somebody else cross by. Very good. This is superstition. So you may be asked to differentiate between delusion and superstition. Superstition can be explained by social or cultural background. Very good. Yes, that is the right answer. Very good. Now tell me, let's now talk about a very important topic. In fact, I say this is a VVIP topic for your exams. Delusion, in fact, abnormalities of thought is very important. Please don't go in the exam, without revising this. Of course, I'm not saying don't go, you can go, but please revise this topic because many questions you will be getting from abnormalities of thought. Tell me, delusion is a disorder of flow, content, form or possession, So we have discussed delusion is an abnormality of, content. In fact, this question was asked in FMG exam. Delusion is an abnormality of, there the option was very simple, thought. It's an abnormality of thought. Very good. Now let's see some of the delusions. So there are various types of delusions. One is delusion of persecution, which we have already covered. Patient thinks that somebody wants to plan to harm him or kill him. Please remember, harm him. You know, sometimes they may say that patient is suspecting. In fact, this was asked in one of the questions, that a 16-year-old girl thinks that the school principal along with teacher wants to fail her in the exam. So she thinks somebody wants to harm her. So this is delusion of persecution. Delusion of reference, patient thinks that everything around him is in reference to him. So patient thinks that people are talking about him, somebody spying on him. So this is delusion of reference. Please remember, in psychiatric disorders, the most common delusion is delusion of persecution. Very important. Let's discuss some of the other delusions. Grandiosity means patient is making false big claims. So patient may claim, you know, that I have supernatural powers. You know, just like Thanos, I can snap my finger and do anything. Patient may claim that Prime Minister, you know, asked me how should I run the country. I made Donald Trump the president. Although neighbor does not know him, but he may claim such big things. Then what is delusion of nihilism or negation? Very good. What is delusion of nihilism or negation? Here, patient is negating everything. So patient is denying existence of his self. Patient may say that I am a dead person. I don't have any intestine. I don't have a brain. Or he may deny existence of his loved ones. Everybody is dead. Everybody is just a plank of card. Or he may deny the existence of the world. The world is a dead place. So please try to remember these points, because nowadays they will give you such clinical scenario and you have to identify which delusion. Now there is a very interesting syndrome known as Cotard syndrome. Can anybody tell me Cotard syndrome is associated with which delusion? In fact, this question has been asked both in FMGE also, and also this question was asked recently in INI-CET also. So remember, Cotard syndrome is when a patient with depression, he develops delusion of nihilism. Very good, yes. So then we use the term Cotard syndrome. In fact, a very tricky question was asked in INI-CET. The question was very simple, that a patient has depression and he says that I don't have a brain, what is the point of eating anything? So patient with depression is having delusion of nihilism. The question was which delusion is present, and the option was, one option was delusion of nihilism and another option was Cotard syndrome. So can you tell me what would you mark in the answer? So they had given a patient with depression with delusion of nihilism and they had asked which delusion is seen. So the question, again, always read the last line, what they are asking. Okay, is it clear to everyone? So please remember, yes. So the answer there was, I understand all of us have understood the phenomena is Cotard syndrome, but the question was which delusion is seen. So please be very careful. You know, sometimes you know the concept, but please see what they are asking. So very important to remember. Yes. Now let's discuss another important, delusion. So see this question again. Similar questions have been asked. So let us see this question. A 30-year-old male suspects that the wife at home is not his wife but a stranger who has replaced her. He continues to argue with her and gets aggressive as well. What is this likely phenomena? So can you appreciate here the patient is having a false belief in his mind. So it is a delusion. So which delusion we are talking about? So I hope everybody is clear with what is a delusion. It's a false thought which has come in the mind of the patient. So what is this? It is very good. So options are Fregoli syndrome, Capgras syndrome, erotomania, delusion of infidelity. The right answer is yes, it is Capgras syndrome. So please be very careful. In fact, I'll highlight some of the questions, some of the points as hashtag. Nowadays anything which is trending, we put a hashtag. So I'll put some hashtags. So very important, such questions may be asked. Okay. So let's talk about two important delusional misidentification syndrome. Again, see this. So misidentification means that person is having problem in the identity of the person. So two important syndromes will cover here. One is Capgras syndrome and another is Fregoli syndrome. Very good. I always say, but please try to remember these tricks. See the name Capgras. So I made one trick, Capgras syndrome. Just see the name. In the name itself, you will see this close person replaced by a stranger. Like in this case, patient is suspecting that his wife is not his wife. So a close person, in this case wife, has been replaced by a stranger. Nothing of this sort has happened, but it is a false thought in his mind. Fregoli is just the opposite. Here the person thinks that familiar person is imposing a stranger. So for example, a patient goes in public place, he meets a stranger, let's call him S1, and he says to this stranger, you are not a stranger, you are my wife in disguise, what are you doing here, go back home, go back home. So this is Fregoli. He thinks that a familiar person is imposing as a stranger. Always remember these tricks. whenever you get confused, always see with whom the patient is arguing or fighting with. So remember in Capgras syndrome, very good, yes, Capgras syndrome, he is arguing with the close person. So remember C for Capgras, C for close person. Like in this case, he is arguing with the wife, no, you're not my wife, you're someone else. So this is Capgras syndrome, while in Fregoli, the person is fighting with the stranger. Like in this case, he is arguing with this stranger, no, that you're not a stranger, you're my wife in disguise. So this is Capgras and Fregoli syndrome. Very, very important. Please remember these points. Now also let's talk about some of the other options given. So what is erotomania and what is delusion of infidelity? Let's cover these also. Again, please remember these names. So we'll discuss two delusions with different names. So one is erotomania, also known as de Clermont syndrome, also known as delusion of love. Now what is love? You know, love is something when you say I love that person, but this is delusion of love. Here the patient claims that someone else is in love with me. So a 25-year-old female, let us say, is claiming that the superstar Salman Khan is in love with her. So she may say that the movie Kisi Ka Bhai Kisi Ki Jaan, which came, you know, in that movie the Jaan was me, I was that Jaan. So the Big Boss show he hosts, the Big Boss Eyes is telling me that he is looking for me. Although the actor might have never met this patient, but the patient is claiming that someone else is in love with me. So this is delusion of love. Yeah, very good. What is delusion of infidelity? Again, see the name. Infidelity means that my partner is cheating. Also known as Othello syndrome, also known as morbid jealousy. So here what is happening? Here the patient claims that my partner or spouse is having an affair. So 40-year-old male claims that my wife is having an affair. Everybody is trying to convince, सब लोग convince कर रहे हैं उसको ऐसा कुछ नहीं है, but he is not getting convinced. So this is delusion of infidelity. Now please remember, when we say delusion, these are psychotic symptoms. This is a psychotic symptom, can be seen in psychotic disorders like schizophrenia, and even in other conditions we'll discuss can be seen. Can anybody tell me one important substance? Very good. One important substance which is associated with this. Again, this can come as a new question also. Has been asked previously, this can be asked in a clinical way. So which substance he is consuming? Very good, yes, alcohol. You know, sometimes we see patient who is consuming alcohol for a long time may start doubting the partner, that the partner is having an affair. Very good. So a very important topic of delusion we have talked about. Remember, delusion is an abnormality of content of thought. Let's see the next question. A patient says, I am a lawyer, call my doctor because you are a liar. He is umpire, don't touch that wire, it's hot, hot like today's sun, oh my son is Mohan. Which of the following is seen here? Now please try to appreciate this. Okay, yes, erotomania, it can be, you know, to every person, but usually we see that it is usually to a person who is of a higher stature, but of course it can occur in other scenarios also. But you know, again, it is very difficult when a person says that, you know, my neighbor is in love with me, but you know, as compared to when someone is saying that, you know, celebrity is in love with me. So please remember, usually we see it is seen with person of a higher stature. So person claims someone of a higher stature, maybe social or economic stature, is in love with that person, but it can occur even in other scenarios as well. Okay, yes. So tell me, what is the answer here? Yes. So can you appreciate here, you know, I'm sure all of us have identified this as flight of ideas. Now we'll discuss flight of ideas. We know that the speed of thought is increased, but here they have not mentioned that the speed is increased. Still, you have identified flight of ideas. How? Can you appreciate patient is saying so many things which are not making much sense. Again, one of the close differential of this is loosening of association. We'll discuss. Now one difference is loosening of association would have normal speed, while flight of ideas, when you hear patient is speaking very, very fast. So still we have identified this as flight of ideas. Why? We'll discuss this. I hope this is clear to everyone. I'll tell you also, you know, sometimes two options will be like this, may be very confusing. So remember, in both loosening of association and flight of ideas, patient may be speaking things which are not making much sense. In flight of ideas, speed is increased, loosening of association, speed is normal, but still they have not mentioned speed is increased, but still we are calling it flight of ideas because we are seeing some connection. Can you appreciate there are some rhyming words also, and also you can see that there is some by chance connection as well. So let's come to the next important heading under thought, which is flow or stream of thought. Very, very important. So in flow or stream of thought, what is happening? Normally thoughts flow in our mind, but sometimes there may be a problem of this flow. One problem of the flow is flight of ideas. Again, I always say don't mug up anything in psychiatry, just see the name. You know, Shakespeare ne to kaha what's there in the name, but I always say names are very important in psychiatry. You remember the name and we'll remember the concept. Flight of ideas. What is this term telling you? That the ideas are on a flight. That means the speed of the thoughts is very fast. One thought, second, third, fourth. So patient is talking very fast because the thoughts are coming very rapidly. So you ask a question, patient may speak so many things not making much sense, but ultimately he will not answer your question. So we say that the goal is not reached. But when you listen to the patient, you will see that there are certain connections. One is by chance connection. For example, patient may speak like this. My name is Virat. I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. You know, ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे. Something like this. So can you appreciate one thought is connected by either by chance, and sometimes it may be connected by clang association or rhyming words. So patient may speak like this. You know, Ram is the king. Birds can sing. You know, I am a king, phone goes tring tring, the weather is spring, bring 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 bring. So patient is speaking things which are rhyming, not making much sense. So this is flight of ideas. A very important question. Tell me, this question has been asked in NEET PG. Flight of ideas seen in which condition? Tell me, where would you find flight of ideas? This question has been asked. Remember one important condition, it is mania. Okay, one important condition is mania. Also, let's talk about some other abnormalities under flow. You know, always we discuss, and this question in fact was asked this year only in FMGE January 2025 exam. Circumstantiality. Again, just see the name. What do you mean by circumstantiality? Circumstantial means talking about unnecessary things. So circumstantiality is when the person is giving unnecessary or trivial information. You ask a question to the patient, rather than directly answering the question, patient goes here and there, but ultimately he answers your question. So this is circumstantiality. In circumstantiality, the speed is reduced. The patient may talk slowly, give unnecessary details, but ultimately he answers your question. The goal is reached. So this is circumstantiality. You ask a patient, who is your favorite actress? The patient may start like this, you know, Alia Bhatt acts very well. I've seen all her movies. I was upset for a few days when I heard she's getting married, but now I'm happy for her. May God bless her. Even Katrina Kaif is a good actress. I've seen all her movies. I was upset for a few days when I heard she's getting married, but may God bless her. Even Kareena Kapoor Khan is a good actress. You know, I was upset for a few days when I heard she's getting married, but my favorite actress is Kiara Advani. So can you appreciate patient has given unnecessary trivial information, although he's talking logical, but this information you have not asked, ultimately he's answered your question. So this is circumstantiality. In fact, I'll discuss, you know, a question which was asked this year only in FMG exam. I hope this is clear. Yes. Another important abnormality is perseveration. Now, before coming to perseveration, yes, she also got married, but the patient says she is my favorite actress. Yes, correct. See this question and try to answer this question. A 65-year-old male is brought to the OPD by his wife as she has noted personality change in the last 7 months. While the patient is being interviewed, he answers every question with the same 3 words. So the patient is replying all the questions of the examiner with the same words. Can you tell me what is this behavior? What is this phenomena? I'm sure now you know it is not circumstantiality. It is not flight of ideas, and it is not delusion. So what is the right answer? Very good. I'm very happy all of you are marking it correctly. This is perseveration. Let's now understand what is perseveration. Very important. Again, this is a point, you know, which can come as a new question. So again, putting a hashtag, very important. Now again, what do you mean by, you know, somebody is persevering? You know, there is perseverance in English. Means something is getting repeated. So remember 3 P's. P for perseveration, a thought is persisting in the mind of the patient beyond the point of relevance. So, a patient is answering all the question with the same word. So, you ask a patient, what is your name? He says, my name is Mukesh. It is correct. It is relevant here. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. Now, can you see here? Now, this thought is persisting beyond the point of relevance. So, you may be asked a question like this, or the way I have asked you the question. That one thought is stuck in the mind of the patient, is repeating that same thought again and again. This is perseveration. You know, any Avengers fan? Yes, any Avengers fan here? So, what is your name? I am Groot. What do you do? I am Groot. Where do you live? I am Groot. Something like this. Okay, so this is perseveration. Tell me 2 important conditions where you may find this. 2 important conditions, and I want you to remember. Yes, I want you to remember the sequence also. Remember, one is organic mental disorder, very important. If you are asked one condition, then you can go with organic mental disorder. Another is, remember, even in schizophrenia, it may be seen. Yes, correct. So, I hope this is clear to everyone. Perseveration, again these are important abnormalities under thought. Now, let us come to the other heading of thought. Very good. See this question again. In fact, this is a repeat question, NEET PG 2021. This question was asked. See this. Which of the following is included in formal thought disorder? Can you appreciate from the name? Formal. Formal is derived from the word form. So, they are asking you which of the following is an abnormality of form of thought. So, can you tell me what is the right answer here? Very good. The correct answer is, we will talk about obsession, we will talk about thought insertion, these will discussed under possession of thought. Delusion we have already covered, it is an abnormality of content. Yes, the abnormality of form here is, remember, it is derailment. Very good, I am very happy. See this. Now we are talking about abnormalities of form. Now when we say form, what do you mean by form? Form means structure or shape. Like this pen I am holding, it has a shape, it has a structure. Similarly, all our thoughts, they also have a structure, they have an organization. So you can understand, form basically means organization. That means all our thoughts are organized. Pick up any of your thought coming in your mind, you will see that it has a start, it has a middle part and it has an end. So every thought you will see is logically connected, it will have a start, middle part and end. So this is how a normal thought is organized. When the thought is not organized, then we say it's an abnormality of form, or we can say formal thought disorder means disorganization of thought. Very important. In fact, when I'll cover schizophrenia, one of the symptoms is disorganized speech or thought. So there you may find these abnormalities. Again, don't mug up anything. Just remember the name. Can you appreciate loosening of association? What is this telling you? Name is telling you that the association between the thoughts, it has loosened. So what do you mean by loosening of association? That means that there is a break in the logical connection between the thoughts. Suppose I ask a patient, what will you do if you want to have food outside? Since he is having loosening of association, he may speak like this. Sir, I will eat, I will come back, I will book a cab, I will pay, I will order food. Black umbrella. So can you appreciate, you will say, sir, I can understand the words, but I am not able to understand the sentence. What is the patient trying to say? So this is breakdown in the logical connection. This is loosening of association. Again, this can be seen in schizophrenia. Then some other abnormalities, again see this derailment. What do you mean by derail? A train is moving on track and suddenly it gets derailed. So for some time the patient is on track, then he changes the topic. This is derailment. Also this is known as, can you tell me what is this also known as? Another term for derailment is night move thinking. Can you appreciate what is night move thinking? In chess, how does a horse move? It goes straight and suddenly takes a right or left. This is happening in the thinking also. So this is derailment, jumping off the track. So please remember, for derailment it should be evident कि patient कुछ देर के लिए is on track, then he has changed the topic and there is no link between these topics. Now let's understand what is tangentiality. Again, can you appreciate the name? What is a tangent? We have read in school days in mathematics, what is a tangent? A tangent is a line that touches the circle at one point and goes away. Does a tangent ever return back to the circle? क्या tangent कभी वापस आती है circle पे? नहीं. So this is tangentiality. Patient touches the topic and goes away. He just touches the topic and goes away. Does he answer the question? No. So remember, tangentiality का मतलब है touches the topic, goes away and the goal is not reached. Very important. Goal is not reached. Sometimes they compare tangentiality with circumstantiality. Can you appreciate the difference? In circumstantiality, patient gives unnecessary information and reaches the goal. In tangentiality, he just touches the topic and goes away and does not answer the question. So this is tangentiality. Also, you should know how to differentiate derailment and tangentiality. This question was in fact asked. We'll discuss. Derailment में it should be evident कि for some time, कुछ देर के लिए patient on track, then he changes the topic. While in tangentiality, from the beginning he is off track. He has just touched the topic. You ask him, what will you do if you want a food outside? He may just touch the topic. There is a new restaurant near my home and next to it is a cinema hall. I am planning to watch a new movie there. In fact, I am buying ticket right now. So can you appreciate, he just touched the topic and he went away. So this is tangentiality. Also tell me what is neologism. Yes. So I hope derailment is clear to everyone. So derailment, let us say patient says, sir, I will book a cab, I will reach the cafe. So he is on track for some time and then suddenly he has changed the track. Sir, IPL matches are going on and I hope this time my favorite IPL team wins. So this is derailment. For some time he's on track, then he changes the track. While in tangentiality, from the beginning he just touched the topic and he has went away. I hope this is clear. Yes. Neologism, new means there is, neo means new, logism means word. So patient, suddenly uses a new word whose derivation you are not able to understand. Suppose a patient knows only English language and he says he's talking about the weather conditions are now in Delhi, the weather is becoming really hot day by day. I have taken out my summer clothes and he's talking about weather. Suddenly he says, sir, I have brought a new Pratt knit kit with go, and you are confused. You googled this word, आपको कहीं नहीं मिला. आपने Oxford dictionary देखा, this word is not there. Person knows only English language, so this word is not existing in that language. Then he points out to his pen, sir, I've got a new Pratt knit kit with go. So can you understand how he has given this pen this term? So suddenly there is a new word in his mind. So this is neologism. So I hope this is clear to everyone. Yes, very good. So these are some examples of formal thought disorders. They can be seen in conditions like schizophrenia. See this question now. Now let's try to apply these questions, and these questions have been asked. A psychiatrist asks a patient, how is your mood? Patient replies, sir, it is up and down. See, you have to tell me which symptom or which phenomena you can see here. Always try to rule out the options. Is it neologism? No, sir. It is not neologism. There is no new word in the question. Is it clang association? No, there is no rhyming here. Now tell me whether it is C or D. Now I have answered this question whether it is C or D. So I have made it very simple for you. You have to tell me out of C or D what is the right answer. Now please remember, you have asked a patient how is your mood. He has touched the topic. Now for derailment, it should be evident that he is on track for some time and then he has changed the topic. From the question, it is not evident that he is on track or he has changed the topic. So that is not the answer. Again, it may be an incomplete question, but when you see such questions are being asked, so you can say, yes sir, he has touched the topic. It is up and down is not meaning that he is happy or sad. He has just touched that topic. So the correct answer here is, it is tangentiality. I hope this is clear to everyone. It is not a complete, the question might not be complete. Still, if you are asked such question, you have to answer it like this. I hope it is clear, because I am sure it is not derailment, because we don't know whether he has changed the track or not. Okay. Now see another question. This question was asked this year only. Such newer questions are being framed in the exam. Please try to see such questions. Always try to see what they are asking. A doctor asks a patient about her age. So patient ka age पूछा. The patient responds, doctor, I am from a village. We were married at a very young age, at 12, with my husband who is just 5 years older than me. Then I had 2 kids when I was around 18 or something. Now I am 38 but look like their older sister, doctor. What is the phenomena here? Very good. What is the phenomena here? Can you appreciate when you ask the patient her age, she is talking logical. Things are making sense. She is giving unnecessary information. Has he answered your question? Yes or no? Tell me. Has the question been answered? Yes, it has been answered. She is telling you the age. So it is not tangentiality, it is circumstantiality. I hope this is clear to everyone. These are the type of question I am saying that they may ask. Such newer questions have been framed. I hope this is clear to everyone. Right. So we have covered thought abnormalities of flow, content, form. Let's now discuss some abnormalities of possession. Now what do you mean by possession? Now if I ask you, the thought coming in your mind, ये आपका thought है or is it your पड़ोसी or neighbor's thought? You will say, of course sir, this is my thought, this is thought coming in my mind. But sometimes patient may say that I cannot control my thought or this thought is under someone else's influence. So then we say it is abnormality of possession. Now very important, again it is a slightly debatable point, obsession. Where do you keep obsession? Now please remember, if you are asked, between possession and content, better answer will be it's an abnormality of possession. It is rhyming also, so remember it like this. So possession is an abnormality of, obsession is an abnormality of possession of thought. Now we will discuss in great detail what is an obsession. It's a repetitive thought, image or impulse. What do you mean by an impulse? Impulse means urges. Patient says मेरे mind में repeatedly एक thought या image या impulse आ रहा है. We'll discuss this when we'll talk about OCD. So we'll talk about obsession in great detail. I'll give you a mnemonic also. Now please remember, in certain psychiatry books, they have placed obsession under content, but there they have not used this classification of 4. Okay, so remember, if you are asked out of content or possession, then better answer will be it is a abnormality of possession. I hope this is clear to everyone. Right. Okay. I hope this is clear, right? And another is thought alienation. Again, just see this term, alien. This is also known as passivity, passivity of thought. Remember this point. Whenever you read this term passivity in psychiatry, beta passivity का क्या मतलब है? That is, it is under someone else's influence. It is under someone else's influence. So when we say thought alienation, so my thoughts are not my thought, it is under someone else's influence or passivity of thought. So there are three phenomena: thought insertion, withdrawal and broadcast. Look at the names. The name will tell you everything. What is thought insertion? Patient says somebody is inserting thoughts in my mind. Thought withdrawal, patient says somebody is taking away my thoughts. And what is thought broadcast? Patient says my thoughts are getting broadcasted outside. You know, sometimes they may say, a patient says that when I enter a room, everybody in the room is able to know my thoughts. So can you tell me what is this abnormality? Anybody? Can you tell me what is this abnormality when the patient says, sir, everybody in the room is able to know my thoughts? What is this? Can anybody tell me what is this phenomena? Yes. So patient is saying that my thoughts are getting broadcasted outside. So this is example of thought broadcast. Again, remember, thought alienation phenomena may be seen in condition like schizophrenia. I hope this classification is very, very important. We have discussed some important points, some important abnormalities of each of these domains of thought. Let us see some questions now. Now see this question. This in fact was a new question which was asked last year. Now, you know, sometimes you will get such questions, but please try to rule out the option, you will get to the right answer. So please don't worry if you get some new option in the question. Always try to rule out. I always say in psychiatry, try to rule out options, try to see the name and you will answer the question correctly. A patient believes his feelings and thoughts are controlled or influenced by an external agency. Now in the option they have given you all the 4 delusions. You have to answer the question. You know, you are sure, sir, it is not delusion of nihilism? It is not delusion of reference? You will say, sir, it is not Othello syndrome. Very good. So the right answer here is, it is delusion of influence. It is a type of delusion of persecution. So here the person thinks that his feelings, his thoughts are controlled or influenced by an external agency. I hope this is clear to everyone. Very good. Very correct. Now see this question. You know, sometimes such match the following questions may come. So always be ready with such newer questions. See this. Tell me, delusion is an abnormality of, now I am sure the answer will be very clear, it is an abnormality of content of thought. Obsession is an abnormality, we have discussed possession. Flight of ideas is an abnormality of flow or stream. So the last is loosening of association, it is an abnormality of form. Very good. So 1B, 2A, 3D and 4C. The answer is, correct answer is option B. I hope this is clear to everyone. Yes. So the concept of abnormality of thought I hope is clear to everyone. Very good. Now see this question. So we have covered a very important heading under thought, under MSc, that is thought. Let's move on to the next abnormality. A 30-year-old male reports of hearing voices of his neighbors planning to kill him, which is coming outside of his room. So he is hearing voices of the neighbor. He sees no one around but only hear the voices, which no one else can hear. Which of the following is false? Again, please read the question carefully. You know, sometimes we make silly mistakes. We don't read the question carefully. They are asking you the false statement. Can you identify what is this phenomena first? Can you appreciate it's an abnormality of perception? Perception means, you know, something related with hearing something or seeing something, or, you know, there is a taste sensation, or there is some smell, or there is some sensation of touch. He is hearing something. So it's a false perception without any real object. Yes, all of you are correct. We are talking about hallucination. Again, remember, hallucination, it's an abnormality of perception and it is also a psychotic symptom. So we know, yes, A is correct. It's a false perception without any real object. It is independent of patient will. Patient says, I don't have any control over it. It comes and goes on its own. It is very clear, as vivid as real. Patient ko आवाज इतनी clear सुनाई दे रही है, like you can hear my voice. Is it occurring in the inner subjective space? No. Can you tell me what is something very similar to hallucination? देखो hallucination उसको बाहर, he is experiencing it in the external outer space. Patient experiencing some phenomena similar to hallucination, but patient says, sir, voice is coming from my mind within. This is pseudo hallucination. Very good. I am very happy you are answering it correctly. Yes. In fact, this was a PYQ. ये एक PYQ अभी आया था in one of the FMGE exams. So please be very careful when they ask such questions. Okay, I hope this is clear. So hallucination, you know, if you've seen this movie, In this movie, Munna Bhai can hear and see Mahatma Gandhi. We know Mahatma Gandhi is no more with us, but उसको सुनाई दे रहे हैं, दिखाई दे रहे हैं. This is how patient experiences hallucination. You know, people are trying to convince him. His friend circuit says there is no one, but he is not getting convinced because he can see it, hear him very clearly. So this is how patient may experience hallucination. Remember, hallucinations, they are experienced in the outer objective space, जबकि pseudo hallucination का experience होते हैं in the inner subjective space. This is the very important difference. So ask the patient where he is experiencing it, so you can differentiate. I hope this is clear to everyone. Okay, I hope this is clear to everyone. Yes. Now also remember, you know, let me just touch upon one more point, imagery. You know, since the way they are asking questions, sometimes they may ask such questions also. देखो imagery. What is imagery? Imagery is a normal phenomena. Suppose if I ask you, you know, let us say all of us have been to some hilly area. If I ask you to create an image of a hilly area in your mind, you will be able to create that image in your mind. Now I will say, you know, you have spent a lot of time there, वापस आ जाओ class में, you will come back to the session. So can you appreciate this is imagery? This is also, you know, this is also in the inner subjective space. But imagery, can you appreciate, it's under our control. So imagery you can control. Imagery is also not very clear, not very clear. Remember this. Okay, so sometimes they may ask you difference between pseudo hallucination and imagery. Both are occurring in the inner space, but imagery is in your control. It is not very clear. That image which you created, it was very blurry. So remember, sometimes they may ask you such newer questions. So remember this. I hope this is clear. But what is illusion? Okay, we'll also discuss illusion. Illusion is also a false perception. It is also a problem of perception, but it is a false perception of a real object. Here there is a real object. For example, a person is sleeping, in the middle of the night वो उठ जाता है और he says he can see a snake under the bed. उसको अपने bed के नीचे एक snake दिखाई दे रहा है, उसको दिखाई दे रहा है, it's a snake. He becomes frightened, he shouts, family member आते हैं, they switch on the light, then he see, oh, actually it was a rope. So can you appreciate this snake is a false perception but of a real object. ये real object यहाँ पे क्या है? Rope. So that is illusion. It is also an abnormality of perception. I hope this is clear to everyone. Yes, very good. Now see this, there are various types of hallucinations. Again, sometimes they will ask question like this. So depending on the which sensory modality is involved, so remember it can be auditory. Patient is hearing something like in the question. Remember, this is the most common overall hallucination. You will see. Visual, patient is seeing something. Now very important question, I want you to highlight this point. Now of course, we are talking about hallucination, these are psychotic symptoms. They can be seen in condition like schizophrenia. Now can anybody tell me, when I say visual hallucination, one very important diagnosis which would come to your mind? Tell me. Yes, very good. Even in alcohol, yes, very good. Remember, you know, when we talk about visual hallucinations, you know, many times we see that in organic mental disorder, if they ask you, most common hallucination is visual hallucination. Of course, they can be seen in condition like schizophrenia also. But remember this, you know, if they, in the question they mentioned visual hallucination, try to see, are they talking about any organic disorder? Many times this is a hint to you. Of course, it can be seen in schizophrenia, other conditions also. But remember this point, we'll discuss one question also. Tactile, patient says, sir, I can feel some sensation, you know, there is a insect crawling over or under my skin. So this is also known as formication, sometimes also known as cocaine bugs or magnum bugs. This question was asked. A patient comes to you with tachycardia, tachypnea and scratch marks. Which substance he is consuming? Can you tell me the substance he is consuming? You will say, sir, scratch mark is telling us maybe the patient is having these tactile hallucinations. Why tachycardia, tachypnea are seen with cocaine? We'll discuss when I'll come to the substance, because it's a stimulant. So remember this point. This question, again, I'll highlight this. So many times in INI-CET, especially recently, they have asked this question. So please be very careful. Sometimes these topics get repeated. Now, olfactory means he says that there is some smell coming, nobody can, you know, smell that, but he's experiencing some smell. Gustatory means he says there is nothing on my tongue, but he's experiencing some taste. Now, another interesting question, a patient had a head injury, after which he developed olfactory gustatory hallucination. Can you tell me which area? Very good, yes. In temporal lobe abnormality, sometimes, you know, in temporal lobe disorders or abnormality, you may find this. So sometimes they may give you a clinical question like this. They may give you a CT and MRI also. Patient had an injury and he developed these hallucinations. So there may be abnormality in the temporal lobe. Also can be seen in temporal lobe epilepsy, in temporal lobe tumor and other condition. Very good. Very good. Now see this question, a very interesting question related to hallucination. It is a special hallucination. In fact, this question was asked recently in a question from this topic has been asked even in AIMS previously. See this. A patient consuming a substance reports of seeing red color when he hears the radio. Can you tell me which substance it is associated with? Yes, it is associated with hallucinogens like LSD. What is this phenomena we are talking about? Now, normally we said that hallucination does not require any real object, but it's a special hallucination. What is the name? Very good, yes. It is known as reflex hallucination, also known as morbid synesthesia. But please highlight this name also. This was once asked in AIMS. It's a PYQ. Another name of reflex hallucination is morbid synesthesia. So here a normal stimulus in one sensory modality provokes a hallucination in a different modality. Like in this case, patient says, sir, जब भी मैं radio switch on करता हूँ, he is hearing it. So can I say it's a auditory modality and it is a real normal stimulus. You can also hear the radio. So when he says I switch on the radio, I see color in the air. So can you tell me which hallucinations are getting produced? It is visual. So auditory stimulus is producing a hallucination in a different modality. It is reflex hallucination. अगर modality same हो जाता, let us say a auditory stimulus is producing auditory hallucination, then can anybody tell me what is this known as? इसको क्या कहते हैं? This is also a special hallucination. Can anybody tell me what is this known as? What is this known as? Very good. Yes, this is known as functional hallucination. Very good. Functional hallucination. But in reflex hallucination, can you appreciate as a reflex a hallucination is getting produced? So this is reflex hallucination, can be seen with hallucinogens like LSD, lysergic acid diethylamide. Very important. Okay. So I hope this is clear to everyone. So the right answer of this question is it is LSD. Very good. Now let's see this question. Now we are talking about some other domains of MSc. Let's talk about the cognitive functions. Let's see this. You have to mark the cognitive functions and the test we do to assess these cognitive functions. So orientation, attention, concentration and recent memory. Can you tell me what is the right answer here? Very good. Orientation means awareness of self and surrounding, which we assess by asking the patient time. What is the time right now? What is the place you are in? Who are the people around you? Very good. So all these questions can come in the exam. A psychiatrist is asking a person time, place, person. Kya assess ho raha hai? It is orientation. Attention means ability. Attention, what is attention? It is ability to focus on a particular stimulus. Teacher comes in the class and say, pay attention. So we check whether the patient's attention is intact. We use method known as digit repetition test. Please remember, it has two types, digit forward test and digit backward test. In forward test, we ask the patient to repeat the numbers in forward direction. Like 2, 7, he has to say 2, 7. Then we increase the number. Backward test, he has to repeat in the backward direction. If both options are given, remember, it is forward test is a better answer for checking attention. This question was asked in a FMGE exam. Concentration. Concentration का मतलब है sustained attention. So sometimes you say, sir, after reading for half an hour, हमारी concentration चली जाती है. So concentration मतलब sustained attention. इसको हम check कैसे करते हैं? By using 100-7 test. Serial 7 subtraction test. We say the patient subtract 7 out of 100, जो भी आंसर आता है उसमें से 7 को keep on subtracting till you can. So this is how we check concentration. And recent memory. Recent memory मतलब memory of the past few minutes, hours or days. इसको हम कैसे check करते हैं? By asking something which has happened in the past 24 hours. 24-hour recall method. जैसे we ask the patient, what did you had in your last meal? Suppose if I ask you, what did you had in your breakfast today? Some of you may say, sir, I had a parantha, I had a idli. So what I am doing, I am checking your recent memory. I hope this is clear to everyone. So they may ask a newer question. A psychiatrist is asking a patient who came to meet you in the morning today. So he is asking something which has occurred in the 24 hours. So he is checking recent memory. So correct answer यहाँ पे है option D. I hope this is clear to everyone. Very good. अच्छा, you had milkshake. Very good. Okay. I hope this is clear. हाँ. चलो let's complete this. When we are talking about cognitive functions, we have discussed orientation, attention, concentration. Let's complete memory. Again, memory based on the duration. We can divide into immediate, recent and remote. Immediate का मतलब है memory of the past few seconds. So this again we don't use any other method. Test of attention and concentration are also checking my immediate memory. Again, if you are asked one test, then again you can go with digit forward test. If they ask one test, then you can go with digit forward test. Recent means past few minutes, hours or days. Again we have discussed the test which we use is the 24-hour recall method. देखो what do you mean by remote? Remote का मतलब है ना something which is far. So memory of past few months or years. So we check this by asking some personal information. I am asking a 70-year-old male. I am asking a 70-year-old male. Name of his school friends. Can you appreciate? I am asking so much, old information. So I am checking his remote memory. Don't ask this male his date of anniversary. He may not be able to tell. Ask other questions. Okay, just joking. So remember, this is how we check remote memory. I hope this is clear to everyone. Right. I hope this is clear now. So this is how we check some of the important cognitive functions. In fact, I'll talk about this. Dekho, Peter, can you appreciate? With checking cognitive functions, in fact, we'll talk about organic mental disorders, which are now also known as neurocognitive disorders. In fact, we'll discuss in disorders like dementia, these cognitive functions are affected. I hope this is clear to everyone. Right. Now see this question. A psychiatry resident asks a patient similarity between a car and a plane. So a similarity is being asked between a car and a plane. The patient replies that both have tires and both have windows. Which of the following function, in fact, answer this, which of the following function is being assessed here? Can you tell me what are we checking? So we are using similarity testing. So we are asking similarity between two objects. Yes, we are checking abstract thinking. Abstract thinking is what? It is the ability to understand hidden meanings or to form concept. Yes. So remember two important tests for abstract thinking. One is proverb testing. You may ask proverbs. So for example, if I ask you the meaning of this proverb, pen is mightier than sword. Pen is mightier than sword. कलम की ताकत तलवार की ताकत से ज़्यादा होती है. Can you appreciate, proverb मुहावरे? They have a hidden meaning. So if I ask you, the meaning, you will say, sir, this means that intelligence is more powerful than, muscle. So that is, you are able to understand the hidden meaning. And similarity testing, like in this question, we are asking similarity. Usually what will you say if I ask you similarity between a car and a plane? Can anybody tell me what similarity will you tell me? So what similarity will you tell me between a car and a plane? You will say, sir, both of them are mode of transport, isn't it? So can you appreciate you are able to see the functional similarity, the larger similarity? That means your abstract thinking is intact. But here in the question, patient says he is only able to see superficial similarities. He says that both have tire, both have windows. So he's seeing things which are quite obvious. He's not able to go in the deeper meaning. So can I say abstract thinking is impaired in this situation? Can anybody tell me what is the term we use when we say that there is loss of abstract thinking? Can anybody tell me what is the term we use when we say both, when we say that abstract thinking is impaired? क्या term हम use करते हैं? It is known as which thinking? Very good. It is known as concrete thinking. Very good. So can I say here, I am seeing concrete thinking. Very good. Now also let's see some other options. Judgment में test judgment. How do we assess test judgment? We take a test. Just remember it like this. So we give a hypothetical situation and we ask a patient, what he will do. For example, we ask this fire problem. If I ask you, what will you do if your neighbor's house catches fire? You might say, sir, I will try to help the neighbor. I'll call the fire brigade. Okay, so that is telling me your test judgment is intact. Suppose a patient says, sir, what I'll do? I'll pour kerosene in the fire. So tell me here, test judgment is intact or impaired? Tell me, test judgment is intact or impaired? So we say the test judgment is impaired. Again, it may be impaired in conditions like psychosis. We'll discuss some important points. Yes, it may be impaired. Now, what do you mean by insight? Insight का मतलब होता है awareness of the illness. Whether patient is aware of the illness. You might not check insight in medicine or surgery, but we check insight whether the patient is aware of their illness in psychiatry. Because sometimes patient says, sir, I don't have any illness. I think my family members have got some problem, you check them. But actual problem is with the patient. So sometimes patient does not have insight, he is not aware of the illness. Again, we'll talk about, in neurosis, we'll discuss insight usually is present. In psychosis, insight is absent. I hope this is clear. Yes. There are 5 grades also. Yes, very good. And lastly, remote memory we have already discussed. So here the answer is, it is abstract thinking which is getting tested. So we have discussed some important headings. We have talked about some important headings of the MSc. I hope this is clear to everyone. Yes, a very important topic. Again, I am saying, those who are preparing especially for FMGE, NEET PG, you may get simple direct questions from this topic. Many questions have been asked also. Sometimes even in INI-CET, they may ask maybe indirect questions from this topic. Now let's talk about the disorders. Now this classification is an old classification, but I always discuss this classification because once we understand this classification, things become really simple. We are able to compartmentalize some of these important disorders in psychiatry. So in older times, psychiatric disorders were divided into organic and functional. Now, what do you mean by organic? Organic means that it has a visible cause. The cause is visible. For example, somebody had a head injury after which he developed some symptoms. So, can you appreciate, you can see the cause. You can see the head injury. Do a CT MRI, you will see the cause. So, disorders like delirium, dementia will discuss under organic. Functional, usually we say where the cause is not visible. Like a patient with depression, schizophrenia may come to us. If we do all the basic investigation, we may not be able to find any cause. Of course, nowadays we don't say anything is functional because we know everything has a cause. It may be cause at a genetic level, cause may be at a neurotransmitter level, but still it's an old classification. So, functional disorders are further divided into neurosis and psychosis. Let's understand some important difference between neurosis and psychosis. Once you understand this classification, I'll tell you how it is important. You can solve many questions. Now, insight we have already covered. It is present in neurosis and it is absent usually in psychosis. Judgment, we discussed judgment may be intact in neurosis, usually it may be impaired in psychosis. Delusions, hallucination, I have been talking again and again. These are psychotic symptoms, so they are usually absent in neurosis, present in psychosis. Now coming to reality testing, touch with reality, whether the person is able to differentiate what is real, what is unreal. Tell me where it is present, where it is absent. Reality testing is usually intact, again it is intact in neurosis, while it may be impaired in psychosis. So, these are some important differences. Now, very important is to remember the examples. Can you give me some examples of neurotic conditions? Just tell me quickly some important example. In fact, we will discuss all these disorders. Give me some examples of neurotic disorders such as anxiety disorders, very good. Anxiety disorders, OCD, very good. Even we will talk about somatoform and related disorders, very good. Even depression to an extent you can say, it has many characteristics of neurosis. Coming to psychotic illnesses, very important, one example we have been discussing again and again, schizophrenia is a psychotic disorder. So many other psychotic disorders are there like acute psychosis. Even mania or bipolar disorder you can say to an extent may have psychotic disorder characteristics. In fact, we have talked about sometimes patient with depression may at times develop psychotic illness. So, that is known as psychotic depression. So, can you appreciate this classification is not very crystal clear. Sometimes some problem from one condition can go to the second side. So, please remember it's an old way of classifying, but very important. What we'll do is first we'll cover all the important organic disorders. We'll talk about psychotic disorders, we'll discuss mood disorder and then we'll cover important neurotic disorders. Sometimes in the exam, अगर आप differentiate कर पा रहे हो कि ये neurosis का question है या psychosis का question है, many time you'll see, you'll solve the question. In fact, I'll discuss some questions also. Just by knowing this classification, you'll be able to solve. In fact, there was a question which was asked in NEET PG. Previously, it was a question related with dissociative disorder, which is a neurotic condition. And there were 4 options and some options were new, but one option was you have to choose a false statement. एक option था कि in dissociative depersonalization disorder, which is a dissociative disorder, reality testing is impaired. Now you will say, sir, it is a neurotic disorder, we know, and in neurotic disorder we discussed that reality testing is intact. So ये false statement था. So just by knowing this classification, you will be able to solve questions. Okay, I hope this is clear. Yes, I am trying to discuss many of the points. Okay, so don't worry, we'll share the PDF also. So I'm trying to share, of course, you can also, along with this, you can also use RRR and also do PYQs. When you are revising, again, you can also, go with the RR videos and also the PYQs along with this session, and you will see, a lot of the question you'll be able to solve. Okay, now let's come to the first and a very important topic. Recently, many questions have been asked from organic mental disorder, which we discussed that both in DSM-5. So, there are 2 classifications, one is DSM-5 and another is ICD-11. So, these are the 2 recent classifications, which help us make diagnosis of psychiatric illnesses. So, both have named organic mental disorder as neurocognitive disorder. Can you appreciate from the name? हमने ऑर्गेनिक डिसऑर्डर्स के बारे में डिस्कस किया दैट दे हैव अ कॉज. कैन यू सी द नेम इज टेलिंग यू देयर इज अ न्यूरोलॉजिकल कॉज which is causing cognitive impairment. So neurocognitive disorder. So three disorders are there. One is delirium, dementia and amnestic disorder. But a very important delirium, you have seen many questions on delirium. देखो delirium में it's a neurocognitive disorder, so cognition is impaired. We'll discuss what is cognition. Also very important is that there is also impairment of consciousness. So consciousness of the patient is impaired. Consciousness means awareness of self surrounding, that is impaired. Now I'll discuss, I'll tell you 4 points. Many times any of these point अगर question में mentioned है, this is giving you a hint कि patient का जो consciousness है that is impaired. So see this, very very important, see this. So when we say that the consciousness is impaired, see this. So they may use this term that there is clouding of consciousness, मतलब कि in the clear sky of consciousness now there are clouds. Or they may use this term that there is altered sensorium. We have already discussed, orientation means to time, place, person. So if a person is disoriented to time, place, person, then again this is telling you patient may have delirium. Remember, disorientation, D for delirium. Or nowadays they may use this term, there is confusion. Remember this. So any of these terms is given, this is giving you a hint that patient ko kya hai? Patient is having impairment of consciousness. I hope this is clear to everyone. Very very important, right? Also cognition is impaired. Cognition means functions like memory is affected, memory is there, language is impaired, even perceptual problems are there. Can anybody tell me which perceptual abnormality will be more seen here? कौन सी perceptual abnormality मिलेगी यहाँ पे more commonly? We have discussed this point. Can anybody tell me? Yes. Tell me which perceptual abnormality you will be able to see. Yes, we'll discuss. हाँ, कौन सी hallucination will be more? Very good, visual hallucination. Very good. Very good. Now when we do EEG, okay, somebody is asking EEG. When we do EEG, देखो, delirium may have any cause. It may be because of, let us say, head injury. It may be because of hyponatremia. It may be because of infection. So delirium में management में you should remember, we should identify the cause and then you have to treat the cause. Delirium is an emergency but it is reversible. When we do a EEG, remember there is slowing of the background activity, cortical activity on EEG. Any cause of delirium, you will see there is slowing of the cortical background activity, but there is an exception. Remember, except alcohol withdrawal. Alcohol withdrawal can also cause delirium. We'll discuss. There the activity on EEG is fast. So please remember, on alcohol withdrawal delirium, also benzodiazepine withdrawal delirium, sedative withdrawals, there you may find fast activity. Otherwise in all the other causes you will see EEG, electroencephalogram if we do, there will be slowing of the activity. I hope this is clear to everyone. Yes. Now there is a important differential diagnosis. देखो delirium का question they may just give you this. Let us say there is a patient who had a head injury or he underwent some surgery. 2 days later the patient in the ward is confused. He is not oriented. So what is the diagnosis? You are thinking of delirium. Now please see a differential diagnosis. There is one differential diagnosis which I want you to remember. Let us say there is an acute onset of symptom. Delirium में there is acute onset of symptom. Patient has fever. Patient has delusions, hallucination. So again, this is a close differential diagnosis of delirium. Delirium में भी acute onset होता है, fever में भी given, delusions, hallucination, delirium में भी हो सकता है. Can you tell me which is a close differential diagnosis of delirium? ये कौन सा diagnosis हो सकता है? देखो delirium को diagnose करने के लिए you have to see whether there is impairment of consciousness or not. Here they have not mentioned consciousness is impaired. So यहाँ पे diagnosis क्या है? Very good. It is acute psychosis. Please remember this. Acute psychosis is a close differential diagnosis of delirium. In fact, this has been asked so many times in PYQs. अगर question में they have mentioned impairment of consciousness, then you will go with delirium. Otherwise, you can choose acute psychosis. Acute psychosis में भी fever can be present at the onset. I hope this is clear to everyone. Also, let's talk about the treatment. This question has been asked recently. देखो delirium का management में remember we have to treat the cause. Whatever is the cause, you treat it. Delirium is reversed. But many times, as a psychiatrist, we may have to manage the symptoms. So can anybody tell me what drugs we may use for management of delirium? देखो delirium में patient may be very agitated. Patient may have delusions, hallucinations. So we can use antipsychotics. Very good. This question was asked. In fact, most common antipsychotic which is used is haloperidol. This question was asked in one of the exams, FMG exams. Also we can use other drugs like olanzapine, even other drugs can be used. But remember, if one drug they ask, most commonly the drug which is used is haloperidol. Also remember, for managing alcohol withdrawal delirium, what is alcohol withdrawal delirium known as? Can anybody tell me alcohol withdrawal delirium को क्या कहते हैं? That is known as delirium tremens. What is the drug of choice? देखो यहाँ पे important है. This question was asked in the same exam. Once they had asked treatment of delirium and one they had asked treatment of delirium tremens. Alcohol withdrawal की treatment क्या होती है? Very good. It is benzodiazepines. Can you appreciate both the questions? Very important. Okay, we'll discuss. Okay, I hope this is clear. Delirium tremens is a very important topic. I'll discuss when we'll come to the substance. I hope this is clear. हाँ देखो, don't get confused with thiamine. I'll discuss. देखो, this is a very important point for managing alcohol withdrawal. The drug of choice is benzodiazepine. I'll discuss where we use thiamine as a drug of choice. We'll talk about this later. Clear? Right. Now let's talk about the second neurocognitive disorder. This is dementia. देखो, dementia, remember here the consciousness is intact. What is impaired? It is the cognition. So there is cognitive impairment. It's a neurocognitive disorder ना, तो यहाँ पे cognitive impairment है. So patient may have amnesia. What is amnesia? Can anybody tell me? What is amnesia? In amnesia, there is loss of memory. So memory is getting affected. Very good. Memory is getting affected. Family members may say, what is aphasia? Patient's family member may say that there is problem in the language usage. Then patient may have apraxia. Praxia means motor movement, apraxia. Family members may complain he is not able to comb his hair, he is not able to unbutton the clothes, not able to tie the shoelaces. So can you appreciate fine learned movements are getting affected. So there is problem in the fine learned movements, that is apraxia. Family, you show this object, we do this when we are examining the CNS. We show some object, patient is not able to identify the object. What is this known as? Agnosia. He is not able to identify object. Also remember, sometimes patient may have problems in identifying the faces. What is this known as? This was again asked in a PYQ in FMG exam. What is this known as? It is prosopagnosia. Sometimes when you don't know, always try to see the name. They had asked, the patient is not able to identify faces. Agnosia is coming in the end. This is prosopagnosia. Such questions may be asked. So please be very careful. So in dementia, usually dementia has a insidious onset. Usually it has an insidious onset, while delirium has an acute sudden onset. We have discussed delirium, it's an emergency, but it is reversible. Usually we'll talk about dementia, they are irreversible. There are some reversible causes also, but usually they are progressive condition. Many of the causes are progressive. There are some irreversible also, we'll discuss. So remember, but one important point if I ask you to differentiate between dementia and delirium is that consciousness is impaired in delirium while the consciousness is intact in dementia. I hope this is clear to everyone. Very good. I hope this is clear. Also in amnestic disorder, can you appreciate delirium में हमने discuss किया both consciousness and cognition is impaired. In dementia we discussed only cognition is impaired. Amnestic disorder में out of the cognition it is the memory which is only getting affected. That too patients, recent and remote memory is getting affected. So then we call it as amnestic disorder. There are so many causes of amnestic disorder. One important cause I want you to remember, we'll discuss this Korsakoff syndrome. Korsakoff syndrome. So in fact I'll discuss this when we'll talk about alcohol. तो अगर मैं आपसे पूछूंगा Korsakoff syndrome में what is one important symptom, you'll say, sir, there is amnesia. It's a amnestic disorder. Actual cause is not alcohol. We'll discuss actual cause is vitamin B1 deficiency. I hope this is clear to everyone. Yes, anterograde भी होता है, retrograde भी होता है. It is anterograde more than retrograde amnesia. I hope this is clear to everyone. Yes, even confabulation also we'll discuss. So this is again a very important slide. Now let's talk about some points about dementia. Let's see this table again. This table was asked, question from this table was asked in FMG, and then you'll appreciate once this was asked in FMG, and the next year INI-CET question was again asked from this table in INI-CET. So sometime you'll see the topics get repeated. So see this. We said that dementia में क्या हो रहा है? Dementia is usually progressive, but there are some reversible causes. 10 to 15% are reversible, so that is a good thing. If my patient is having a reversible cause, I treat it, dementia will be reversed. Otherwise, we know it is a progressive condition. I hope this is clear. So see, there are some Neurological causes such as SDH. What is SDH? What is SDH? So they may just give you a clinical condition that patient had a head injury. They may give you a CT scan. What is SDH? Subdural hemorrhage, subdural hematoma. That can also lead to reversible dementia. You treat it, dementia will be reversed. Patient has some brain tumor, brain abscess. Again, you treat it, dementia may be reversed. NPH. What is NPH? What is NPH? This was asked in the INI-CET. What is NPH? It is normal pressure hydrocephalus. Remember, normal pressure hydrocephalus. So NPH. So even NPH can also cause, remember, it's a reversible cause. So normal pressure hydrocephalus. What is the triad? Sometimes there is a triad which you see in the NPH, Adams triad, or sometimes known as Hakim's triad. What is this triad? So can you appreciate? There is cognitive impairment, there is a magnetic gait abnormality, and urinary incontinence. So remember, so you may be asked, such scenario, and you may be asked, whether it is reversible or irreversible. Remember, these are some reversible causes. Then we'll talk about infections like encephalitis, meningitis. You treat it, the dementia will be reversed. Now this is very important. Please highlight this in your notes. Metabolic causes. Can you tell me? Very good. Can you tell me deficiency of one important vitamin which may cause reversible dementia? In fact, this was asked in the exam both in FMGE and INI-CET. Remember, one important vitamin is vitamin B12. Also other deficiencies such as niacin, folate, vitamin B1, they can also cause reversible dementia. In the endocrinal, if I ask you, can you tell me in the endocrinal, one important endocrinal abnormality associated with reversible dementia? Remember, hypothyroidism, very important, hypo. Even hyperthyroidism, even hyperparathyroidism can cause. If you are asked, all these and one option is all, then go with all. But if you are asked one, then you can go with hypothyroidism. Even see this, alcohol use. Chronic alcohol use से भी reversible dementia हो सकता है. You have to tell the patient stop alcohol. Even जो brain changes हैं, they may be reversed within a year of stopping alcohol. So this is a very important table. Again, I am highlighting this. You may be asked a clinical question. देखो, this question, these options were mentioned in the exam. NPH was given, B12 was given, and hypothyroidism was given in the INI-CET. In FMG, they had asked vitamin B12. You may be asked, a patient comes to you with dementia. Would you like to check the vitamin B12 levels? Would you like to check the thyroid function test? You will say yes. Because what if my patient is having a reversible cause? So sometimes a clinical question may be asked like this. I hope this is clear. You will be able to solve question from this table. Let's see this question. Deficiency of which of the following is the reason for cognitive impairment in old age? But always try to see what the examiner is asking. देखो, जब भी ऐसा क्वेश्चन आता है ना, they may not ask you directly, they may ask you indirectly. Can you appreciate cognitive impairment in elderly? They're trying to ask you, a cause of dementia. Which important deficiency? Yes, remember this, vitamin B12. So always see in the question, they may not ask you a direct question, they may just twist the language. Many times, this is more of an English language paper sometimes, you will see. But try to, understand the question and you will be able to solve the question. Now there is one more classification of dementia, which we use, that is cortical and subcortical. Depending on which area is getting affected first. So cortical dementia mein it is the cortex which is getting affected first. Subcortical mein it is the subcortical grey matter. Now very importantly, they may ask you examples. Can you give me some examples of cortical dementia? Can you give me some examples of cortical dementia? Now very important, one of the most common, in fact most common cause of dementia, Alzheimer disease, is a cortical dementia. Even pig disease. This question was asked in INI-CET. Pig disease, is it cortical or subcortical? If you know another name of pig disease na, you will never make a mistake. So that is why I always say psychiatry में नाम याद रखने हैं. Pig disease को हम क्या कहते हैं? It is also known as, very good, frontotemporal dementia. Name is telling you that frontal and temporal lobes are getting affected first. So it is again a cortical dementia. Tell me some examples. Tell me some examples of subcortical dementia. Remember, Parkinson disease, which you read in medicine, it can also, have dementia. Huntington disease, multiple sclerosis, Wilson disease, PSP, progressive supranuclear palsy. Again, so many other conditions, they may also develop dementia, and these are subcortical dementia. So even in Parkinson disease, sometimes patient may develop cognitive impairment. So we say it is Parkinson disease dementia. Now, can you appreciate all these disorders, like in Parkinson disease, what symptoms you read in medicine? Patient has tremors, patient has rigidity, patient has bradykinesia. Huntington disease, patient has coriform movements. Wilson's, patient may have motor abnormality. So can I say that in subcortical dementia, patient may initially present with motor abnormalities? Yes, very good. So please remember, motor system is usually normal in the beginning in cortical dementia, while you may get motor abnormalities in subcortical dementia first. So can anybody tell me why this is happening? Can anybody tell me ऐसा क्यों हो रहा है? See this, it is the subcortical gray matter, is getting affected first. Areas like basal ganglia, which are associated with movements, they are getting affected first. So this may come as a clinical question also, कि patient को cognitive impairment है, but initially he started with, certain motor abnormalities. So which dementia you are thinking? So in the option, they may give you one of the option as a subcortical cause. So remember, sometimes such new questions may be framed like this. I hope this is clear to everyone, right? Also, there may be certain dementias which may have mixed features in the beginning, like vascular dementia, even Lewy body disease, a very important topic we'll discuss. Okay, so sometimes they may have mixed features. That means features of both cortex and subcortex may be there. I hope this is clear. Also, chalo, since we are discussing most common cause overall we have discussed of dementia is Alzheimer disease. Can anybody tell me second most common cause, overall cause of dementia is again step ladder pattern you see in vascular dementia. Step ladder pattern, very good. You see in vascular dementia, very good. Can anybody tell me overall second most common cause of dementia now is? Again, this is a very important point. Remember, it is Lewy body disease or dementia due to Lewy bodies. Remember this. This is a very important topic I'll cover. I hope this is clear. In fact, this is the next topic I'm going to cover now. See this question. This question was asked in both these exams, and I'll tell you what was the question. First it was asked in NEET PG, a 75-year-old female having difficulty in doing activities of daily routine. So they are trying to tell you she's having problems in activities of daily routine. There is cognitive impairment, she has visual hallucination, and also she has motor features like bradykinesia, tremors. In the brain you can see Lewy body. So what is the diagnosis which is coming to your mind? I'll come to that question, but let's see this question first. What diagnosis? You'll say very good. You'll say, sir, the diagnosis which is coming to your mind is Lewy body dementia, Lewy body disease. Very good. Let's talk about Lewy body dementia. This is a very, very important topic, and in fact there is a potential new point also which I'll discuss may come in the upcoming exam. Lewy body dementia has both the features, cortical features also, and it has subcortical features. I'll give you a mnemonic. There are earlier 3 core features, now one more 4th core feature has been added in Lewy body dementia, very, very important. So I'll give you a trick to remember. So suppose there is a person, Mr. Lewy, he goes for the interview, and in the interview, the interviewer asks Mr. Lewy, show your CV, Mr. So remember CV, Mr. So they tell Mr. Lewy, show your CV, Mr. So let's see what is C. C is there is problem in cognition, there is fluctuating cognition. So variation in cognition, and that is also very, that is not stable, it is fluctuating. So family members may report that cognition was less impaired in the morning, that by the evening it got more impaired, then it improved. So जो cognition है वो impaired और वो fluctuate कर रही है. Can you appreciate, we have been discussing this point कि visual hallucinations are more common, in organic mental disorder सबसे common hallucination कौन सा है? Visual hallucination. See this, in the core criteria itself there is visual hallucination. I told you Lewy body dementia, it has, again subcortical features also. See the 3rd core feature, motor features of Parkinsonism like tremors, rigidity, bradykinesia. This is a very, very important point. Now REM sleep behavior disorder has been also added in the core feature. This may come as a potential new question. Please remember this. So they may just ask you, a patient has REM sleep behavior disorder, which dementia you're thinking of? Remember, it is Lewy body dementia or dementia due to Lewy bodies. I hope this is clear to everyone. देखो REM, usually in REM there is atonia. What is REM sleep behavior disorder? देखो, usually we know REM में क्या होता है? The muscle is in a state of paralysis. But if this atonia does not occur, patient when in REM he is having punching, kicking movements. So this is REM sleep behavior disorder. I hope this is clear to everyone. Many questions have been asked from Lewy body disease. So please remember this. This is a new core feature which has been added. Also there are So can you appreciate in the question patient को cognitive impairment है, visual hallucination है और motor features of Parkinsonism है. So here you are thinking of Lewy body dementia. We'll come to this question. Before this, then there are also certain supportive features of Lewy body dementia. That means these features if are present, they are supporting the diagnosis. किसका diagnosis? Lewy body dementia. देखो, they have severe neuroleptic sensitivity. Neuroleptic का मतलब antipsychotic sensitivity है. We'll discuss कि antipsychotics can cause EPS. So these patients are sensitive to these EPS. देखो, I may think of giving antipsychotics to the patient because patient में है visual hallucination. But हमने patient को दिया antipsychotic, patient में come to us like this. Sir, I am not able to move my neck. My neck is twisted to one side. So can you appreciate? Patient को acute torticollis हो गया. So one has to be very careful because these patients are sensitive towards these side effects of antipsychotic. Also patient may have repeated falls. Please highlight syncope. Syncopal attacks you may see in the patient. There may be transient loss of consciousness, autonomic dysfunction, hypersomnia, hallucination in other modalities. देखो visual तो core feature में, other hallucinations can also occur. Delusions can occur like delusion of persecution, and please see this Capgras syndrome. This question has been asked in one of the FMGE exam. Patient आता है with Capgras syndrome, which dementia you are thinking? It can also occur in Alzheimer disease, but remember, you know, Capgras syndrome may be more commonly seen with Lewy body dementia. Remember Capgras syndrome, close person replaced by stranger. Patient may have other symptoms like depression also. So I am again highlighting some important points, you know, again you should remember which may be asked associated with Lewy body dementia. I hope this is clear to everyone. No, it's not a contraindication. We can give antipsychotic, but I will give antipsychotic in low dose. I will not give those antipsychotic which have high potency to cause EPS. Okay, I hope this is clear. हाँ, if possible I may avoid, but अगर necessary I may give. But remember they are having severe neuroleptic sensitivity. I hope this is clear to everyone. Now also one more point. Can you see in the pathology, again you know this question was asked in FMG exam. They had given the same question and in the end they had asked कि patient में आपको ये मिल रहा है, there is a core, central core which is surrounded by a halo. So can you appreciate ये क्या है? What is this? Remember ना, it is Lewy body. So what is this? In the pathology we find it is Lewy bodies, alpha synuclein. Very good. Now can you tell me a close, you know, differential diagnosis जहाँ पे Lewy bodies मिल सकती हैं? A close differential diagnosis in which Lewy bodies may be seen. Of course, Lewy bodies can be seen in Lewy body dementia. One more important cause. Can you tell me? Very good. In Parkinson's disease. Very good. In Parkinson's disease also you may find Lewy body. So let's come back to that question. देखो, please see this question. This was the question asked in NEET PG and they had asked diagnosis. देखो, you're thinking of Lewy body dementia, that was not in the option. So one more, you know, option that was given was Parkinson disease. There the answer was Parkinson disease. वहाँ पे Lewy body dementia was not in the option. फिर आंसर क्या था? Parkinson disease. Suppose if both are in the option, can you tell me how will you differentiate? अगर दोनों ऑप्शन में है, देखो दोनों में सिमिलर फीचर्स हैं. Can you tell me how will you differentiate? Very good. कैसे डिफ्रेंशिएट करोगे? वेरी गुड. देखो हमने डिस्कस किया था पार्किंसन डिजीज सबकॉर्टिकल है. इन द हिस्ट्री यू विल सी मोटर सिम्टम्स आर फर्स्ट, आफ्टर दैट कॉग्निटिव सिम्टम्स विल अकर. इनफैक्ट रिसर्च क्राइटेरिया में हम कहते हैं 1 year आफ्टर द स्टार्ट ऑफ मोटर सिम्टम कॉग्निटिव सिम्टम विल अकर. जबकि लुई बॉडी डिमेंशिया विल सी कॉग्निटिव सिम्टम्स इन द बिगनिंग प्लस माइनस मोटर सिम्टम्स. मोटर सिम्टम में अकर इन द बिगनिंग और में अकर लेटर ऑन. So again sometimes clinically also we can differentiate. Okay, I hope this is clear to everyone. Because since they are going so much into the detail of this topic, let me just discuss one more point. Again a potential question, maybe more for INI-CET aspirants who can just hear me out. In Lewy body dementia, especially in the initial stages when we do FDG PET scan, what we see there is hypometabolism in the occipital region but relative sparing of the posterior cingulate cortex. Can you appreciate this? You know, so please see this. So can you tell me what is this known as? What is this known as? This is known as the cingulate island sign. You know, just remember this. This is a sign again which may be seen in the initial stages of Lewy body dementia. Just remember this extra point, you know, again more for INI-CET, but just have an idea. Again, you know, very difficult to say which is an INI-CET and which is NEET PG or FMG question. Just remember this because they had asked, you know, one of the question of Capgras syndrome also. So just remember this point, okay? Just remember this is seen in the initial stages, okay? So this is known as the cingulate island sign, okay? I hope this is clear to everyone, right? Now let's talk about, in fact, in the later stages, this sign may be lost. So initially to differentiate from Alzheimer disease, sometimes this sign may be very helpful. Okay. Now let's talk about the treatment. Let's talk about all these questions can be asked in any exam. Very good. Yes. Now drugs for dementia. You know, I always say, always correlate the etiology with the mechanism of action, and you will never, you know, forget the etiology. Because we know, let's talk about Alzheimer disease here. Alzheimer disease, again this question has been asked. Because Alzheimer disease may, we know which important neurotransmitter is reduced. Can anybody tell me? We know acetylcholine is reduced. Glutamate, in the initial stages we say it is increased, and also there are A beta deposits. Also one more important pathological finding, can anybody tell me? What is neurofibrillary tangles? Since we are discussing, chalo ye bhi discuss kar lete hain. What are neurofibrillary tangles? Anybody? They are hyperphosphorylated. Which protein? You may find these deposits. These are tau, hyperphosphorylated tau protein. Very good. So we know some of the etiologies. There is decrease in acetylcholine, glutamate is increased. Glutamate is an excitatory neurotransmitter, and also remember A beta deposits. Now let's understand the drug's mechanism. So we know the etiology. So we are saying that there is a decrease in acetylcholine. So we use one important category of drug known as the cholinesterase inhibitors. Now please see this enzyme, what this enzyme is doing. Now we know that acetylcholine is broken down into acetyl-CoA plus choline by this enzyme. So what we are doing is we are inhibiting this enzyme. So what will happen? There will be increase of acetylcholine. Okay, so can you appreciate we are increasing acetylcholine? So remember some of these important drugs, tacrin, we don't use much now because it is hepatotoxic. Then we have other drugs like donepezil, rivastigmine and galantamine. I hope this is clear. Now let me ask you the question which was asked in INI-CET. Patient was started on this drug, cholinesterase inhibitor, but patient developed GI side effects. So these drugs can cause GI side effect. Which of these drugs now we can give? So I am trying to ask you, is there any drug which is also available in other form other than oral route which can be given? So what was the answer? Very good. Rivastigmine is available as transdermal patch. Very good. Transdermal patch. In fact, now even donepezil patches are also approved by FDA, but remember, yes, if you are asked one, remember it is rivastigmine. Now since they have asked this point, let me give you one more important new drug. So remember, there is a new drug with the name of benzgalantamine. Please highlight this new drug. Now this is a oral drug. Because they have already talked about GI side effects. You know, GI side effects are notorious side effects. So these can occur. So they have talked about this. So remember, benzgalantamine is a new drug. It's an oral drug which has very less GI side effects. So this drug is developed because it has very less GI side effects. So again, I have told you one new drug. So in fact, I will discuss some new drugs. In the end also, I will give you a list of some new drugs. So remember this. I hope this is clear. Now second is, we have talked about that glutamate is increased. So we use a NMDA antagonist. Now NMDA receptor, these are glutamate receptors. So can you appreciate glutamate increase ho raha hai? We are giving a NMDA antagonist. Can you name that drug starting with M? Can anybody tell me? Can anybody tell me what is the drug? Yes, it is mementin. Very good. So the NMDA antagonist drug, it is mementin. Very good. So please remember, mementin is a drug and usually it is used in moderate to severe cases. And also remember, it can be combined. Sometimes donepezil mementin combination are also available. Dekho, India mein to we have these two category of drug. Now there is a third category of drug. Remember we discussed that there are A beta deposits also in the brain. These two category of drug which we discussed, they can be used in other dementias also. But let's discuss some monoclonal antibodies. Now what these monoclonal antibodies are? They basically go and bind to the A beta deposits in the brain and help in their clearance. Now can I say these monoclonal antibodies can be used only for which dementia? Can you tell me? Very good. It can be used for Alzheimer disease. In fact, it is used for mild cases of Alzheimer disease and dementia, mild cognitive impairment occurring in Alzheimer disease. Very good. So remember the names with this only. So remember Alzheimer disease we are talking about now. So I'll just give you a trick. So three important drugs. One is aducanumab. Can you remember the name? Yes, you can. Aducanumab. What is MAB? Monoclonal antibody. It is a human IgG1 monoclonal antibody. Then we have L for lecanemab. Can you remember the name? Yes, you can. And one more drug is donanemab. So remember donanemab. These are humanized monoclonal antibodies. I hope you will be able to remember these names. Remember with this trick used for Alzheimer disease now. So there is A, L, D. So remember these three names. Also one more extra point you can remember with these drugs like lecanemab, there is one important adverse effect which you can remember. Just remember ARIA. They may just ask you the full form, what is ARIA? Remember, it is amyloid related imaging abnormality. Sometimes amyloid related imaging abnormalities can occur. So when we are giving these drugs, we give these drugs through IV infusion. When we give these drugs, we also do repeated imaging also, because one of the adverse effects, just remember ARIA, it is amyloid related imaging abnormality. Just remember the term. I hope this is clear. Now see this question. This is a question which was asked previously in FMGE, and this is a very interesting question. This is what I am saying, sometimes a very simple concept they will give you in this form. Which of the following is not suggestive of medical cause of mental illness? Let's see if we can answer this question. Options are elderly age, acute onset, loss of consciousness, auditory hallucination. First, try to understand what they are asking in the question. Always see what has been asked, then answer the question. Dekho, what they are asking, very good. Some of you are saying A, some of you are saying D, very good. Dekho, they are saying not suggestive of medical cause of mental illness. Let me reframe this question. When a medical illness has a medical cause, so can I say there is a visible cause? Can I say they are talking about organic mental disorders? So now reframe this question. Which of the following is not suggestive of organicity? Now tell me, elderly age, is it suggestive of organicity? We know dementia, delirium, both may be more in elderly. Acute onset, we know acute onset like delirium is again suggesting towards organicity. Consciousness if is impaired is again suggestive of organicity. Please remember, I have been telling you again and again, Consi hallucination is suggestive of organicity. It is not auditory, but it is visual. So can you appreciate a very simple point like that? They framed in a question. So always try to read the question and then try to come to the answer. I hope this is clear to everyone. Very good. Now let's come to the next topic. We have covered a very important topic of organic mental disorder or neurocognitive disorder. Let's come to now the psychotic disorder. See this question. A 30-year-old male patient is brought to the psychiatry clinic with an illness since 10 years. देखो psychiatry में duration is very important. Always make a note if they have mentioned duration. Family members report that when any happy event and sad event comes at home, he shows no emotions. So can I say this is flat affect? This is flat affect, can I say? He also doubts that his wife is not his wife but a neighbor in disguise and doesn't get convinced even if they try to give contrary evidence. So can I say this is a delusion? And here it is Capgras syndrome. He also report of hearing voices of the neighbors talking about him not heard by others. So what is this? This is hallucination. Which hallucination? It is auditory. Can you tell me the diagnosis? The diagnosis here is very good. The diagnosis here is schizophrenia. Dekho, if I change the duration, the diagnosis may change. If symptoms are less than 6 months according to DSM-5, then the diagnosis would have changed to acute psychosis. So please remember, duration is very, very important. Always make a note of duration. So let's come to a very important diagnosis, that is schizophrenia. Because schizophrenia, DSM-5 ke according, there are 5 symptoms, and I always use this mnemonic. Now, if you've seen this movie Dhadkan, just remember the name. Don't worry if you've not seen this movie. Movie mein nobody had schizophrenia, but the name of the movie will help us remember the symptoms of schizophrenia. So remember the movie name Dhadkan. So D for delusion, HA for hallucination, D for disorganized speech, catatonic symptoms, and N for negative symptoms. So these are the 5 symptoms. Let us discuss. Dekho, we have already covered what are delusions. Any delusion can occur in schizophrenia. Any hallucination can occur. Can you appreciate we have talked about disorganized speech or disorganized thoughts? Remember some of the abnormalities of disorganized thinking like loosening of association, derailment, tangentiality, neologism. We have discussed now. They can occur here. Now let's talk about what are negative symptoms. Can you name some negative symptoms? Now very important, let's discuss some negative symptoms like anhedonia. What is anhedonia? Patient says, sir, there is decrease in interest. My interest has reduced. Sir, earlier I used to enjoy playing cricket, but now मेरा interest कम हो गया. Avolition. But what is the meaning of volition? Means willpower. So what is avolition? Means decrease in the will. What is alogia? Can you appreciate we discussed neologism? So logia means word. Alogia का मतलब क्या है? There is decrease in the verbal output. Patient is speaking very less. Affect blunting, or you can say affect flattening. Can you appreciate we have already covered what is affect flattening? This in fact was asked this year in FMGE exam. Now, affective flattening is a negative symptom of schizophrenia. Okay, so there is decrease in the emotion. Also there is asociality. See this. देखो, don't confuse it with antisocial. Antisocial का मतलब है against society. Asocial का मतलब है less social. Family members say that he socializes very less. People come and meet him, he socializes very less. Don't go and greet them. मिलता जुलता नहीं है. Decrease in socialization. So these are some negative symptoms of schizophrenia. Lastly, let's also talk about catatonic symptoms. I hope catatonic symptoms is a very important topic. Again, a very important slide which we are discussing. Many times you will see questions may be asked just on these terms also. So catatonic symptom, basically these are motor symptoms. So patient may have certain motor signs or symptoms. Okay, I am talking about catatonia in schizophrenia, but that does not mean it is only seen in schizophrenia. It can be seen in other condition. In fact, catatonic symptoms are more common in mood disorders than even schizophrenia. So let's discuss some of the important catatonic symptoms. The first is stupor. Stupor means there is a decrease in the psychomotor activity. Psyche means mind, motor means body. So patient speaks very less, patient hardly moves. So patient may be in a stuporous condition. He is just lying down, not talking much, not reacting much. Some patients may have opposite, excitement. मतलब उनकी psychomotor activity बहुत ज़्यादा है. You will see a patient with catatonia is very excited, not sitting at one place, running around. So patient may also have excitement. And remember mutism. Mutism means, you know, suppose you are watching television, you can mute the television. So as if I muted the patient. So patient is speaking very less. Speech is significantly reduced or no speech. So these are the first three symptoms. What I have done is I have clubbed them together so that it becomes easy for us to remember. Next, very important is waxy flexibility. You know, sometimes you will see this term in the question when they are asking about catatonia. देखो, waxy flexibility मतलब flexible like a wax candle. Person can be molded like a wax candle. Suppose this is a wax candle. If I try to mold, initially resistance होगी, उसके बाद I can bend the way I want. Similarly, suppose I am moving the patient's hand, initially there will be resistance and after that I can bend the way I want. So ये है waxy flexibility. Can I say in waxy flexibility there will be initial resistance? There will be initial resistance. So please remember this. Initial resistance will be seen in waxy flexibility. Also see this, you know, sometimes you may be given such images. You know, examiners are fond of images. So can you appreciate patient ने एक abnormal posture maintain किया हुआ है? This could be catalepsy, this could be posturing. दोनों में difference क्या है? Catalepsy is a passive phenomena. Passive phenomena मतलब suppose examiner ने patient को इस posture में लाया and now patient is maintaining. मतलब passively वो आया. This is catalepsy. देखो ये catalepsy है. Cataplexy भी एक term होता है जो narcolepsy में आता है. तो कैसे याद रखना है? नार्कोलेप्सी यू डोंट हैव कैटालेप्सी, यू हैव ऑपोजिट कैटाप्लेक्सी. कैटालेप्सी कहाँ होता है? इन कैटाटोनिया. पोस्चरिंग का मतलब इट इज अ एक्टिव फिनोमिना. पेशेंट हिमसेल्फ केम इन दिस पोस्चर एंड नाउ ही इज मेंटेनिंग. सो दिस इज पोस्चरिंग. नाउ अगेन प्लीज रिमेंबर व्हेन यू डिफरेंशिएट कैटालेप्सी फ्रॉम वैक्सी फ्लेक्सिबिलिटी, इनिशियल रेजिस्टेंस कहाँ मिल रहा है? इन वैक्सी फ्लेक्सिबिलिटी. While in catalepsy there is no resistance, you know, you just place the patient like hand like this, remove your hand, patient may maintain this posture. This is catalepsy. Let's discuss the next two terms, negativism and automatic obedience. Again just see the name, negativism. Patient as if is carrying a very negative attitude. मतलब whatever I say, patient will do the opposite. I tell the patient come forward, he goes backward. Come forward, he goes backward. So can you appreciate whatever I am saying, he is doing the opposite. While automatic obedience means now he is automatically obedient. He is showing extreme cooperation. Whatever I tell the patient, he will do, even if it is harmful for him. For example, if I tell the patient I am holding a needle and I will prick your tongue with the needle, I have told this to the patient. Now I tell the patient pull out the tongue. He will pull out the tongue. Even if I prick his tongue slightly, he will again pull out the tongue. So ये क्या है? Automatic obedience. Let's discuss the next two symptoms together, mannerism and stereotypy. Here patient is having some abnormal movements. Patient is doing some abnormal movements. What is the difference? Difference है नाम में. See the name. Mannerism is derived from the word manner. इसका मतलब क्या है? Patient whatever movement he is doing, they have a purpose. These are purposeful movements. For example, a patient is doing repeatedly this movement. Can you appreciate? It's a salute movement. It has a purpose but now it has become repetitive. तो ये क्या है? Mannerism. जबकि what is stereotypy? These are non-purposeful movement. Patient is doing such movement which has no purpose. So ये क्या है? Stereotypy. Next two symptoms. This was in fact asked in one of the recent exam. Echolalia, echopraxia. Echo means to repeat. Lalia means word. Patient is mimicking, repeating the words of the examiner. What is your name? What is your name? What do you do? What do you do? So can you appreciate? He is repeating whatever you are saying. So ये क्या है? Echolalia. What is your name? My name is Mukesh. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. ये क्या है? Can anybody tell me? I've just asked this question so that you understand the difference. What was this? When he was answering all the question with the same answer. Can you tell me what is this? When he is answering, that was perseveration. Very good. What is echopraxia? देखो, apraxia we discussed ना. Praxia means movement. So echopraxia means repeating the movement. Whatever movement you are doing, patient will repeat the same movement. Suppose you are writing in front of the patient something. Patient has no pen, no paper, but he will also repeat the same movement. Scratch your head in front of the patient. Patient will also scratch his head. So ये क्या है? Echopraxia. Last two symptoms, grimacing. Grimacing का मतलब है patient is maintaining a odd facial expression. You know, nowadays when you take a selfie, what do? You pout. If you maintain that pout for a long time, what is it? Grimacing. And lastly, ambitendency. देखो, ambi means not able to decide. Tendency means movement. So ambitendency means not able to decide a movement. At the level of movement, there is undecisiveness. Suppose patient goes forward, then come backwards, then goes forward, then come backward. Patient decide nahi kar pa raha, should I go forward or should I remain backward? So this is ambitendency. So these are some of the important catatonic symptom. I hope catatonic symptoms are clear to everyone. Very, very important topic. You know, you may be asked question just on the terms. Let us also talk about the treatment. Let's see this question. In fact, this was asked in INI-CET exam. You know, we'll discuss management of schizophrenia, we'll talk about antipsychotic. But when they ask you treatment of catatonia, see this, very good. Patient comes with voluntary purposeless movements, there is negativism, there is waxy flexibility. So we say 3 or more symptoms. When we say that patient has catatonia, if out of those symptoms patient has 3 or more of those symptoms. So see, he has 3 or more of those symptoms, so he has catatonia. What is the treatment? Very good. So first line treatment of catatonia is lorazepam. So we use benzodiazepine like lorazepam. We can give IV or we can also give IM or oral. Patient may show drastic improvement. If lorazepam is not working, then another important method can be used. What is another important treatment modality? It is ECT, electroconvulsive therapy. So first line treatment you can answer as lorazepam. If they ask you best treatment for catatonia, then you can go with ECT. I hope this is clear to everyone. A very, very important point. Please remember this, right? Now let's talk about schizophrenia. Now again, I'll share this table with all of you. Again, I'll not go into the detail, but still I'll just discuss, you know, schizophrenia mein prognostic factors are very important. 2 important prognostic factors I'll discuss, you know, because sometimes it is confusing. So remember, presence of mood symptoms. If a patient along with schizophrenia, let us say, is appearing sad, that has a good prognosis as compared to absence of, you know, mood symptoms. So remember this. So presence of mood symptom, you know, we have discussed patient has flat affect. So if we showing some mood symptom, that means the affect is not totally dead. So remember, presence of mood symptom is a good prognosis. Also one more point, family history of mood disorder is good. While family history of schizophrenia, so suppose a patient's, you know, let us say one parent had depression and another patient's parent had schizophrenia. तो किसके, you know, patient में you will say has a better prognosis, remember, जिसकी family history में mood disorder है, as compared to somebody who has a family history of schizophrenia. So please remember, you know, presence of mood symptoms and family history of mood disorder is a good prognosis. But please remember, when I say mood symptom, it is not a negative symptom. Please remember, देखो, please remember this. When we talk about negative symptoms of schizophrenia and when we talk about depression, please remember, देखो, many of the negative symptoms you will feel that they are like depression. But in negative symptoms, I have never said that patient's mood is low. Negative symptoms of schizophrenia mein patient may have anhedonia, patient may have asociality. You may think that, sir, it is appearing like depression, but please remember, when I will discuss depression, depression is a mood disorder. So when I say depression, that means that there is abnormality of mood. While in negative symptom we have not discussed. that patient ka mood is abnormal. So please remember, sometimes negative symptoms of schizophrenia and depression can be very confusing. But can you appreciate the difference? When we say depression, there you will see abnormality of mood. We'll talk about this when I'll discuss depression. Jabki in negative symptom of schizophrenia, I did not say ki abnormality of mood is there. There are some other symptoms. So that is why flat affect is a negative symptom and not a affective symptom. That question जो FMG में आया था उसमें एक ऑप्शन था कि affective flattening is a affective symptom. नहीं, affective symptom का मतलब है they will say some abnormality is there related with feelings or emotions. I hope this point is clear to everyone. है ना, negative symptom is a bad prognostic factor, but presence of mood symptom remember is a good prognostic factors. I hope the point is clear to everyone. है ना, when I say mood symptom मतलब mood की abnormality है. Clear? Very good. है ना, I hope this point is clear to everyone. Yes. Now let's talk about, now before coming to the treatment, let's talk about the antipsychotics, and dopamine pathway. Now there are various pathways, 4 important dopamine pathways in the brain I'll discuss. 2 pathways are related with symptoms and 2 pathways are related with the side effects. Now please remember, one pathway is mesolimbic pathway. Meso means midbrain to the limbic system. In this pathway there is increase of dopamine जिससे positive या psychotic symptoms होते हैं of schizophrenia like delusion, hallucination. While in the mesocortical pathway कहाँ से कहाँ तक? It is from the midbrain to the cortex. There is decrease of dopamine and which leads to negative symptoms of schizophrenia. So can you appreciate? Please remember this. The 2 pathways are related with symptoms, dopamine pathways. Mesolimbic में dopamine increase हो रहा है, mesocortical में dopamine decrease हो रहा है. Now also let's discuss 2 more pathways. When you understand these pathways, you will understand some of the important side effects associated with antipsychotics. See this. The third pathway which I am discussing is nigrostriatal pathway. But please see the name. When you talk about the nigrostriatal pathway, substantia nigra to the striatum. In medicine, neurology में which disorder, you read these areas. One of the disorders is Parkinson disease. Let's use our knowledge of Parkinson disease and understand about this nigrostriatal pathway. Now in Parkinson disease, we know patient has motor symptoms like tremors, there is rigidity, bradykinesia, such symptoms are there. And we know we give drugs like levodopa because we know there is decrease of dopamine in these areas. So decrease of dopamine in these areas, can I say, is leading to motor symptoms. I hope this point is clear to everyone. Now let's apply this knowledge and see, when I treat a patient with antipsychotics in schizophrenia, we'll discuss, we are saying that dopamine is increased in schizophrenia, so we use antipsychotics that are dopamine antagonist. So can I say the dopamine antagonist, that is antipsychotics, what they will do? They will decrease dopamine in this pathway, and we know decrease of dopamine in this pathway can lead to motor symptoms, so that is known as EPS. I hope this point is clear to everyone. This is again very important, that why antipsychotics are causing EPS. Because antipsychotics are decreasing dopamine in this pathway also. And in this pathway, if dopamine is reduced, it can cause motor symptoms. So just remember your knowledge of Parkinson and you will be able to remember this. I hope this is clear to everyone. Also remember one point. Now can I say, if I want to treat EPS, I need to increase dopamine in this pathway? And in fact, in this pathway we see that dopamine has an inverse relation with acetylcholine. This question was asked in a recent INI-CET exam. So the question was, so can I say in the treatment of these EPS, देखो मुझे dopamine increase करना है. So can I say if I use anticholinergic drugs, what they will do, they will decrease acetylcholine, जिससे क्या होगा, dopamine will be increased in this pathway. In fact, we'll correlate this point when I'll discuss like treatment of acute dystonia, we'll use anticholinergic drug. So can I say anticholinergic drugs will increase dopamine in this pathway so that we can treat the EPS. Very good. I hope this is clear now. Just remember this one point. Okay, remember this one point, that anticholinergic effect will increase dopamine in this pathway. Okay. Now also there is one more pathway, that is tuberoinfundibular pathway, that is from hypothalamus to pituitary. Now we know from our physiology knowledge that dopamine is inversely related to prolactin here. Again, can you appreciate when I am giving antipsychotic, what they do? They will decrease the dopamine in this pathway. So what will happen? Again, a very important point, remember there will be hyperprolactinemia. So please remember, antipsychotics can cause hyperprolactinemia. Now just remember, let's talk about obs-gynae. You know, a lady who is pregnant who has delivered, you know, there is increase in prolactin. So what all important effects are there? There is milk secretion, there is galactorrhea, there is lactational amenorrhea. So a lady who is not pregnant, who has not delivered, but she is on antipsychotic, she may develop very similar side effects. Remember, so patient has developed galactorrhea, amenorrhea. Again, this can occur because of hyperprolactinemia, and both in males and females there can be decrease in libido or sexual desire. So remember, these side effects can occur because of decrease of dopamine in this pathway. I hope this is clear to everyone, hai na? Very good. So please remember, one point which I want you to remember is that antipsychotics can cause hyperprolactinemia. I hope this point you will remember, right? Now let's see some important EPS. So let's talk about, this is a very important topic. You will see many questions being asked recently in all the exams related with EPS. Let's answer this question. A patient diagnosed with schizophrenia was taking the medicine trifluopromazine. This is a first generation antipsychotic, and developed Parkinson-like symptoms, tremors, rigidity. Treatment. What is the treatment? Very good. It is trihexyphenidyl. We'll use anticholinergic drug. Let's talk about this table of EPS. You know, I've given a very simple mnemonic, DP at night. So in medical college you have dance party at night. So remember this simple mnemonic and we'll discuss important EPS. So what is D? Remember D for acute dystonia. It is the earliest EPS to occur. You know, sometimes if you give the drug parentally, patient may develop symptom within few minutes also. Acute dystonia. Dystonia का मतलब है sudden contraction of muscle. So patient को हमने antipsychotic दिया, patient may come to us, sir my eyes are uprolled upwards, I am not able to move my eyes, oculogyric crisis. Patient may say my neck is twisted to one side. Patient may even develop, so this is torticollis, may even develop laryngospasm, may have difficulty to swallow, or may even have difficulty to speak clearly. So these patients may land up in emergency. What is the treatment? Very, very important treatment. We discussed now that we can use anticholinergic drugs, give drugs parentally like promethazine, benztropine. This was asked in one of the exam. Again, before doing anything else, we will use anticholinergic drugs. This is a very distressful condition the patient has come in. Okay. Now next is P, drug-induced Parkinsonism. So patient may come to us with tremors, rigidity, bradykinesia. Again, what is the treatment? We can give anticholinergic drugs. Here we can give oral drugs like trihexyphenidyl. That was the answer of the question. DP. Next is AT. A for akathisia. Again, please highlight this. You may be asked question on this also. Akathisia का मतलब है restless. Patient is restless. This is the most common EPS. So patient will say, sir, ma'am, inner also I am feeling restless. अंदर से मुझे restless feel हो रहा है, घबराहट हो रही है. And also when I see the patient objectively, you will see that patient is not able to stay still, continuously is moving, he is pacing around, he is rocking from foot to foot, constantly pacing. So from inner also he will say I am restless, outside also, objectively also you will see restlessness. So this is akathisia, and remember for akathisia the drug of choice is beta blocker like propranolol. I hope this is clear to everyone. Very, very important. DP at T. What is T? T is tardive dyskinesia. Tardive means long term use. In the question, they may tell you patient is using antipsychotic for a long duration, maybe for months or years. Dyskinesia, patient has developed some abnormal movement like chewing movement, lip smacking movement, or there is tongue protrusion movement. In the hand, patient may have piano playing like movement, or there may be pelvic thrusting. You are thinking about tardive dyskinesia. Again, treatment may we can use VMAT2 inhibitors. These are dopamine depleters like valbenazine, deutetrabenazine. So these drugs can be used. N, remember N, very important, neuroleptic malignant syndrome. I am trying to give you clinical scenario so that you are able to answer those questions. Please see this, neuroleptic I know means antipsychotic, malignant, if something is malignant that means it is serious or it is benign, it's a serious condition, it's an emergency. So patient on antipsychotic comes to us with high temperature, increase in the CPK, creatine phosphokinase, there is muscle rigidity, there is breakdown of muscle, CPK levels have increased. What you are thinking of? You are thinking of NMS. Patient may have other symptoms also, like there is sweating, tachycardia, patient is confused, there is increase in the LFTs, even the TLC count is increased. Again, all these are pointing towards NMS. If they ask you first step in NMS management, what is the first step if I ask you? Please remember, try to answer the question like this. If I ask you first step, then you will say, sir, I'll stop antipsychotic. If they ask you drug of choice, yes, then it is dantrolene. Very important. I hope this is clear. So that is a skeletal muscle relaxant, so dantrolene. We can also use dopamine agonists like amantadine, bromocriptine in the management. I hope this table is very clear to everyone. So you see in the question there will be history of dopamine antagonists like antipsychotic, and patient has developed some of these motor sign symptoms. Then you're thinking of all these important side effects. So remember this mnemonic, DP at night. See this question which was asked again recently. Very good. A patient with sudden spasm of muscle on antipsychotic treatment. So what you're thinking of, tell me what is this EPS, sudden contraction of muscle? Yes, you're talking about acute dystonia. Yes, thank you. Yes, so this is, you will give IV benztropine. Very good, the answer is option C. Now let's talk about some important antipsychotics. Again, I'll discuss few points about these antipsychotics. देखो मोबाइल में तो we have 5G ना, but in antipsychotic we have 1G and 2G, and also I'll discuss one new drug also. I'll show you a question also which can be framed. So we have first generation, that is typical. We have second generation, that is atypical. Now what is the mechanism of action? Remember we said na dopamine increase हो रहा है schizophrenia में. So first generation is a D2 antagonist. So it is specifically, it is antagonizing which dopamine receptor? D2. Remember D2. देखो also when we talk about the etiology, we also say that there is increase of serotonin in schizophrenia. So you just correlate the mechanism of action of second generation, you will remember this. Second generation are not just D2, but they are also 5-HT2A antagonist. So can you appreciate, हमने कहा serotonin increase हो रहा है, so we are giving a serotonin antagonist. देखो how to remember, both are 2. And which 2 it is? Remember A for atypical, this is how you can remember. Because sometimes in the exam we get confused. Both are 2 and it is 2A. I hope this is clear. Now EPS occurs because of dopamine blockage in the nigrostriatal pathway. Can you tell me which will have more EPS, which will have less EPS? Anybody? Can you tell me which will have more EPS, which will have less EPS? Okay. So please remember, more will be with first generation, less EPS will be with second generation. Yes. In fact, maximum is, one of the first generation with maximum EPS is haloperidol. Very good. Now, what is metabolic side effect? This is one topic, I'm seeing so many new questions being asked again and again. So this is one important point I'll discuss. Metabolic side effects. Metabolic side effects, for example, patient may have hypertension, may develop diabetes, may develop weight gain, even cardiovascular disease. Now, metabolic side effect, in fact, this question has been asked in one of the INI-CET exam. Once this question has been asked, you should know. Metabolic, in fact, weight gain is a metabolic side effect that asked, it occurs because of which? Blockage of which receptor? So, remember, ये metabolic है ना, it is because of blockage of 5-HT2, यहाँ पे भी 2C, remember it like this. Metabolic blockage of 5-HT2C receptor. Now, if I ask you which drugs will have more metabolic side effects, how to remember? You can say, sir, it is the second generation which are blocking serotonin. So how will you say? It is, yes, even hyperlipidemia. Very good. Even the lipid profile is deranged. Yes, very good. Yes, all these are metabolic side effects. Who will have more metabolic side effect? Remember, usually it is more with second generation and less with first generation. I hope this is clear to everyone. But there are some exceptions and they have asked questions on these exceptions. We'll talk about that a bit later. Very good. But I hope this is clear to everyone. Patient says, sir, when I am on these antipsychotic, my weight is increasing, my blood pressure is increasing, lipid profile is getting deranged. So remember, even metabolic side effects can occur. Let's discuss some first generation drugs. So let us talk about some first generation. Now one is haloperidol. Haloperidol is one of the drugs, and remember it is one of the first generation jiska EPS is maximum. Chlorpromazine is one of the drugs, I see, a lot of questions on chlorpromazine. I will also discuss one new question. Because this question was asked previously in INI-CET. Chlorpromazine ka mechanism of action we know is D2 antagonism, it's a first generation, but it also blocks alpha receptors. So blockage of other receptors will cause side effects. Alpha blockage se kya hoga? There will be hypotension. Muscarinic receptor block होंगे तो it will cause anticholinergic side effects. H, what is H? Histaminic receptors. Antihistaminic receptors, antihistaminic effect क्या होगा? It can cause sedation. And one more important side effect you should know, histaminic effect is it can also cause weight gain. Look at this, chlorpromazine is a first generation antipsychotic, but it has a moderate risk of weight gain. Please remember this point. This question has been asked, so we'll discuss that question. Remember this. Now, if I want to ask an integrated question, I will ask like this. A patient on antipsychotic goes to an ophthalmologist with some problem in vision, and ophthalmologist sees some deposits on the cornea on the lens. They may also give you some images, split lamp images may be given. So can you tell me which drug is responsible? Very good. Remember, it is C for chlorpromazine, C for corneal and lenticular deposits. Very good. So please remember, this can come as a integrated question with ophtha. Please remember. One more drug is thioridazine. Again, R is coming in between. Now remember some important points. I'll share better. You'll get PDF. Don't worry. Don't worry about the PDF. You'll get it. Okay. So thioridazine, 3 R's, 3 important side effects you can remember. Again, a patient on antipsychotic develops some retinal pigmentation. Now, which drug you are thinking of? It is thioridazine. Also, one more R, remember, it can rise, it can increase in the QTC interval. And also one more R, it can cause retrograde ejaculation. Sexual side effects, decreased libido can also occur. Dekho, we know thioridazine is a first generation antipsychotic, but it is one of the first generation which has less EPS. So this also you can remember. Haloperidol we discussed has maximum EPS. Thioridazine is one of the first generation which has least EPS. I hope this slide is clear to everyone. Please be very careful. Yes, very careful, such questions can be asked. Now let's talk about one drug in second generation which is very, very important. One of the star drugs, Clozapine. Now very importantly, you'll see many questions have been asked. NEET PG, INI-CET mein back to back. Recently questions were asked from this drug, Clozapine. It's a second generation antipsychotic. Now there is some important difference. Usually we say that second generation they are blocking more of D2 receptor, but Clozapine, it is blocking D4 more than D2. EPS हो रहा है D2 के blockage से. So this is one of the drugs with least EPS. Antipsychotic with anti-suicidal property, remember it is again Clozapine. Clozapine anti-suicidal property है. Which mood stabilizer, if I ask you, has anti-suicidal property? Can anybody tell me? कौन सा mood stabilizer है which we'll discuss in the end which has anti-suicidal property? It is lithium. Very good, it is lithium. Now what is the use? There is one important use. देखो, a patient comes to you for the first time, पहली बार schizophrenia है, never ever he is on any antipsychotic. Will you give Clozapine? No. It is used for this indication, for treatment resistant schizophrenia. That means if a patient has no response to at least 2 antipsychotic, you gave haloperidol, no response, gave olanzapine, no response, then I'll think of Clozapine. This was the question which was asked in NEET PG. You will say, sir, it is such a good drug, why don't we start it as a first drug? Because it has some serious side effect which we will cover. But before this, let's discuss some common side effects. One of the most common side effect is it can cause sedation. So usually we start the drug in the night time. Cyalloria, it can cause hypersalivation. Now this question can be asked. Patient comes to you in the morning, his pillow is all wet because of cyalloria. Which is the first practical step you can do with, before starting any drug? Because this cyalloria occur because of decrease in swallowing. Now before starting any drug, one practical method which we can do is we can tell the patient to put a towel over the pillow. Tell the patient put a towel over the pillow. This is the first practical thing. He's again he's affected because the pillow is all wet. So you can just tell him to put a towel over the pillow before he sleeps. Patient can also develop hypotension, weight gain. In fact, we'll discuss this is one of the drugs which has maximum weight gain. Also anticholinergic side effect like constipation. Remember, C for Clozapine, C for constipation can also occur. I'll give you a slide, discussing about weight gain because of important antipsychotic. We'll discuss this in the end. So remember Clozapine. Now let's come to the serious side effects. So remember how we remember the serious side effects. If you've seen the movie Drishyam, who was killed in Drishyam? Sam. So remember it with the mnemonic Sam. What is S? Can anybody tell me? What is S? What is S? It is seizures. Yes, patient on Clozapine can develop seizure. So how we can treat this? We can treat it by giving anti-epileptic drug. A is very important. Can you tell me what is this A? Patient on Clozapine comes to you with fever, with sore throat, with tachycardia. You're suspecting infection. So it may be because of agranulocytosis, very, very important, decrease in the WBC count, especially the absolute neutrophil count. I'm trying to give you a clinical picture because this is how you may get a question. What you will do is you will check these levels and you will stop clozapine if the WBC count is less than 3000 per millimeter cube or the ANC is less than 1500. In fact, this is such a serious side effect. What we do whenever we start a patient on clozapine, we monitor the levels. We monitor the levels for the first 6 months. Every week we will monitor these counts. After that, next 6 months, we will do it every 2 weeks, and after that we will do every month. So per month we will do till the time the patient is on clozapine, we will regularly monitor. In fact, this was asked in the INI-CET, which serious side effect of clozapine requires close drug monitoring. So remember, it is agranulocytosis. Patient is on clozapine, comes to you with chest pain, there is tachycardia, abnormal ECG. So what is this? This is myocarditis. Again, if the patient has developed myocarditis, you have to stop the drug. So remember, these are some important serious side effects. Now, one very interesting question which I always ask, this can come as a new question. Patient on clozapine develops seizure. You are planning to give an anti-epileptic drug. One important anti-epileptic drug you will not give in this case. Okay, you will not give in this case. Very good. We'll talk about that. Tell me which important anti-epileptic drug may be contraindicated. Remember, C say clozapine, C say contraindicated, C say it is carbamazepine, because we know carbamazepine can also cause bone marrow suppression. So again, clozapine is causing agranulocytosis, it is causing bone marrow suppression, lethal combination. Again, don't start such drug which also decreases the count. I hope this is clear to everyone. I hope this is clear. Very good. Now let me just talk about this table. So many questions, in fact FMGE may back to back they have asked questions from this. Now if we talk about antipsychotic induced weight gain, remember two of the drugs which have high risk, it is clozapine and olanzapine. O for olanzapine, O for obesity also you can remember. This question in fact came in January 2025. Patient on olanzapine, he was diagnosed with schizophrenia, showing good improvement on olanzapine, but he stopped taking the drug. Because of which cause he might have stopped? This was the question. So because of weight gain. Sometimes patient says, my weight is increasing, patient may become non-adherent to the drug. So remember. Okay. Now moderate may please see this. Risperidone we know is a second generation, quetiapine is also a second generation, paliperidone, chlorpromazine, look at this. It is a first generation drug which causes moderate weight gain. Now I am just discussing some drugs in the low. Again, we know in the low risk there may be some of the first generation like haloperidol, but look at this, two second generation drug. You can remember A to Z, A aripiprazole, B ziprasidone. They also cause low risk of weight gain. So out of chlorpromazine and these drugs which are second generation, which has less weight gain risk, it will be these second generation drugs. So remember this point, very, very important. Yes. Also remember, few points about aripiprazole, it causes low risk of weight gain. Also it has low risk of hyperprolactinemia. So there is a low risk, you can remember, usually we discussed that they have hyperprolactinemia, but aripiprazole has low risk of hyperprolactinemia, remember. Also remember, aripiprazole ka mechanism is slightly different. It is a partial D2 agonist. Dekho, it is acting on D2 only, but it is partial D2 agonist. So please remember this. I hope this is clear. So these are some important points. Let me show you the question which was asked. Dekho, this year the question was ki olanzapine he has stopped. Why? Because of weight gain. This was the question asked last year. Least metabolic side effect is with which drug? Now the answer I hope is very clear to everyone. We know risperidone can cause moderate, quetiapine can cause moderate. Dekho, ziprasidone, chlorpromazine is a first generation, but it also causes moderate. So it is ziprasidone. Although it is a second generation, but it has least out of these options. I hope this is clear to everyone. Yes, very good. Now see this. This is one question, a potential new question which can come or the topic which can be asked. Which of the following is incorrect about xanomeline? Tell me. So which of the following is incorrect about xanomeline? So tell me what is the answer here. Tell me the answer. देखो xanomeline is a new drug which has been approved for schizophrenia. So please remember, it is a new drug. What is the mechanism? See, again in schizophrenia etiology, we have talked about dopamine is increased, serotonin is increased, and some of the other neurotransmitters like acetylcholine, like glutamate, GABA, they are reduced. So to treat a patient, if we are talking about acetylcholine, so we have to give a agonist. It is a M1 M4 muscarinic acetylcholine receptor agonist. Very good. It is combined with trospium. Yes, it is combined with trospium to counter the cholinergic adverse effects, because we are giving a cholinergic agonist. Peripheral side effects can occur. So trospium is added. It works on the peripheral tissue to decrease those side effects. Is it safe in liver disease? No, it is not recommended for even mild liver disease. So how to remember? Just see the name. I'll give you a trick. Remember it. It is M is coming in between. Remember, it is a muscarinic agonist. L is coming. Remember, it is not safe in liver disease. Not recommended even in mild liver disease. So please remember this. So the answer here is, the correct answer is option D. I hope this is clear to everyone. So just remember this, sometimes a new drug may be asked like this. See this question now. So we have talked about schizophrenia, very important topic. Next is a patient since 3 months. Okay, before this, let me just come back to the diagnosis. We were talking about the diagnosis. I'll come back to this slide. See this here. To make a diagnosis of schizophrenia, we have discussed these are the 5 symptoms. According to DSM-5, out of these 5, at least 2 or more symptoms should be present. But there is a catch, that out of the 2, at least first, 1 symptom should be from first 3. पहले 3 symptom कौन से हैं? Delusion, hallucination and disorganized speech. And what is the duration according to DSM-5 for making a diagnosis of schizophrenia? Anybody can tell me what is the duration? What is the duration? It is 6 months. So remember, the duration in DSM-5 is 6 months. For ICD-11, what is the duration in ICD-11? For ICD-11, it is 1 month. Okay, remember. If nothing is mentioned, you can follow with DSM. If they particularly ask according to what, then you can answer accordingly. I hope this is clear. This is how we make a diagnosis of schizophrenia. Now let me go back to that question. I hope all of us now know how to make a diagnosis of schizophrenia. In fact, can you appreciate this question? We have discussed duration यहाँ पे है 10 years. So it is of course more than 6 months, isn't it? So this is how we make the diagnosis. Now let's come back to the question which we were now discussing. See this. A patient since 3 months believe that his daughter wanted to kill him. Can you tell me the diagnosis here? First tell me what is the symptom. Which symptom can you see here? Patient को लग रहा है कि my daughter wants to kill me. Can you tell me what symptom is it? This is delusion of persecution. So patient has only delusion. If a patient has only delusion, can you make a diagnosis of schizophrenia? Yes or no? You will say no, sir. For making a diagnosis, at least 2 symptoms should be present. Okay. So please remember, at least 2 symptoms should be present. Now see here. So I cannot call it schizophrenia. The answer here is, it is delusional disorder. Very, very important. It is delusional disorder. But even if the duration, let me make it 6 months. Let me make it 7 months. Don't worry about the duration here. Because here, please remember, patient is only having delusion. If you are saying, sir, I am not making a diagnosis of schizophrenia based on duration, no. I am not making a diagnosis because only delusions are present. So if patient has only delusion, see this, then we call it as delusional disorder. So in delusional disorder, patient has 1 or more delusion, but only delusion. Hallucinations are absent or they are transient. Matlab, hallucinations are present for very less duration, maybe for few hours, or they are absent. Because अगर hallucination भी prominent हो गई, तो मेरा diagnosis change हो जाएगा. It can be schizophrenia, it can be acute psychosis depending on the duration. One more important point, beta, functioning. Please remember. देखो schizophrenia में we see that functioning is impaired. Patient की social functioning, occupational functioning, उसका self care decline हो जाएगा. But in delusional disorder, usually you will see that there is not significant decline in the functioning. So they may tell you in the question that this patient is going to the office regularly, meeting other people regularly, but is afraid of the daughter. So can you appreciate only one area of the life may be affected, which is related with the delusion. So this is again giving you a hint that this is delusional disorder. I hope this is clear to everyone. And we have already covered कि acute psychosis क्या होता है. If the symptoms are less than the duration of schizophrenia, then we'll call it acute psychosis. Okay, so these are some important psychotic disorders. Let's discuss the last point because this was asked in NEET PG exam. Let's see this. an interesting question. They had asked risk factor for delusional disorder are all except. Now very interestingly, you know, when we talk about schizophrenia, we say early onset, early age of onset. Somebody developing schizophrenia in their 10s or 20s usually carry poor prognosis. But in delusional disorder, remember, advanced age, remember this point, advanced age is a risk factor. Social isolation, if he is isolated socially, is a risk factor. Recent immigration to a new land, yes. If there is sensory deprivation, he is not able to see, that also can eventually lead to delusional disorder. So the answer here is, it is not early age, it is the advanced age which is a risk factor. So I am trying to discuss PYQs also so that you get a good idea about how the questions have been asked. Okay. So we have talked about psychotic disorders. Let's now discuss about mood disorder. Again, it's a PYQ. See this question. You know, that is why I am saying they are framing new questions, but the concepts are very similar. If you know the concept, you will be able to solve. See, what is the answer here? A patient is diagnosed with MDD. What is MDD? Major depressive disorder or depression, you can say. What is the key feature of depression? But always remember, when I talk about mood disorder का मतलब है there will be abnormality of mood. Now abnormality of mood can be patient is sad or patient is very happy without any reason. Based on these abnormalities, we have divided the disorders into, one is the mood is always sad, and another is when the mood is sometimes happy, sometimes sad. When the mood is always sad, what are these disorders known as? Very good. It is known as depression. Depression. Can you appreciate here? Sometimes patient may just have one episode, or sometimes patient may have more episodes, 2, 3 or many episodes. If he is having again and again depression, then we call it as recurrent depressive disorder. It is depression only. But if it 2 or more episodes, so this is depression. Here can you appreciate, sometimes the mood is sad, sometimes the mood is very happy. Patient without any reason is happy and other symptoms. So this in fact is known as mania or hypomania. So can you appreciate kabhi khushi kabhi gum? This is bipolar disorder. So remember, this is bipolar disorder. Can you appreciate why we are calling it bipolar? Because symptoms are present on both the poles. Also appreciate this, in between the patient is normal. So, you know, many a time you will see these are episodic illnesses. Okay. So, this is the basic concept of mood disorder. I hope this is clear to everyone. We say the minimum is 2 months. Minimum gap is 2 months, beta. For at least 2 months, more than 2 months, patient should be normal. Then only I will consider it as a new episode. Okay. I hope this is clear. So, let me come to first this depression. You know, again I will talk about, when we talk about depression, we always use this mnemonic. Remember the symptoms, SIGE caps. So you can remember the diagnosis. I hope all of us know this mnemonic, SIGE caps. So what are the symptoms? Sad mood. Always remember, it's a mood disorder, sad mood. Interest is decreased. What do you call it when the interest is low? That is anhedonia. Decreased interest, anhedonia. Remember, patient has anhedonia. Guilt. Patient may report of excessive guilt, negative views about self. Energy is low. Patient says, sir, आजकल मेरी energy बड़ी low हो जाती है. बैठे बैठे I get tired. Easy fatigability. Concentration is poor. What is the effect when the concentration is poor? Patient हमारे पास आता है, says, sir, I am forgetting things. Not able to remember. So patient may come to us with pseudo dementia. This question in fact was asked. Pseudo dementia is seen in depression, not in Alzheimer disease, not in other dementia. It is seen in depression. Appetite, again patient में से appetite decrease हो जाता है, जिससे मेरा weight भी decrease हो जाता है. But sometimes patient may also report opposite. Sir, nowadays I am eating a lot, my weight is increasing. You know, sometimes when we are very upset, we go in the kitchen, start eating whatever is present, है ना? We do emotional eating. So usually appetite decrease होता है, but it can increase also. Psychomotor activity reduces. Patient talks very slowly, walks very slowly. But कभी कभी ये increase भी हो सकता है. Sometimes you will see patient in depression is very hyperactive, is very agitated. Sleep, very interesting. Patient says, sir, I am not able to sleep, insomnia हो गया. But some patient may also say that I am sleeping a lot, even in the daytime. Patient, last S is suicidal thoughts. Patient may say, sir, I am having thoughts to harm myself. So these are the symptoms of depression. But what is the duration to make a diagnosis of depression? Tell me the duration. The duration is, it is 2 weeks. So these symptoms should be present for 2 weeks. And the catch is, please remember the criteria. Let us say ये first symptom है, let us say ये second symptom है. So out of the first 2 symptoms at least 1 should be present, plus there should be 4 or more symptoms. Please see this. This is how we make the diagnosis. So if I now ask you which is the key feature, देखो from this table only that question was framed. If I ask you which is the key feature of depression, what will you say? You will say, sir, 1 and 2 are key features, but both were given in the option. See this, both were given, decrease interest भी दिया हुआ है और low mood भी दिया हुआ है. So then what will you choose? You know, I said na that it is a mood disorder, so please remember mood abnormality is a very important point. So remember, यहाँ पे answer है, it is low mood. If low mood is not given in the option, then I'll go with decrease interest. I hope this is clear to everyone. This is how we will answer such questions. Now see this question. This is a repeatedly asked question in all the exams. Let's talk about some specifiers. Okay, so what we are going to do is, we have made a diagnosis of depression and also we know what is RDD. RDD is recurrent depressive disorder if a patient has 2 or more episodes, right? This question has also been asked recently. A patient currently has depression, previously had a depressive episode, diagnosis. Better answer क्या होगा? Recurrent depressive disorder. I hope this is clear. Answer this question. A woman would get anxious mood swings with occasional sleep disturbance, weeping episodes after birth of the child after 5 days post delivery. So after delivery, patient has developed some symptoms. What is the likely diagnosis here? Can anybody tell me? Very good. It is postpartum blues. Please see this table, very important table again. I am highlighting this. Let's talk about postpartum blues. देखो blues, you know, when you see in the movie somebody had a breakup, you know hear the song in the background, feeling blue, feeling blue. So blue means sadness. It may be seen, look at this, up to 80% of the females after delivery may experience this. So it is common. Okay. Onset may occur 3 to 5 days after the delivery and it may last for days to weeks. See this. This basically is transient and mild symptoms. So patient has transient mild mood disturbance like there is sadness, tearfulness, decreased sleep. What do you mean by transient? Transient means the patient will, you know, have spontaneous recovery. Would you like to treat this patient? क्या हमें treat करना चाहिए? Please remember, only supportive care, no specific treatment. No specific treatment is required. I hope this is clear. Postpartum depression, look at this. Postpartum depression, again it is seen in 10 to 15% of the females, you know, after, during pregnancy or after delivery. Onset within 6 weeks after delivery or during pregnancy, patient has depression. How will you differentiate blues from depression? Look for these more symptoms, serious symptoms like suicidal thoughts, excessive guilt, anhedonia. You know, in fact, this question was asked. You know, 3 weeks after the delivery, patient reports of sad mood, decreased interest, suicidal thoughts. So patient has developed suicidal thoughts. I am thinking of postpartum depression. I hope this is clear to everyone. Now, would you like to treat this patient? Yes, you will say, yes sir, I'll treat. So we have options, we have drugs like SSRI we'll discuss, we can use therapy like CBT. Now there are some new drugs which I want you to remember, which are approved only for this condition. Which condition? Postpartum depression. So these are GABA A modulators. So two GABA A modulators, remember, one is brexanolone, another is zuranolone. Both are nolone. Remember, brexanolone is a IV drug, very important. Zuranolone is a oral drug, very important. Again, new drug I am highlighting. It's a oral drug which is approved for postpartum depression. So they have asked plenty of questions from these two topics. Let's also finish this since we are discussing psychiatry and pregnancy. Let's talk about postpartum psychosis. This is even less common. It is seen in 1 to 2 per 1000 childbirths. देखो, postpartum psychosis. Psychosis means patient has developed delusions, hallucination. So patient may start with vague symptoms like irritability, sleep problem, but eventually patient develops delusions, hallucinations, which may be related with the baby. Patient may say, I have not delivered any baby. This baby is not mine. This baby is possessed. Or patient may say, I am hearing voices telling me to kill the baby. So patient may have delusions, hallucinations, which may be related to the baby. You are thinking of postpartum psychosis. Very good. Now, how will you treat this? How will you treat this? Again, you know, patient has developed psychotic symptom, we can use antipsychotic. Also remember, mood stabilizer lithium is also found to be useful in this condition. So please remember this table. Again, sometimes you may be asked new questions. Also remember these new drugs. Sometimes from pharma side you may be asked questions like this. I hope this is clear to everyone. Very good, right? Now let's talk about one point, about there are so many theories. We know in the neurotransmitter theory for depression, we know there is decrease of serotonin, decrease of norepinephrine. That is why in many of the drugs, antidepressants, we are increasing them. Also even dopamine is reduced. Now there is one cognitive theory, again I am discussing this because last year INI-CET mein question was asked. Cognition means thinking. Cognitive theory of depression was basically given by Aaron Beck, and he said that what is happening in depression, patient develops cognitive distortions. These are basically automatic negative thoughts. Patient says, sir, बिना किसी reason, without any reason, my mind में automatically negative thoughts आ रहे हैं. All of us have automatic thoughts in our mind, but sometimes, in depression, these are negative automatic thoughts. In fact, you can appreciate we use CBT in the therapy. So in CBT, what we do, we identify these negative thoughts and we try to correct these cognitive distortions. So remember, this is cognitive theory of depression. Aaron Beck also gave a triad known as cognitive triad of depression. Okay, triad of depression. Please remember, in cognitive triad, patient may develop negative views about self, इसे कहते हैं worthlessness, sir I am worth nothing. Patient may develop negative views about the environment, sir nobody can help me, helplessness. Or negative views about the future, sir nobody, future is very dark, kal ho na ho, kal kisne dekha, future is very dark, hopelessness. In fact, very important, again hopelessness is a very important, when we talk about the risk factors for suicide, hopelessness is a very important risk factor, in suicide. So please remember, this is the cognitive theory of depression. Very good. So Beck theory is, cognitive theory is different and cognitive triad, both are given by Aaron Beck. This is the cognitive triad of depression. I hope this is clear to everyone. Now let's talk about some drugs. Now in the treatment we have drugs and we have therapy. Remember, for depression we have drugs and also we have therapy. Now in the treatment of drugs, antidepressant, the drug of choice are SSRIs. Please remember some of these names. In the question usually they will give you these names. They will not mention SSRIs. Selective serotonin reuptake inhibitor like sertraline. Many times they give this drug, fluoxetine, paroxetine, citalopram, escitalopram, even vilazodone. Vilazodone is in fact serotonin partial agonist also and reuptake inhibitor. It is a SPARI drug. If I ask you, we are saying that these are drug of choice. Why they are the drug of choice? Because are they most effective? No. Because they have less side effects. But still they have certain side effects. Let's discuss side effects. अगर मैं आपसे पूछूं most common side effect of these SSRIs, tell me most common side effect. Beta, we'll try to wrap up before 4 because I want to cover all the topics, so that when you're revising, some of the important topics we have covered. Okay, right? I hope this is clear. Drugs, again, try to solve more questions, do Q banks, and then come back to the theory and you will be able to remember drugs. The only thing is you have to again practice question and come back to the theory and you will remember. Practice many times, you will remember the name. Very good. GI side effects like nausea, this is one side effect we write for all the drugs, nausea, vomiting. Sometimes even for antiemetic drugs we write the side effect, right? So yes, nausea, diarrhea, constipation. Again, yes, diarrhea can occur and constipation, especially drugs like paroxetine, they can cause constipation also. Even vomiting can occur. Dry mouth, this question has been asked twice in the INI-CET, in the AIMS exams. They'd asked escitalopram, which is a SSRI, causes dry mouth or sialorrhea. So please remember, sometimes questions from this have been asked. If I ask you most common long-term side effect with SSRI, so if I am giving SSRI for a long duration, which is the most common side effect which can occur? Can you tell me which is that side effect? Please remember, it is the sexual side effects like decreased libido, delayed ejaculation. In fact, we'll use this side effect of delayed ejaculation when we'll talk about treatment of PME, premature ejaculation. Patient may also report of vivid dreams. Patient says, sir, since this drug has started, I am getting very vivid dreams. बड़े अजीब सपने आ रहे हैं. Sweating can occur. Even hyponatremia, especially in elderly, especially with drugs like escitalopram. So remember, you may see even hyponatremia can occur. Since they are asking so many questions on pregnancy and psychiatry, let me ask you one question. The question is, can I give SSRIs in pregnancy? We can weigh the risk and benefit, and many times we can give, but there is one drug which is contraindicated in pregnancy. Can anybody tell me which is that drug? Again, this may come as a, as a potential new question. Which important SSRI I will avoid giving in pregnancy? Remember, P for pregnancy, P for, which is the drug I am talking about? Anybody? It is paroxetine. Very good. So SSRIs are one important, drug. They are the drug of choice. Sometimes questions are simply asked. Patient has depression. MDD has been diagnosed. Which drug psychiatrist has started? So maybe they're just asking you the drug of choice, and one of the option would be a SSRI. So this is how you have to answer the question. Let's talk about some other antidepressant. So we discussed even the norepinephrine is reduced. So remember SNRIs. So SNRIs very important. Again, at least remember these three names: venlafaxine, desvenlafaxine, duloxetine. Also there is milnacipran and levomilnacipran. The side effects again are similar. Side effects are similar to SSRIs. One more side effect for venlafaxine you can remember, it can cause even hypertension, especially at higher doses. One more important antidepressant which we will discuss is the NDRI. What is NDRI? We discussed even dopamine भी effect होता है, तो NDRI क्या है? Norepinephrine dopamine reuptake inhibitor. One important drug in this category is bupropion. This is one of the drugs they have asked multiple times. We have been saying that the antidepressants which we use, they may cause sexual side effects. So question ये आता है, a patient on on an antidepressant who was diagnosed with depression develops sexual side effects. Which drug now the patient should be switched to? So which is the drug? Vivid dreams? Again, different mechanisms are there. Different mechanisms. Remember, for bupropion, one important point is it has low risk of sexual dysfunction. So this has been asked. Key patient on an antidepressant has developed sexual side effect. Which drug now he can be switched to? Bupropion is one of the option. And one more option, again, you read in pharma also, one more drug which again has an antidepressant has less sexual side effect, starting with M, it is mirtazapine. So again, both these drugs have been asked. So please remember. Now bupropion, I also want you to remember one side effect. We have discussed S for sexual dysfunction are less. But one side effect, remember, seizures can occur especially at higher doses. So let's discuss a potential new question. I'll discuss this question again in the end. Can you tell me any psychiatric condition in which I will avoid giving bupropion? Anybody? So you will say, sir, any condition in which the risk of seizure will increase in psychiatry I will avoid? So very good. Remember B for bupropion, very good. B for bulimia nervosa. In bulimia nervosa, patient is eating and patient is doing self-induced vomiting or compensatory behavior. So electrolyte imbalance say seizure risk can increase. You give bupropion, he may develop seizure. Even in anorexia nervosa also, patient is not eating much. Again, electrolyte imbalance is there, patient may develop. There is a risk of seizure, and you give bupropion, seizure may develop. So again, remember this, very, very important. Let's discuss one more important topic in antidepressant. Again, you will see so many questions being asked from this topic. A patient on antidepressant presents with altered sensorium. There is hypotension. ECG shows QRS complex, wide QRS complex. Can you identify? Very good. Can you identify which antidepressant toxicity we are talking about? This is again very, very important. We are talking about TCA toxicity. Very good. So please see this. In TCA toxicity, questions have been asked also on the manifestation. So we get CNS effects, CVS and ANS. In CNS, patient may have seizures, convulsions, coma, confusion may occur. Remember, in CVS, patient may have arrhythmias because of sodium channel blockage. There may be widened QRS complexes. ANS, patient may have dry mouth. This has been asked. Is it hypo or hyperthermia? Remember, it is hyperthermia. Tell me in TCA toxicity, it is meiosis or mydriasis? Again, this has been asked. What is it? Meiosis or mydriasis? Tell me. It is, remember, it is mydriasis. I'll in fact discuss some substances also. TCA toxicity mein there is mydriasis. Also, I'll discuss some substance which can cause mydriasis. Very, very important. Now, in TCA toxicity, patient develops acidosis. So, what is the treatment? We do alkalization by sodium bicarbonate. Very, very important. Of course, we also monitor ECG. If there is any drug which is not absorbed, we can also remove it by activated charcoal. So, please remember. Let's come back to this question. So, can you appreciate patient is here having TCA toxicity? So, here the treatment is sodium bicarbonate. I hope this is clear to everyone. let us discuss a potential new question. You know, since they've asked so many times question on TCA toxicity, let's discuss this question. Which of the following is least useful in TCA toxicity? You know, whenever you get such new question, don't worry. Always go back to the basics and try to answer such questions. Can you tell me what is the right answer here? Diazepam, sodium bicarbonate, you will say, sir, we know, we use it. Is diazepam having any role? Yes, you will say, sir, what if patient has seizure? Lidocaine, what if patient has arrhythmia? Very good. Dekho, please remember, you know, you also read this in pharma, you know, drugs like amitriptyline, which is a TCA, you know, they have high volume of distribution. In those drugs, hemodialysis, you know, in the toxicity, hemodialysis does not have much role. In fact, we'll talk about one important toxicity in the end, where hemodialysis is useful. Can you tell me which toxicity I am talking about, which mood stabilizer toxicity we'll discuss? Lithium, very good. Lithium toxicity may we'll discuss that yes, it has, hemodialysis has a role. Very good. Now let's complete this. A patient is taking MAO inhibitor. This has been asked so many times, this question. Patient is taking MAO inhibitor and he eats tyramine rich food such as cheese, such as red wine. Can you tell me what happens? What happens? What is this reaction known as? Very good. What is the reaction? Yes, this is known as cheese reaction. You know, suddenly there is increase in the blood pressure, hypertensive crisis. So this is very good. This question has been again asked and asked repeatedly. Remember, MAO inhibitors, if tyramine rich food is consumed, it can cause cheese reaction. Trazodone, this side effect was again asked clinically in one of the INI-CET question. Patient comes to the emergency with painful prolonged erection. Which drug the patient is on? Very good. Yes, yes, Avinash, we will use drugs like phentolamine. Yes, alpha antagonist. Can you tell me what is important side effect? It is priapism. So can you appreciate these are all very simple one-liners which nowadays they are, you know, framing as clinical questions. Very good. So many of these points we have covered. Lastly, also remember this. This was in fact asked recently. A patient is taking, you know, SSRI sertraline, and on the top of it even amitriptyline was added. So he was taking sertraline and amitriptyline was added and he developed serotonin toxicity. So can you appreciate this is in fact known as serotonin syndrome. Now many times you will see, you know, NMS may, when you will see NMS you will also see similar symptoms. Here also there may be increase in temperature, there may be rigidity. You know, you will see, you know, again such patients in emergency, you know, you will see, you know, these are some emergency situation, but in the question you will see, in NMS you will see that there is dopamine antagonist drugs. Here you will see drugs which are increasing serotonin, serotonergic drugs. You will see the history and you will try to then see. Also very important, when you see serotonin toxicity, you will see, you know, symptoms, GI symptoms like patient is having diarrhea. Also, you know, they will give you symptom like myoclonus. So this is again giving you hints towards serotonin toxicity. Can you tell me what is the treatment? Serotonin is increased to a toxic level. We will use serotonin antagonist, 5S2 antagonist, cyproheptadine. Okay, so remember here the answer is cyproheptadine. Again, it's a PYQ which was asked recently. Please be very careful. Now, one new drug I just want you to remember, it's an antidepressant which has been approved. You know, one of the latest antidepressant to get approved is Gepiron. Again, just simply remember the name Gepiron. It is ending with 1. So what is the mechanism of action? Remember, it is a partial agonist at 5-HT1A. Gepiron ending with 1 na. So remember, it is acting on 1A. Just remember. Also you can remember, you know, when we are giving Gepiron ECG, again you can remember it like this. ECG is also done because, you know, it is notorious to increase the QT interval. In fact, it is contraindicated if the QTC interval is prolonged. Okay, so just remember Gepiron and remember ending with 1 and in the beginning you can just remember ECG. Okay, so that is done when we are giving this drug. I hope this is clear to everyone. Yes, there are some other drugs. Yes, yes, very good. Esketamine is also there. Yes. Now let's talk about, we have talked about some important points. Also we have discussed in the management treatment may for therapy it is CBT. If it is asked what is the treatment of choice, remember it will be combination SSRI plus minus CBT. So if combination is given, better answer will be treatment of choice will be combination, but if it is given separate option then you will go with drugs. But if they ask you for mild depression, this has been asked previously, mild depression mein kya karenge? Remember, if I have drugs also and if I have therapy also and if they ask us mild depression ka treatment, then I may choose CBT. For mild depression I may start with CBT. Otherwise, treatment of choice is combination, but if you are asked to choose out of them one only, then you can go with SSR. I hope this is clear because all these have been asked previously. So we have covered depression. Let's now talk about bipolar disorder. Now in bipolar disorder, as we discussed, patient may have depression and patient may have episodes of mania, hypomania. Let's discuss what is mania, what is hypomania. Already we know what is depression. Now to remember the symptoms of mania, you can just remember the mnemonic. So again a very simple mnemonic, remember me, dig, fast. So person is doing something really fast. So remember the mnemonic, yes. ECT we can use again in depression. In depression we can use ECT for one very important indication if the patient is having suicidal thoughts. This is very important. So patient with depression comes to us with suicidal thoughts. Then if you are asked, then for MCQs you can prefer ECT. Please remember, even if the patient is pregnant, sometimes they may just add pregnancy somewhere in the question. Then also don't worry, even in pregnancy we can give ECT. So please remember, for suicidal thoughts if they ask you preferred treatment, then you can go with ECT. Yes, correct, very good. So patient with mania, again first, I always say it's a mood disorder, so first symptom will be mood. Patient's mood is elevated, is very happy. Sometimes patient may be very irritable. Irritable, generally if they have to tell you that patient mood is irritable, they may use this term dysphoric. So if I say patient ko dysphoric mania hai, remember that means mood is irritable. E is energy. Energy levels are also very high. Mood is high, energy is high. Patient may also have distractibility. You're talking to the patient, he gets distracted, his attention goes there. Suddenly his attention goes there. So the patient is very distractible. Patient is very impulsive. So, patient may do things without considering the consequences. So patient may spend a lot. There is this increase in the spending, overspending. Father says 10 lakh rupees were there 10 days ago, now there is 0. Patient may have increase in socialization. So many things he may do without thinking of the consequences. There may also be increase in the sexual activity. G is grandiosity. I am not talking about delusion of grandiosity. Grandiosity here means patient has high self-esteem. So patient goes to the office, tells the boss, you get up from here. You don't know anything, now I will manage the office. So there is inflated self-esteem. F is flight of ideas, we have discussed, thoughts are coming very fast. Patient activity levels are increased. He will not sitting at one place, continuously moving around. Sleep, there is decrease, need for sleep. Patient says sleep is a waste of time. Who requires sleep? So there is a decreased need for sleep, and there is talkativeness. Yes, very good. So these are the symptoms. Now what is the duration? Remember, यहाँ पे duration है 1 week. So symptoms are present for at least 1 week. And the criteria is, let us say this is first symptom, this is second symptom, 1 plus 2. So both the first 2 symptoms are present plus 3 or more of the remaining symptoms if present for at least 1 week or 7 days, then we say it is mania. Sometimes patient with mania may also develop delusions or hallucination. So that is known as mania with psychotic symptoms. Patient may develop delusions like delusion of grandiosity. I am the king of the world. But remember, any delusion can occur. Patient may develop hallucination. Patient may say, me and God are in direct connection. We talk to each other every day. But if you talk to God, it is normal. But if God starts talking back, maybe something abnormal has started. So hallucinations may also occur. So remember, even with mania, patient may develop delusions and hallucination. Yes, symptoms should be present for at least 1 week. Then I'll make a diagnosis of mania. I hope this is clear to everyone. Now then, what is hypomania? Hypomania is when the symptoms are less than mania. So symptoms are similar to mania, but they are not severe. That means they does not cause significant impairment in functioning. Now this is very interesting. So patient, they will give you in the question that symptoms are similar, but how will you choose hypomania? They will say in the question that patient is going to the office, he is doing all the things, maybe more than usual. So they are trying to tell you that functional impairment is not marked. Then I will think of hypomania. And for making the diagnosis of hypomania, the duration is also less, at least 4 days. Also remember, very good. Also remember, in hypomania, you will never get psychotic symptoms. Patient को psychotic symptoms अगर develop हो गए हैं, then it will be mania, not hypomania. There will be no need for hospitalization. If patient is hospitalized, I'll go with the diagnosis of mania. Can you appreciate out of all these symptoms we discussed, na, flight of ideas is usually seen in mania and not hypomania. So again, flight of ideas is usually not seen in hypomania. So again, I've just told you some important points also. You know, any of these points, functional impairment is not marked and these symptoms usually are not seen in hypomania. Will you be able to now make a diagnosis of mania and hypomania? Let's see this question now. You know, again, you'll see this question has been asked previously and very important concept they have tested in this question. A 30-year-old patient diagnosed with depression was started on imipramine. What is imipramine? Imipramine we know is a TCA. It's an antidepressant. The treatment was given for 2 weeks. After that, the relatives noticed that patient developed new symptoms like patient is very cheerful, there is increased excitement, wearing colorful clothes, increased talking. What is the next important line of treatment? Can you tell me what is the answer here? So please appreciate this. In fact, there was also that she is a female. Even if that is not mentioned, but that was mentioned, let us say. So please see this. What has happened? Patient was having depression. I have given antidepressant. Now can you say that patient has developed symptoms of mania, hypomania? So when we talk about the treatment of mania or hypomania, we have 3 first line drugs. We have antipsychotic, lithium and valproate. We know lithium and valproate are mood stabilizers. Now before starting any drug, but can anybody tell me what we will use? What we will do? Can anybody tell me what is the first step? Before starting any of these drugs, what I will do? This patient is on antidepressant. What will antidepressant do? They will elevate the mood. Mood तो already too much elevated hai. My first step always remember will be to stop antidepressant. Please remember this. Okay. Now, which drug to start? You know, I can use any of these drugs, but if they ask you, you know, which is the drug of choice? Again, you know, we say all these 3 are first line, but you have to choose one, then you can go with antipsychotics. Okay. So remember antipsychotics. Also remember, valproate is one of the drugs, you know, which we avoid in women of child, you know, bearing age, you know, because it can cause PCOD. So please remember, in this situation, better answer will be, so what we will do, we will stop imipramine, which is in both option. One option is start antipsychotic, one option is add sodium valproate. Better answer will be stop imipramine and start antipsychotic. I hope this is clear. So this one question is testing 2 important concepts. I hope this is clear. Now also let us say now the patient is pregnant. A patient is pregnant and a patient has developed mania, hypomania. If I have to give drug, can you tell me which is the preferred drug now? Please be very careful. They are asking again a lot of questions related with pregnancy and psychiatry. Again the order is antipsychotics are preferred. Then we, you know, if antipsychotic is not in the option, then I may choose lithium, but remember lithium is teratogenic. It can cause Epstein anomaly. And I'll try to avoid valproate in pregnancy. Can you tell me which is the important teratogenic effect of valproate? Please remember, it is, what is the teratogenic effect of valproate? Very, very important point. Please remember this. It is neural tube defect. Very good. So please remember, okay, again preferred drug in pregnancy when patient has developed mania would be antipsychotic. But I've given you this order as well. I hope this is clear to everyone. Very good. Let's discuss this again, a very small concept last year asked first in FMGE, then it was repeated in INI-CET. So again you will see a lot of topics getting repeated. What is rapid cycling bipolar disorder? So in bipolar disorder, when we say it is rapid cycling, rapid means very fast, cycling means up and down. So if a patient has developed 4 or more episodes of depression, mania, hypomania in 1 year, can you appreciate this is 1 year duration and patient has developed at least 4 such episodes. So I'll call it rapid cycling bipolar disorder. So this question has been asked, you know, previously in FMG. This year the question was asked, what is the treatment? Again remember, for rapid cycling, one of the preferred treatment is valproate. Very good. It is valproate. Even lamotrigine is one of the drugs, you know, again it is a, you know, again mood stabilizer which can also be used. And in fact, remember lamotrigine, if you ask about relative safety in pregnancy, it is relatively safer than lithium. Also this question has been asked, that in pregnancy which drug you will avoid if valproate is not in the option, lamotrigine and lithium is given in pregnancy. So again we may prefer lamotrigine. Okay, so again such questions have been asked. Now the question which was asked in the INI-CET exam was, rapid cycling is more in males or females? The risk is more with males or females? Tell me. Yes, carbamazepine can be used, but it is not considered as a first line drug. Yes, it can be used in bipolar disorder, but not considered as a first line drug. Yes, it can be used. Please remember, it is more, risk is more in females than male. Again, this question was asked in the question which was asked in INI-CET. In fact, I'll give you this list, some of the risk factors, again I'll attach this list with the PDF. Females, even substance use, patient with bipolar disorder is using substance, that can also increase the risk of rapid cycling. Patient is aggressively taking antidepressant, we know antidepressant can increase, vulnerability towards mania, hypomania. So again, if a patient with bipolar disorder is only taking antidepressant, so then again the risk of rapid cycling may occur. So these are some risk factors. Remember, it is more in females. Now we have talked about treatment in mania. Let's talk about the treatment. Let's briefly talk about treatment of bipolar depression. When I say bipolar depression, can I say that means ki right now patient has depression, but previously patient had episode of mania or hypomania, and I have to treat now this episode. Please remember this one point. Again, they have not asked questions, but if they want to ask new question, they may ask like this. I am saying patient has bipolar depression. Bipolar depression means currently patient has depression, but past mein patient ko kya tha? Mania ya hypomania. Now in this case, please remember, don't give antidepressant alone, because if I give antidepressant alone, remember patient had past episode of mania, hypomania, patient may develop mania, hypomania later on. So please remember, if I have to give antidepressant, I will also add a mood stabilizer. तो जब bipolar disorder में हमने mania, hypomania discuss किया, वहाँ पे हमने कहा था कि अगर antidepressant is there, stop antidepressant. In bipolar depression treatment, I am saying don't give antidepressant alone. If you want to give antidepressant, also add a mood stabilizer. I hope this is clear to everyone. Very good. Now see this question. So we have covered another important topic of mood disorder. Now let's talk about the neurotic disorders. See this question. A 25-year-old female patient is brought with symptoms of anxiety, palpitation. See, this is a recently asked question. Even in your FMGE and INI-CET also they are asking these questions. Patient has anxiety, palpitation, sweating, breathlessness, chest pain, and patient has a feeling of impending doom. Very good. So patient को episodes हो रहे हैं, sudden onset of anxiety, ऐसा लग रहा है I am about to die, and these are occurring 5 to 6 in a month, lasting for 30 minutes. Classically, yes, very good. This is a case of, it is not GAD. GAD में क्या होगा? Anxiety will be consistently present, persistently present. It is panic disorder. Very good. Let's now talk about some important anxiety disorders. Now there are 5 anxiety disorders which we will discuss, and in this one table only we can cover all. First is panic disorder. Can you appreciate in panic disorder? Sudden onset of intense anxiety है, patient कह रहे हैं अचानक से, unexpected, मुझे anxiety हो रही है. So there is palpitation, there is breathlessness, chest pain, and very important, there is a feeling of impending doom. Patient says, I feel I am about to die. Very good. Tell me, panic attacks, are they dependent on a situation or they are unexpected? Very important. Tell me. Remember, these are unexpected. Patient says, sir, I don't know, without any reason, they can occur in any situation. So one attack came when I was in my office. Another attack came when I was at my home. Another attack came when I was at my car. Can you appreciate? They are occurring anytime, anywhere. Unexpected. And what is happening in between? Can you see in between the patient is absolutely normal? This is how a patient has panic disorder. Now, second category you can remember, phobias. Phobia means they are situational anxiety. So if a situation comes, there will be anxiety. No situation, no anxiety. So here 3 disorders we will discuss: agoraphobia, specific phobia, and social phobia. So can you appreciate, let us say these red dots are situation. जब भी situation है, there is anxiety, situation goes, anxiety goes. In between patient is normal. So we will discuss the phobia. So अगर question में patient is having anxiety in a situation, then you have to think of these disorders. All these 4 anxiety disorders, can I say they are episodic? They are, panic disorder is unexpected, but they are occurring in situation, but all the 4 are, they are occurring in a particular situation. Lastly, there is GAD, but as the name suggests, generalized anxiety disorder. Now patient has persistent anxiety. This is also known as free floating anxiety. This is also known as free floating anxiety. One key feature here in generalized anxiety disorder is excessive worries. Please highlight this. Patient says, I am worried about small daily things. My husband is late from office, oh my god. What if his accident has occurred? My children are late from school, oh my god. What if somebody have kidnapped them? So patient को small worries हैं about day to day things consistently. Can you appreciate? यहाँ पे anxiety is lesser but it is consistently present. ये है generalized anxiety disorder. Patient may even have somatic symptoms like headache, tingling sensation. Those may also be there. I hope this is clear to everyone. Patient has this excessive worries. Very good. So I hope this is clear to everyone. No, PTSD I'll discuss separately, but a PTSD has occurred because of some trauma. We'll discuss it separately. So these are the 5 anxiety disorder. Let us see this question. Dekho, I talked about a very old classification in psychiatry. Now you will appreciate the use. Dekho, let's try to see this question again. You'll see they are framing newer questions. Please be prepared. This time NEET PG 24, so many interesting new questions they had framed. So please be very careful. Dekho, please first make a diagnosis. A 45-year-old female comes to the OPD complaining feeling tensed and having stomach upset with heartburn and diarrhea. She reports these symptoms since many years. So can I say that patient is having a generalized anxiety disorder? Always she feels tensed. She is having GAD. She reports her family members usually feel tensed, also nervous. So this can occur. Many times we see that genetic factors are there. Family members may also have some similar symptoms. Which of the following symptom is likely seen in the patient? Dekho, we know GAD, tell me, is a neurotic disorder or a psychotic disorder. You will say, sir, it is a neurotic disorder, right? Dekho, ideas of reference, they are, delusion of reference क्या होता है? When it's a fixed belief. Ideas of reference में क्या है? The belief is not fixed to a, very high level. So in ideas of reference, patient may say, I think people are talking about me. Okay. Again, it is not a psychotic disorder, hallucination are not seen. Neologism again will be seen in condition like schizophrenia. So here we discussed now patient can have somatic symptoms, so this was the answer. So if you know it's a neurotic disorder, you can solve such questions. So please be very careful. I am again saying, नए questions आते हैं, don't worry. Think of the diagnosis and then try to answer the question, and the question, answer will be easy. देखो आपने rule out कर दिए बाकी सारे options, you can see many of these you'll see in psychotic disorder. So we have come to the answer. Now we were talking about the 3 phobias. Let's discuss them as well. देखो agoraphobia में ना, I want you to remember a very important point. Patient has fear in situations where escape is difficult. DSM-5 has added 5 situations. The important catch point is, which was asked in FMGE once, anxiety should occur in 2 or more situations. क्या situations है? Patient को public transport में, जैसे bus में, train में, plane में anxiety है. In open spaces like big park, parking lot, he has anxiety. Closed spaces like lift, he has anxiety. In crowd or standing in a line. Or patient says, I cannot go alone outside, I have anxiety. So can you appreciate, if patient has anxiety in 2 or more of these situations, then we call it agoraphobia. The question which was asked was, a patient has anxiety in using a lift. He cannot use a lift. Diagnosis. Tell me, will you mark agoraphobia as the answer, yes or no? Just tell me yes or no. Tell me yes or no. Will you mark agoraphobia as the answer, yes or no? Very good. You will not mark agoraphobia. You will say, sir, it is specific phobia, like claustrophobia. उस ऑप्शन में एक ऑप्शन था स्पेसिफिक फोबिया का, तो प्लीज़ रिमेंबर वहाँ बेटर आंसर था स्पेसिफिक फोबिया. स्पेसिफिक फोबिया का मतलब है इरैशनल फियर ऑफ ऑब्जेक्ट या सिचुएशन. किसी भी ऑब्जेक्ट या सिचुएशन से इरैशनल फियर है. तो प्लीज़ रिमेंबर सम ऑफ दीज नेम्स, दे हैव बीन आस्किंग दीज नेम्स. व्हाट इज एलियोरोफोबिया? फियर ऑफ कैट्स. एक्रोफोबिया वाज आस्क्ड लास्ट ईयर. एक्रोफोबिया, एक्रोबैट्स करते हैं ना स्टंट ऑन हाइट्स. सो एक्रोफोबिया क्या है? It is fear of heights. Claustrophobia is fear of closed spaces. Nyctophobia, again this was asked in NEET PG. What is nyctophobia? It is fear of darkness or night. Cynophobia is fear of cats. Mysophobia is fear of dirt or germs. देखो xenograft you read in pathology na, xenograft is when it is taken from different species. Xenophobia means fear of strangers. Zoophobia, very simple, fear of animals. Avengers mein there was Thanos na, so Thanos term was taken from Greek god of death. So what is thanatophobia? Fear of death. So I hope you will be able to solve such question. What is arachnophobia? Arachnophobia, fear of spiders. Again such question may be asked. Nomophobia, what is nomophobia? Such new terms are also being asked. No mobile phone phobia. Sometimes you misplace your mobile phone and you are in a anxiety, panicky state, anxiety state, my mobile is not here. So no mobile phone phobia. Okay, so this is specific phobia. Now question they have not asked up till now on social anxiety disorder or social phobia. This may be asked. As the name suggests, the fear is of social situation, but the catch is very important. But the catch is that actually it is not per se fear of situation. The actual fear is, what if I do some activity in that situation that will embarrass me in front of others? What if I go in a wedding and I say something, I blurt out something which will embarrass me? What if I'm eating food, I spill food over my face? It is embarrassing for me. So actually जो fear है वो है fear of doing any activity जिससे मुझे social situation में embarrassment ना हो जाए. तो ये है social anxiety disorder. देखो one more question I will discuss which may come as a potential new question. देखो anxiety disorder usually we say are more common in females or males. Remember, anxiety disorders are more common in females than males, but there is one exception. The exception is this only. Remember, social anxiety disorder या social phobia किसमें ज़्यादा common है, males में या females में? Anybody? Quickly tell me. This point, we always discuss. Tell me quickly. It is more in males or females? No, it is not more in males. It is in fact, remember, equal. In fact, I'll give you a table, especially those who are preparing for INI-CET. I'll give you a table of some important disorders, which are more common in females, which are equal, which are more in males. I'll give you that table. In the end, with the PDF, you will get that table also. Okay. I hope this is clear. So we have discovered one important neurotic disorder, which is the anxiety disorder. Let's discuss the second important neurotic disorder. We'll talk about obsessive compulsive and related disorders. Okay. In fact, this is a new term which has been given in both DSM-5 and ICD-11. देखो DSM-5 और ICD-11 ने क्या किया, बहुत सारे disorders जो बहुत similar थे ना, they have clubbed into one category. So the category term they have named as obsessive compulsive and related disorder. So as the name suggests, देखो पहला disorder तो होगा obsessive compulsive disorder. This is a very important topic. But one more hour and we'll finish. है ना? हाँ, in the last hour. So we are in the end game now. In the last hour, है ना? We'll finish then. ठीक है? I don't want to miss these points because again you will see new questions are being asked. You know the concept, you will be able to solve those questions as well. Okay, I hope this is clear. हाँ. So what are obsession? Very good. We always discuss. Thank you. We always discuss what are obsessions. There are different types of obsessions and we can remember it with the mnemonic ROSY. So remember the mnemonic ROSY. So there are so many types of obsessions. We will discuss with the mnemonic ROSY. So what is ROSY? All these obsessions, we'll talk about. For example, a patient says, sir, I am having repeated thoughts, images or impulses. Sir, मेरे mind में बार-बार thoughts आ रहे हैं that my hands are dirty. So this thought is repetitive 2 hours, 4 hours every day मुझे ये thoughts आ रहे हैं. O means own. Sir, I know these are my own thoughts. Very important is senseless. But please highlight this. One very important point which helps us differentiate obsession from other symptom is senselessness. Patient knows कि ये senseless thoughts हैं. These are wrong thoughts, irrational thoughts. Patient says, sir, look at my hands. My hands are absolutely clean. But ये senseless thoughts बार-बार आ रहे हैं. I want to stop it, but he is not able to. ये irresistible है. So this is a classical example जो मैंने discuss किया of obsession of contamination. ये है obsession, repeated thoughts. What is compulsion then? Compulsion, you will say, sir, compulsion means, person is compelled to do something. So these are repetitive acts. So patient who is having repeated thoughts of contamination, what they may do? they may repeatedly wash the hand, maybe 10 times, 20 times, 40 times, 2 hours, they may wash. So these are repeated acts. Please remember, these acts can be motor acts. देखो, washing hands is a motor act, na, you can see. But sometimes they can even be mental acts. Patient says, sir, when I am having the thoughts that my hands are dirty, I count to 10 in my mind. I read some poem in my mind. So sometimes patient may also do mental acts also, which are not visible from outside. So remember, ये obsessions हैं और ये compulsions हैं. Very good. But I'll discuss a list. This is a very important table. 3-4 questions have been asked just from this table. So let's discuss. Now if I ask you, in obsession, which is the most common obsession, you will say, sir, most common obsession is the example which you have just given, obsession of contamination. In NEET PG, they had asked once, most common obsession. But in that question, contamination was not given as the option. So you also should know second most common. Remember, it is pathological doubts. Patient says, sir, when I go out of the room, I am getting a doubt that whether I have switched off the light or not. These are repetitive doubts. Own thoughts. Patient says, these are senseless. Sir, I remember I have switched off the doubt. You shouldn't switch off the light. But these doubts are coming again and again. A housewife goes out of the kitchen, gets a doubt whether I have turned off the gas knob or not. Then patient may also have, obsession of symmetry or precision. Patient arranges everything symmetrically. If the pen is like this, somebody changes the direction like this, oh my God, symmetry is gone. There may be anxiety. Patient may have aggressive obsession. Sir, I am getting repeated thoughts to slap the person standing in front of me. No, sir, I am not that kind of a person. I don't want to do this. But I am getting these doubts again and again. And these thoughts again and again. Sometimes even sexual thoughts patient may have. Sir, I am getting repeated thoughts to touch the person inappropriately. No, sir, I am not that kind of a person. I don't want to do this. But I am getting these thoughts again and again. But again, if I want to ask a difficult question, what I'll do is, you will read even in forensic, even in psychiatry main videos, we have talked about this topic of paraphilias. In fact, in the last I will discuss about this briefly. Paraphilias mein patient is doing certain behaviors to get sexual gratification. Sometimes they may ask you how to differentiate between sexual obsession and paraphilia like frotteurism. Frotteurism, we read, in frotteurism there is double T, na? T means touching. How will you differentiate a patient having sexual OCD and frotteurism? We know in frotteurism, patient is getting sexual gratification by doing this. But in sexual OCD, the patient knows those are senseless thoughts. So please remember, very, very important, he does not want to do, he wants to resist. But what if he starts touching that other person? So even compulsions can be there. So I hope you will be able to differentiate now. Haan, very good. Frotteurism mein gratification hoga. I am trying to just make some sense if new questions are asked. So please be very careful. Okay? Now remember, compulsion, C for compulsion hai, C for it is checking. Most common is checking. Jisko pathological doubt hai, he may come and check again and again. This is the most common. Second is washing. Dekho, this question was asked in FMGE once, excessive hand washing, and they had given an image of hand washing. Of course, there was no relevance of that image. But please remember, excessive hand washing, तो उसका आंसर था OCD. Patient may do things in counts 10 times, 20 times. He may count things again and again. Patient may start arranging things. A very interesting question was asked in FMG. See the question. 16-year-old female was eating food. देखो, the question that started like they are asking a eating disorder, and one first option was anorexia. But question was a 16-year-old female eating food and she is cutting each meal piece in equal sizes, taking a longer time to eat. Can you tell me the diagnosis? Can you tell me what is the diagnosis? So she is doing something very symmetrically. So the यहाँ पे answer क्या था? OCD. So they may ask question, a person is shaving his beard and he is taking a lot of time, getting a lot of cuts and bruises. He wants to do it symmetrically. Again, answer is OCD. OCD of symmetry and precision. So I hope you will be able to answer questions if new questions are also framed from this table. है ना? बेटा OCPD जो होता है वो अलग है. देखो, OCPD में ना patient will not have these obsessions and compulsions. So very important point, somebody has asked, sir, OCPD, we'll discuss in the end. It's a personality disorder. बेटा OCD में तो obsessions होंगे ना, patient knows ये senseless thoughts हैं. Please remember this. जबकि OCD PD में patient will say that what I am doing is right. These points will help us differentiate. Very, very important. हाँ, very good. Now let's talk about the treatment. Now in the treatment, but again we have ego ego dystonic hota hai OCD, very good. Now in the treatment we have drugs like SSRIs and clomipramine. Clomipramine is the TCA. बेटा both these are first line drugs, but अगर मैं आपसे पूछूं drug of choice, देखो यूजुअली एम्बीवेलेंस एम्बीटेंडेंसी हम देखते हैं. एम्बीवेलेंस आप पढ़ोगे, इट इज़ इन ब्लॉयलर्स 4A's. एम्बीटेंडेंसी you may see it in catatonia, but yes, sometimes patient is in that state of undecisiveness, you can say in a way. So these are the first line drugs, SSRIs and clomipramine. Can anybody tell me what is the drug of choice? First line का मतलब मैं दोनों शुरू कर सकता हूँ. Drug of choice is yes, again SSRIs because of less side effects. There is a concept of augmenting agent. This has been asked twice indirectly in INI-CET. देखो, I have given patient SSRI, there is some improvement. Given clomipramine, some improvement. I want more improvement. So I may add some augmenting agents. Antipsychotics like risperidone, like aripiprazole and even others. What they will do? They will not have their own effect, but they will augment the effects of the first line drugs. But like if I ask you, does antipsychotics have any role in OCD? You will say yes, sir. Not as a main drug, but as a augmenting agent. We can also use, CBT, and one specific CBT which has been, again and again asked, and it is in fact preferred, is ERP, exposure and response prevention. एक patient को obsession of contamination है and he is washing hands again and again. This question in fact was asked. CBT was one option and ERP was one option. Which is a better answer? Better go with more specific answer. ERP, exposure and response prevention. Drug of choice we have discussed. Therapy of choice we have discussed. If I ask you treatment of choice, can anybody tell me what is the treatment of choice for OCD? Anybody, what is the treatment of choice for OCD? It is a combination, remember, drugs plus therapy. देखो, if I want to frame a newer question, the same concept we discussed in depression, mild depression. I may ask you that a very young child has OCD or the symptoms are very mild. Then again, if I ask you what to start, again you may prefer therapy. So please always try to read the question carefully and then try to answer. So you'll see sometimes you will be able to solve the questions. Dekho, we started with this topic now, obsessive compulsive and related disorder. One disorder we have covered is OCD. Let's discuss what are the other disorders which are added here in DSM-5. Similarly, even ICD-11 also has added. So we'll discuss that. Dekho, second is body dysmorphic disorder. Patient has repeated thoughts, preoccupation that there is something abnormal in my appearance. So patient has preoccupation of defect in the appearance. Patient may say, sir, I am getting repeated thoughts, my nose is large or nose is short, ears are large, ears are short. So body में कुछ dysmorphic है, कुछ abnormal morphology है. Next is hoarding. Hoarding disorder means patient is acquiring things, collect कर रहा है, उनको discard नहीं कर रहा. 10 years हो गए, he is collecting all the newspaper. So he is collecting things and he is not ready to discard them. Trichotillomania में he is getting repeated thoughts to pull the hair, he is pulling out the hair. Excoriation disorder, skin picking में he is picking the skin. ठीक है, remember trichotillomania में most common area is scalp and excoriation में most common area is the face. Sometimes such questions may be asked. Very good. देखो, ICD-11 has also made a similar term and they have also added similar disorder. तो पहला तो OCD है, second is BDD, third is hoarding. Now this question was asked in INI-CET that what is included in body focused repetitive behavior disorder. So they have just made one term. So anything which is focusing on the body, repeated behavior. So trichotillomania and excoriation are added in this term. The diagnoses are the same, but they have added in this term. So remember. Also there is a new diagnosis, new term, olfactory reference syndrome. Olfactory means smell. Patient is preoccupied that my body is emitting a smell. But please remember, he is not able to smell it. Because अगर उसको smell आ रही है, then that will be olfactory hallucination. यहाँ पे patient को repeated preoccupations हैं that my body is emitting some bad smell which may be noticed by other. And even hypochondriasis is added here, We'll discuss what is hypochondriasis separately. I hope this point is clear to everyone. This is a very important table. In fact, I'll show you some questions which have been asked. देखो ये last year NEET PG में इसी में से आया topic में से question. See this. A 40-year-old female has visited multiple plastic surgeons requesting correction of face deformity. But she was referred to a psychiatrist. That is telling you that maybe there is actually no deformity. The patient repeatedly checks her face, insists that her face is deformed, needs surgery, despite no evidence on examination. Patient persists with her demand despite reassurances. Can you first tell me the diagnosis? Can you tell me what is the diagnosis here? There is some abnormality in her appearance, she thinks na. The diagnosis is BDD. देखो in BDD management na, one of the treatment is SSRIs. SSRIs have shown very good results in the management of BDD. Also we use therapies like CBT. देखो CBT में what we do is, C means cognition, we change the thinking and the behavior because patient की thinking is also distorted and there is problem in the behavior. So we correct both. Now in the option, देखो atypical antipsychotics से better would be SSRIs, allow for surgery, no. Actually there is no deformity. Okay, now please remember. So this was in fact psychotherapy I've added separately. I'll tell you why. These were the 4 options. देखो out of the 4 options, can you tell me what is the right answer here? देखो it will not be behavior therapy. It will be better answer will be CBT. So here I'll choose SSRI. I'll go with the more preferred answer. यहाँ पे SSRIs I know have shown good result and CBT. Even if psychotherapy may be added, specifically they have not mentioned CBT. So CBT has shown good result. So please remember. So SSRI was the answer here. Okay. So please remember. So this is BDD. You should know how to diagnose and then you should know the treatment. In fact, a very old question has been asked in NEET PG about hoarding disorder. Hoarding disorder also we use CBT, but remember hoarding disorder is difficult to treat. This question was asked again in NEET PG 2019 that a patient, which of the following CBT is less effective? Washing, checking, symmetry and hoarding. So in hoarding usually we see it is difficult to treat. And this question was asked twice in FMGE. A surgeon take out a mass of hair from the stomach of the patient. Can you appreciate this mass of hair is taken the shape of the stomach? So can you tell me what is this? You will say sir this is trichobezoar. एक बार उन्होंने trichobezoar को identify का question पूछा था image के साथ. The question was patients, surgeon has taken out this mass of basically hair, mass of hair from the stomach, where now the patient should be referred to. Can you tell me? हाँ, very good. देखो trichobezoar क्यों हुआ? Because some patient after pulling the hair they may swallow trichophagy. So patient को trichotillomania है, patient should be referred to the psychiatrist. Very very important. So can you appreciate this topic? You'll see some questions being asked. So please be very careful if such questions are asked. Now please see this question. Now this is a newer question which I've made, but try to answer this question. Very good. See this question. A 30-year-old male visiting a foreign country was stuck in an earthquake. He was rescued after 2 days. Can you appreciate the level of stressor here? On returning his homeland now, for 2 months, he reports of getting distressing dreams and flashbacks about the incidents and also avoids going out of the city despite being necessary for his office work. Diagnosis. Tell me, is it acute stress disorder or is it PTSD? Very good. All of you are, most of you in fact have mentioned it correctly. Just tell me why it is not PTSD. Why it is not acute stress disorder. Sorry, it is PTSD only. Just tell me why it is not acute stress disorder. Very good. The answer is PTSD. Just tell me. Very good. Yes, duration. For acute stress disorder, the duration should be less than 1 month. Can you appreciate here? The duration is 2 months. Very good. Let's talk about another important set of neurotic disorder, trauma and stressor related disorder. Now in this, as the name suggests, there will be some trauma after which patient has developed some symptoms. Now depending on the trauma, if it is very severe, like in that case, it was a natural disaster or there is a serious accident, then we can diagnose 2 important conditions. One is PTSD. One is PTSD when the symptoms are 1 month or more, and acute stress disorder if it is less than 1 month. Similarly, if the stressor is very mild to moderate, that means the stressor is something which all of us may experience. but we may not get affected. Then sometimes patient may develop some symptom, it is known as adjustment disorder. Difficulty in adjusting to the new change or to that situation. यहाँ पे patient may have mild behavioral or emotional symptoms and usually say it is a diagnosis of exclusion. We exclude all the diagnoses. If nothing is getting made, then we may think of adjustment disorder. Let us focus on PTSD and ASD. We always discuss this with the mnemonic of Mahi. So when Mahendra Singh Dhoni, this famous cricketer Mahi comes to bat, we are watching him in IPL, we don't know whether we'll see him in the IPL next time. So when Mahi comes to bat, he is a trauma for the opponent, right? So remember Mahi. So M is mood and cognition. So this patient, he has experienced a trauma. After coming out of the trauma, after the trauma, he may report of negative emotional state. He is very fearful, or may develop negative cognition or thinking that I am bad, So such negative thoughts may occur. Very important is A for avoidance. He may avoid, people, places, objects related with that, event. As you can see in this case, in this scenario, he is avoiding going out of the city now. Because he has gone once out of the, city and he had experienced that stressor. So he is avoiding. Also hyperarousal symptom, again not very specific. Patient may have hyperarousal symptoms like he is hypervigilant. He is not able to sleep. Another important symptom which I want you to highlight is I, intrusion symptom. He is re-experiencing that trauma in the form of dreams, distressing dreams, flashbacks. Patient says that entire event comes in front of my eyes like a flashback. So again remember, nowadays we say, this is the world of AI. So please remember, if there is a serious trauma, patient has developed symptoms of AI, very, very important. You are thinking of PTSD or ASD and make a diagnosis according to the duration. Please remember in the treatment, okay, Atman, right. So let us, slightly debatable, but yes, okay. Now in the treatment, please remember it is CBT. There is one more therapy, you must have read about it, EMDR. But remember, if they ask you specifically, the therapy of choice will be CBT. EMDR is also used, but specifically if they ask you therapy of choice, it will be CBT, and even SSRIs may also be used. I hope this is clear to everyone. See this. In fact, this was asked, that is why I am saying they are making new questions. But don't worry if you see a question and answer is not coming to your mind, see all the options. This is the very simple way of answering. Kabhi question ka answer nahi aata, read the options, rule out them, you will come to the answer. Patient admitted in hospital for thinking he has a MI. Patient ko laga usko MI hai, but he is well. On discharge, he refuses to go to home as 10 days back thief came to his house, put a gun. देखो, can you appreciate कितना severe trauma हुआ 10 days back, and now he is avoiding going home. So Mahi में से remember avoidance symptom is there na. So answer is very good. It is acute stress disorder. It cannot be schizophrenia. You will not make a diagnosis. There is no symptom. Duration is also not matching. Delirium is not there. They are saying everything is normal. And personality disorder, you will never make a diagnosis just on a 10-day history. Personality disorders, you will get a history of years and years. So anyways, my answer is acute stress disorder. Always try to rule out, will come to the answer. Now let's talk about the next topic. Now this topic, again I feel is very important. The last of the neurotic disorder will cover. Then we'll come to some other. Very good. See this. A lady presents to the hospital after having a fight with her husband. Dekho, they have given one stressor. She reports that she is unable to speak. She has developed some neurological symptom. However, all the neurological and physical examination are normal. So they are trying to tell you that it is not actually a physical disorder. It seems to be a psychiatric problem. And also, she does not seem to be concerned about the condition. Can anybody tell me? Dekho, answer is very clear यहाँ पे. देखो, it is not somatic symptom, we'll discuss. यहाँ पे मुझे जो phenomena यहाँ पे हमें मिल रहा है, you are correct, it is labella indifference. Can anybody tell me diagnosis of this condition? Very good. Patient को neurological symptoms हैं which are functional. So patient has functional neurological symptom. Can you tell me the diagnosis? Very good. The diagnosis here is conversion disorder. Very good. I hope this is clear. Let's come back to the last category of neurotic disorder we'll discuss in this video. Somatic symptom and related disorder. But please see the name. Somatic symptom means patient has physical symptoms, but these physical symptoms are not caused by bodily, there is no bodily cause. Like in that case, patient is not able to speak, but it does not seem to be because of any problems in the CNS. The problem seems to be in the mind. Now sometimes what happens, the stress is too much, that mind converts the stress into some symptoms. So let's talk about the first somatic symptom, somatoform and related disorder में conversion disorder. So mind has converted stress into some neurological symptom. In fact, DSM-5 has given a very right name, functional neurological symptom disorder. Patient को neurological symptoms हैं which are functional. So patient has only neurological symptoms. These can be sensory like hemianesthesia. Now please remember, you will never find, anatomically it is not possible to have complete hemianesthesia, but sometimes patient in emergency come, that's our entire one half of my body I am not able to feel. Usually you will see hemianesthesia will be crossed. Patient, a 7-year-old girl, after hearing the fight of her parents says I am not able to see anything. So again blindness may be there. And sometimes motor symptoms may occur, like patient is having some abnormal movement, or there are some jerky movement lasting for 1 hour. It is not true seizure, it is pseudo seizure. And very interestingly, labelline difference is seen in such patient. Careless attitude towards serious illness. Like in this case, but if you are not able to speak for a few seconds, you will be in a very panicky state, isn't it? But this patient, it seems to be hardly concerned about her illness. So ये है labelline difference. So the answer is, it is labelline difference. Very good. Please remember this, see this, this has been asked this year only. Again you will see one more question. NEET PG maybe question was asked from this topic. So we are talking about somatoform and related disorder. Usually the treatment is therapy. See the question first. Make a diagnosis. Also remember, these are more common in females than males, especially young females. Very good. See this question now. A young girl presented with history of multiple episodes of loss of consciousness lasting for 20 minutes. These episodes are occurring only in front of family members and only in daytime. There is no history of tongue bite, incontinence, EEG, MRI are normal. So they are trying to say it is not a true seizure. So what is the treatment? So have you identified, can you say that patient is having some neurological symptoms, motor symptoms? So diagnosis beta हमने बनाया है conversion disorder. Now can you tell me what is the treatment now? Treat with aversive? No, aversive therapy is not a common method we use. Aversive therapy का मतलब है patient को कोई painful stimulus देना. For example, mild electric shock. They may be used in condition like substance use, paraphilias, but they are not very common methods. Valproate again I will not think, because I am not thinking of true seizures. Again changing the diet may not help. So again only one option is there with me. Usually we can use behavior therapy, but other therapies can also be used like insight oriented psychotherapy. Maybe there is stress, we try to bring that unconscious stress on the surface. So we try to generate insight about the symptoms. I hope this is clear to everyone. But in malingering now they will tell you, देखो malingering में they will tell you that patient is getting a external gain. There is some monetary or some external gain. Like by presenting this, the patient is avoiding her workplace, her work, or she is being transferred to a new place, and by developing these symptoms, the patient is avoiding that transfer. So they'll give you some gain also, external gain. Then you may think of malingering. I hope this is clear. Now one more important topic in somatoform and related disorder. So two more conditions we'll discuss. We have covered conversion disorder. Then there is somatic symptom disorder or somatization, as the name suggests, somatic symptom. So patient is preoccupied with the symptoms. Patient is preoccupied with the symptoms. Again these may be symptoms like GI symptoms, patient has respiratory symptoms, various other systems are involved. Patient says, sir, I am having pain in my abdomen. My gastric surgeon, gastroenterologist have said everything is fine, don't worry. But still I am worried about my symptom. So can you appreciate conversion disorder में सिर्फ neurological symptom were there? In somatic symptom disorder or somatization, other systems are also involved. Illness anxiety disorder is a new term for hypochondriasis in DSM-5. Very right name they have given, illness की anxiety. So patient is preoccupied of having a serious illness. Sir, I am having pain in my abdomen. My gastroenterologist is saying everything is fine. No sir, I think I have a tumor. Will you be able to differentiate between somatic symptom disorder and illness anxiety disorder? Again this is, again previously questions have been asked from this topic. They may again ask questions. If he is just worried about the symptom, it is somatic symptom disorder. if he is worried about a serious illness, they may name a illness or they may just say कि patient को लगता है he has a serious illness. Then I am thinking of hypochondriasis. I hope this is clear to everyone. So we have covered that classification of organic neurosis and psychosis. Let's now cover some other small topics. Let's first talk about child psychiatry. Now this again was asked last year in INI-CET. Let's first talk about autism spectrum disorder. Now autism spectrum disorder is a new term again added in DSM-5 and ICD-11. So what they have done is, there are certain conditions which are very similar. So what they have done is, they have again made a larger diagnosis of autism spectrum disorder. Tell me what is the right answer. Very good. Here patient has problems in social communication, so abnormalities in socialization, and there is a restricted pattern of behavior. Two types of symptoms. Cognitive function dysfunction is not a criteria, core feature of autism. Very good. So what is autism spectrum disorder? Remember, many of these child psychiatric disorders which we are covering now, they are neurodevelopmental disorders. Please remember this term. You will see, sometimes they may ask you, now we consider them as neurodevelopmental disorders. There is some problem in the neurological development of the child. First, as we discussed, is autism spectrum disorder. There are two core features. Deficit in social communication, we communicate with each other, the child has problems. And the child will do some patterns of behaviors, restricted patterns of behavior again and again. Wake up at 6 o'clock in the morning every day, eat specific thing in the breakfast, sit in a particular seat in the class. So there will be certain repeated patterns. Now what all disorders now we have included under this? Language wala criteria has been removed from the core criteria. Autism, classical autism, Rett syndrome, Heller syndrome, and Asperger syndrome. Again remember, all these are more common in males or females? They are more common in males than females. There is one exception which was asked in your exam. Can you tell me? Sometimes savant skills kya hote hain? They are high proficiency skills. They may occur, not all, nearly 10% only. Can you tell me, all are more in males than females except kaun sa hai? Very important, Rett syndrome is an exception. This was asked in the exam. Please be very careful. Let's briefly discuss Rett syndrome. Rett syndrome, as we discussed, it is more common in female than male. There is one specific risk factor, gene has been identified, MECP2 gene on chromosome XQ28. So there is a known risk has been identified. Now Rett syndrome is again a ASD, autism spectrum disorder. It will have the core features. But interestingly, what is happening in Rett syndrome, that for the first 5 months the child is having absolutely normal development. But a bachcha will appear very normal. Problem will start, abnormality will start from 6 months to 2 years. The child will have stereotypic movements. We remember na, stereotypies, non-purposeful repeated movements. What are these known as? Such movements like hand wringing. You will see such terms in the question. So these are some midline movements like this. Patient may have such movement, child will have such movements. Also you will see that the head circumference growth will deaccelerate. Can you tell me what will happen? What will happen when the head circumference growth will deaccelerate? What will be the physical finding? It will be microcephaly. But this question has been asked also and may come also. Tell me, in Rett syndrome, microcephaly is seen at birth. Tell me true or false. Rett syndrome mein microcephaly is seen at birth. True or false? It is a false statement because birth mein we are saying it is normal. Macrocephaly seen at 6 months, again false. It is not macro, it is micro. So please be very careful. Child may also have other symptoms like loss of speech, muscle coordination, ataxia, seizures may also occur. There is one drug which was approved for Rett syndrome in 2023 and twice this drug has been asked in INI-CET. So again very important, can you tell me the name? Can you tell me the name of the drug? Very good, it is trofinetide. Tide means it's a peptide, it's a tripeptide, remember, of glycine, proline and glutamic acid. Remember this name, very important. Again, those who are preparing for INI-CET, remember this has been asked twice in the exams. Okay, so this is about Rett syndrome. Let's discuss another child psychiatry topic which is ADHD. Again, it is also a neurodevelopmental disorder. As the name suggests, AD, attention is deficient, so the child has inattention. Parents, teachers will say he is not able to pay attention, loses attention easily, gets distracted easily, and the child is very hyperactive. So even if you see the child, observe, he'll be very fidgety. The child may not be able to sit, and also the child may be impulsive. He may not be able to wait for his turn. So there again, two symptoms are there. Two symptoms are there in autism, two symptoms here. Here it is inattention and hyperactivity and impulsivity. Again, ADHD is more common in, remember, males than females. Now what happens? Now this question in fact was asked. Let's discuss this one point. Many times we see, so onset of ADHD, we make a diagnosis when the symptoms start before 12 years of age. 40% of the patient, they show remission at puberty or early adulthood. First symptom to remit is hyperactivity. पहला symptom जो improve होता है वो होता है hyperactivity. Last to remit is inattention. Now if the patient's symptoms continue in adolescence or adulthood, the child may also have a risk of various other conditions. For example, in adolescent, there is an increased risk of conduct disorder. In children, conduct disorder is when there is violation of rights of others, like beating others, destroying the property. So there is an increased risk of conduct disorder if the symptoms continue. And in adulthood, the child may also eventually develop antisocial personality disorder. Please remember, conduct disorder diagnosis we make in childhood. Antisocial, it's a personality disorder, we make a diagnosis in adulthood. Okay, so this question was asked, if untreated child with ADHD, what is the risk in adolescence? It may have risk of developing conduct disorder. I hope this is clear to everyone. Very good. Now in the treatment, do you know what is the treatment? Drugs or therapy? On the first line treatment, remember, is drugs. So please remember, again, twice last year questions have been asked from this. So please remember, this is a very important topic. In FMGE also, in INI-CET also, questions have been asked from this table. So let's discuss. Now we have two important groups. One is the CNS stimulants and another is non-stimulants. In the stimulants, what is the drug of choice? Remember, it is methylphenidate. Very good. Methylphenidate. It is the drug of choice. Remember, it increases both dopamine and norepinephrine. It acts on both dopamine and norepinephrine. Now, important side effects you can remember of methylphenidate. One is it can cause growth suppression. It can cause growth suppression, which we tackle by giving drug holiday. We give holiday from drug. And also it can cause tics. Even all these stimulants can exacerbate tics. So agar ADHD with tics hai, we may choose non-stimulants. Okay. Then one more drug is amphetamine. Again, amphetamine also increases dopamine, norepinephrine, and another is modafinil. Modafinil is a alpha-1 agonist. Okay, so remember, so you can remember simply with the mnemonic MAM. So we are talking about child psychiatry na, so MAM. Then non-stimulant may remember, one is atomoxetine. Now what is atomoxetine? It is a NRI drug. In fact, this question or indirect question was asked. NRI means it is only targeting norepinephrine. In fact, it is, you can say SNRI. I am not saying SNRI ka matlab serotonin. SNRI matlab selective NRI. Okay, norepinephrine. So please remember, there is in fact one more drug, reboxetine. Dekho, reboxetine, atomoxetine, again they are very similar names. Although it is not approved by FDA. In some other countries, it may be used for treating ADHD. So the question was on reboxetine, which is a selective NRI. So in that, one of the option was reboxetine. So remember, can you appreciate methylphenidate, amphetamine, they are acting on both dopamine and norepinephrine. So remember, there the answer was reboxetine. It is a drug which is selectively acting on on the norepinephrine reuptake inhibitor. Then next is clonidine, guanfacine. But what are these drugs? Can you tell me what are these drugs? These are alpha-2 agonists. They act presynaptically. Okay, these are alpha-2 agonists. Now please remember, these drugs are also used. They are also used as first line treatment for tics. In fact, this was question which was asked in FMGE exam. A child with ADHD and has tics. So we may think of starting non-stimulants. We can also give atomoxetine, but remember which we will prefer. We may prefer clonidine, guanfacine, which will also take care of the tics. So that was the question. So see, two questions came from this table, and one more drug, remember, is again, this drug has again come back. That is bupropion. Again, it is an NDRI. Can you appreciate? It is also acting on both norepinephrine and dopamine. So this is also used. So how to remember? Remember, MAM teaches the child A to B. So A2 means 1A is the atomoxetine A2, second two remember alpha 2 agonists like clonidine guanfacine, and B remember is bupropion. So remember ma'am teaches A to B. So by this you can remember. Okay. Yes, if there is history of addiction, again amphetamine may be a drug you may avoid, again because amphetamine is also a drug of abuse. Okay. Again in India amphetamine is not available for treatment of ADHD. Okay, I hope this is clear to everyone. Very good. Now see this last topic I will cover in child psychiatry, that is intellectual disability or mental retardation. As the name suggests, mental retardation. That means there is deficit in intellectual functioning. Also there is problem in adaptive behavior. So intelligence is low. Now again please remember there are so many causes. Causes can be before birth, during birth there is some injury, or even after birth it can occur. Usually we say onset is before 18 years. Now very interesting question which I will discuss is, if I ask you most common genetic cause, most common genetic cause of mental retardation, you will say Down syndrome. Very good. Second most common genetic cause, you will say sir it is Fragile X syndrome. Very good. Now my question is most common inherited cause, or my question is most common single gene cause of mental retardation. See, I have just changed the language of the question. Dekho, you are thinking about genetic causes like Down syndrome, but I have just twisted the language. Most common inherited cause, yeah, most common single gene cause. Then remember my answer will change to Fragile X syndrome, because we know Down syndrome is a chromosomal abnormality, trisomy 21. So please be very careful. Sometimes you know the answer, but they will just twist the language. So please be very careful. Also this table is very important. Based on the severity we have divided into 4 categories: mild mental retardation, moderate mental retardation, severe and profound mental retardation. Remember some of the, we say mental retardation when the IQ is less than 70. So mild may it is 50 to 69, moderate may it is 35 to 49, severe may it is 20 to 34, and profound is it is less than 20. Please remember this table, very very important. Many questions have been asked. Question was asked, IQ was 55, diagnosis. So can you make a diagnosis? The IQ is 55? Yes, very good. Now let's come to one of their favorite topic. Let's talk about substance. This is one topic. Normal is 90 to 109. Yes. Yes. But this is one topic, which I don't know, examiner's favorite topic or favorite substance, alcohol. Nearly in all exams you will get questions on alcohol. So please remember, please be prepared. See this. A patient stopped taking alcohol 3 days, 72 hours back, and presented with irritability, disorientation, paranoid delusion, visual hallucination, altered sensorium. Diagnosis. Can you just tell me why you have made a diagnosis of delirium tremens? देखो, Wernicke's और Korsakoff तो rule out कर दिया because we are talking about withdrawal state, isn't it? We are talking about withdrawal state. Please try to differentiate. Wernicke's, Korsakoff ये है alcohol induced neurocognitive disorders है. Delirium tremens का diagnosis आपने क्यों बनाया है? बेटा duration is not the main reason. Good, you are thinking, but I am saying duration. Let us say इसको 1 day बना देते हैं. Let me take it as 1 day also. Then also I am saying it is delirium. बेटा we discussed ना delirium क्या होता है? Impairment of consciousness. Can you see any points suggesting consciousness is impaired? Very good. Disorientation mentioned and altered sensorium. Don't make a diagnosis only on the basis of duration, but also see the symptoms. So very very important point. Now I am sure. Let us just see this table. Suppose this patient who was taking, let us say, one bottle of whiskey. How much is one bottle? Standard we say it is 750. Let us say he is taking ml of alcohol every day. Suddenly he stops. So in the next 6 to 8 hours, patient may present to us with tremors. There may be other symptoms like there is anxiety, there is increase in the blood pressure, other symptoms. If this withdrawal state continues, in the next 8 to 12 hours, patient may develop alcoholic hallucinosis, patient may develop auditory hallucination, even visual, tactile hallucinations can occur. So patient is having hallucination. Let us say this withdrawal state continues. In the next 12 to 24 hours, patient is having abnormal jerky movements, uprolling of eyes, clenching of teeth, urinary fecal incontinence. अब क्या हो गया patient को? Remember now patient has developed alcohol withdrawal seizures. बेटा these are generalized tonic-clonic seizures. क्योंकि पूरे brain से alcohol is devoid ना, so generalized. Also known as rum fits. let us say this state continues and up to 72 hours may peaking at 48 to 72 hours, patient has reached to the hospital, but when he reached the hospital he say I have reached home. So what diagnosis you are now making? Patient withdrawal state में आया, he reached hospital and he says I have reached home, मैं घर आ गया. Now what diagnosis you have made? You made a diagnosis of delirium tremens. But please remember delirium tremens हमने discuss किया था ना, 4 points we discussed when we'll say it is delirium consciousness is impaired, like clouding of consciousness, altered sensorium, disorientation या confusion. Nowadays they give this word confusion. Word confusion in the withdrawal state is telling me again it is delirium. Now again in delirium also patient may have hallucination. You may find visual more than auditory. I just want you to tell me again how will you differentiate alcoholic hallucinosis from delirium tremens. बेटा बस एक बार ये मुझे बता दो. I'll be assured that you have understood. Tell me how will you differentiate alcoholic hallucinosis from delirium tremens. I hope the question is clear to everyone ना. बस मुझे ये बता दो कैसे differentiate करोगे. Very good. Not on the basis of duration, not on the basis of hallucination, you will say on the basis of impairment of consciousness. Very good. I am very happy. Very good. Very good. Please remember this. I hope this is clear. देखो दोनों में hallucinations हो सकते हैं, visual दोनों में हो सकते हैं. So remember those 4 points. Any of those points mentioned in withdrawal state, think of delirium tremens. देखो delirium tremens ना medical emergency है. Patient can die if it's a medical emergency. Also this question was asked once. देखो delirium हमने discuss किया था ना, even in organic condition, delirium risk of delirium can be increased with infection. This question was asked once in INI-CET. Delirium tremens risk increases with infection, acute infection, or with gradual withdrawal. Tell me what was the answer here? Question I hope सबको समझ में आया कि delirium tremens का risk एक्यूट इन्फेक्शन से इंक्रीज होता है या ग्रेजुअल विड्रॉल से. देखो जब हम डिलीरियम ट्रेमेंस या सीजर, ये बहुत सिवियर सिम्टम्स हैं विड्रॉल के, दे यूजुअली अकर व्हेन देयर इज अ सडन एब्रप्ट विड्रॉल. ग्रेजुअल मतलब धीरे धीरे पेशेंट इसको डिक्रीज कर रहा है, देन पेशेंट में डेवलप ओनली माइल्ड सिम्टम्स. सो आंसर इज एक्यूट इन्फेक्शन. आई होप दिस इज क्लियर टू एवरीवन ना, मेकिंग सेंस. ग्रेजुअल विड्रॉल में पेशेंट में नॉट डेवलप सच सीरियस विड्रॉल सिम्टम्स. हाँ, पेशेंट अगर विड्रॉल स्टेट में उसको एक्यूट इन्फेक्शन हो गया, so risk of delirium tremens may increase. Very good. देखो again and again I am saying, I have shown you एक ही slide में I have put 2 questions so that you get an idea. देखो बार बार these questions are getting repeated. After 72 hours of cessation of alcohol, which of the following may be seen? यहाँ पे you can say they are asking on the basis of duration ना. Okay. But again please remember, everybody may not develop all the symptoms. Some may just have tremors, some may have hallucinations, some may also develop seizures, some may even have delirium tremens. हाँ, the answer is delirium tremens. See this repeatedly asked question. देखो अभी जनवरी में आया था 25 में, फिर से question. 45-year-old male chronic alcohol intake, last intake 48 hours back. देखो उन्होंने हिस्ट्री में दे दिया ना, withdrawal state है, 2 दिन हो गए अल्कोहल नहीं लिया. He seeing snakes crawling on the bed. उसको visual hallucination है. Not able to recognize his own family members. Can you appreciate disorientation शुरू हो गया? The answer will be, can you tell me what is the answer here? Answer is delirium tremens. Very good. Can you appreciate? I am again and again showing you so many questions. Let's come to the treatment. देखो patient आपके पास आया in the withdrawal state. So let's treat it. And again we can treat it into 2 phases. पहला है detoxification phase. दूसरा है maintenance. देखो just understand this concept and you will understand this. Always you will, now you will not forget if you understand. देखो alcohol में it is ethanol ना, C2H5OH, it is ethanol. Beverage alcohol has ethanol. You just tell me ethanol or alcohol is a CNS depressant or it's a CNS stimulant. Tell me alcohol एक CNS depressant है या stimulant है? Please remember alcohol is a CNS depressant. A patient is taking a depressant every day, suddenly he stops. So can you appreciate all the withdrawal symptoms like seizures, tremors? They are telling us that the brain is in a hyper-excited state. So how will you counter these withdrawal symptoms? Detoxification का मतलब है I am treating the withdrawal symptoms. So drug of choice क्या? Give one more depressant. So what is the drug of choice? It is benzodiazepine. But I hope this is clear to everyone. Drug of choice for alcohol withdrawal is benzodiazepine. If you are asked one drug, benzodiazepine. Okay, so there are many benzodiazepine like lorazepam, diazepam, oxazepam, clodiazepoxide. We can use these drugs. Nowadays they ask a tricky question. Somewhere in the question they will tell you LFTs are deranged, or they will tell you patient has hepatomegaly, or they may tell you that patient has liver cirrhosis or icterus. तो अब liver disease है patient को, हो सकता है in alcohol, chronic alcohol use. Now which drug you will use? Very good. Remember liver okay. Lorazepam has been asked, also oxazepam. Just completed one more drug you can remember, which is again, safer is treatment, T for treatment, timazepam. So please remember liver okay treatment, lorazepam, oxazepam has been asked. So then they may ask you ki which benzodiazepine you will use. So please remember these are drugs which we can use if the patient has some liver disease or liver is compromised. Now one more point. If I ask you treatment for withdrawals, so detoxification means I am treating the withdrawal symptoms, right? So along with benzodiazepine, would you like to add something else also? Tell me, yes or no? You will say yes sir, I can also add thiamine. देखो अगर क्वेश्चन आता है अल्कोहल विड्रॉल का and you asked drug of choice, it is benzodiazepine. If there is one more option, benzodiazepine plus thiamine, then that will be a better answer. But if you are asked one, then it will be benzodiazepine. I hope this is clear. We start benzodiazepine on day 1 depending on the withdrawal symptom as high dose, जो भी symptoms accordingly we decide the dose, and then we gradually taper and stop. So this is how we manage the detoxification or the withdrawal state. Now 10 days, 14 days later, patient comes to you, says, thank you sir, thank you ma'am, you've saved me, can I go home? What will you say? You will say yes, you can go home, but now we want you to be in the maintenance phase. मतलब ऐसा ना हो you go back home and you again start consuming alcohol. Okay? Okay? हाँ बेटा, the patient in delirium patient may be very, activity levels may be very high. So there may be hyperactive delirium. Patient is not sitting at one place. Patient is very confused. He is not aware what is happening. So patients sometimes are very difficult to manage at times. Now see this question. Now this question was asked again last year in NEET PG. A patient brought to the hospital after a road traffic accident with confusion, irritability, tremors. He had an accident. On taking history, he was consuming alcohol daily. Can I say because of the accident he was admitted in the hospital, suddenly alcohol is stopped? So can I say these symptoms, occurred because of withdrawal? So they are saying which drug you will use to avoid the withdrawal symptoms. Tell me what is the answer. नहीं बेटा देखो withdrawal state पूछा है. Please see this. देखो he was taking, देखो suddenly because of the accident he is admitted in the hospital, तो alcohol एकदम से intake बंद हो गया ना. So patient is landing up into withdrawal state. So what will you do to manage the withdrawal symptoms? Very good. It will be lorazepam. But I will talk about naltrexone. That will be used in the maintenance. अभी हमने पूछा withdrawal symptoms के लिए. You will be able to answer. I hope you will be able to answer. Na, very good. Let's now come to the maintenance. We have taken care of the withdrawal symptoms. We have treated the detoxification phase. Now let's talk about the maintenance. In maintenance, one drug is we have disulfiram. It's an aversive agent. It inhibits, remember, ALDH, aldehyde dehydrogenase. देखो हमारी body में ethanol is metabolized by various steps. By inhibiting this enzyme, by inhibiting this aldehyde dehydrogenase, so अगर patient alcohol लेता है, who is taking disulfiram, in his body acetaldehyde increases. And acetaldehyde basically is, toxic. So patient, when he is taking disulfiram and over the top of it he consumes alcohol ना, patient को unpleasant symptoms आते हैं जैसे nausea, vomiting. So this drug is aversing the patient away from alcohol. This is one method. But more commonly, we can use anti-craving agents. They decrease the craving of alcohol. Remember, two important anti-craving agents which are approved by the FDA. There are so many other. In fact, I have given you a list. But remember, two important anti-craving agents approved by the FDA. Naltrexone यहाँ पे आएगा. It is a opioid mu antagonist. What is a camprosate? Like memantine, it is a NMDA antagonist. I hope this is clear to everyone. So this is about the management. Alcohol not best friend. Very good. So we have talked about it. Very good. Now see this. Now I will talk about another important table. Now let's talk about what is Wernicke's, what is Korsakoff. Let's talk about Wernicke's क्या है, Korsakoff क्या है. देखो, these are alcohol-induced neurocognitive disorders. अभी तक we were talking about alcohol withdrawal. Now chronic use of alcohol can also lead to certain neurocognitive disorders. We'll discuss them one by one and also we'll discuss some new points. पहला है Wernicke's encephalopathy. Wernicke's encephalopathy, remember, it occurs suddenly, acute in onset. Suddenly the symptom will develop. What are the symptoms of Wernicke's? Anybody? Goa. Remember the mnemonic Goa. G से global confusion. Patient confused state में है. Ophthalmoplegia. Patient has ocular signs and symptoms. Patient comes like this. Sir, I am not able to move my eyes. My eyes are deviated to one side. Remember, sixth cranial nerve is affected more than third cranial nerve. Patient may have nystagmus. So ocular signs है. Ataxia. He is trying to move, but he then falls. है ना? Remember, Goa is very famous for Feni. Goa. So symptoms are Goa. You will say, sir, यहाँ पे भी confusion है, withdrawal state में भी confusion थी. This is big confusion. No confusion. So please remember, when they'll ask question on delirium tremens, na, they will tell you patient has stopped taking the drug, stopped taking the alcohol, and there will be other symptoms of alcohol withdrawal like tremors and others. Here, the patient may be continuously taking alcohol and he has developed Wernicke's. Along with confusion, he will have other symptoms like ophthalmoplegia, ataxia. Will you be able to differentiate now? Very good. But what is the actual cause? Alcohol is not the actual cause. Because of alcohol, patient may develop deficiency of vitamin B1 or thiamine. This has been asked so many times. Actual cause क्या है? Vitamin B1 deficiency. So treatment क्या है? You will say, sir, I will give thiamine. Is it reversible or irreversible? Remember, it is a reversible condition. You give thiamine, the symptoms will be reversed. I hope this table is making sense, clear to everyone. Now I'll discuss now. We always discuss 2 points, 2 extra points, because they have asked so many times this topic. And finally, last year in NEET PG, that question came. So I'll discuss again the 2 points. You will in fact tell me the answer. This was the NEET PG ka question. A patient chronically consumes alcohol, indulged in binge drinking 10 days back. Brought to the emergency in unconscious state. Non-contrast CT scan was normal. Okay, so they are trying to tell you that there is no, again neurological, in the sense injury is not there, but his blood glucose is 45 milligrams. So there is hypoglycemia and maybe that is the cause, and I have to give this patient, glucose. So can I say, sometimes we give, because sometimes in unconscious patient we give thiamine, because what if the patient has a, deficiency of thiamine? Yes. Now here what you will give? Now please remember, we always say that when I am treating a patient with, history of alcohol, let us say, okay, then, because we know that there can be deficiency of thiamine, so whenever we are giving that patient dextrose or glucose solution, always and always we give with thiamine. So thiamine followed by dextrose. This is very, very important. I hope this is clear to everyone. We'll talk about it. Very good. So please see this, why we are saying this. Again, this is some of biochemistry which I am integrating here. In biochemistry, again you must have read about the metabolism of glucose, and TPP is thiamine pyrophosphate. Again, thiamine is required as a cofactor in so many enzymes. Remember with the mnemonic ATP, alpha ketoglutarate dehydrogenase, trans ketolase, pyruvate dehydrogenase, even in branch chain keto acid dehydrogenase. So remember ATP. Now can you appreciate if the patient is having a deficiency of thiamine and I am giving glucose? So again, because of thiamine deficiency, the glucose will not be metabolized by the conventional Krebs cycle. So always and always we make a point that when we are giving patient who might be having, deficiency of thiamine, we have to give glucose. Always we give thiamine followed by glucose. I hope this is clear to everyone, right? So this is a biochemistry question also, you can remember, right? Now the second point is, suppose a patient comes to me with history of alcohol with these Goa symptoms. What I am thinking? I am thinking Wernicke's. I gave thiamine. Question is that there is no response with thiamine. देखो हमने तो Wernicke's सोचा था. Wernicke's होता thiamine के साथ there should be response. So now what I am thinking, maybe it is not because of thiamine deficiency. Why? These symptoms may also be, similar symptoms can occur with some other deficiency. कौन सा? Remember, it may be because of pelagic encephalopathy. Okay, देखो alcohol is basically a gut irritant. It is decreasing the absorption of vitamin and other B1 and other vitamins, minerals. So it can also decrease the absorption of. So now what will be the treatment? Very good, I'll give niacin. Very good. So this may also come as a new question. Again, please remember this. This can come as a potential new question. So once they had asked about, glucose and thiamine, this may be the next question. I hope this is clear to everyone. Very good. Let's complete this table. Korsakoff, usually occurs, it is a chronic condition. So chronic sequelae of Wernicke. What is the main symptom? We discussed this when we were talking about organic. Now you have to tell me. Can you tell me, we discussed now in organic, under which category I talked about Korsakoff? Can you tell me? Yes, remember it is amnesia can occur. Very good. Amnestic syndrome we discussed and even confabulation. Now please remember even confabulation, that is filling of the memory gaps. Filling of the memory gaps with false stories. है ना? So patient may also have confabulation. Again the cause remains the same. It is because of vitamin B1 deficiency. Again treatment is thiamine. But again some symptoms may be resolved, some may persist. So you can say partially reversible or you can say irreversible. This is again a very important table. Again and again they have been asking questions from alcohol withdrawal management and neurocognitive disorders due to alcohol. I hope this is clear now, making sense. One or two questions you may see in the exam from this topic. Let's complete substance. Let's discuss some other points about substance and then I'll just come to some miscellaneous topics. Okay? A patient with suspected overdose, opioid overdose, comes to emergency with respiratory distress, bradycardia and hypotension. Which of the following drug is used in the reversal of depression? Very good. Patient को हुआ है opioid overdose. Just tell me, so there is a triad. Patient may have respiratory depression, patient may have, coma. What will happen in the eyes? If you see the eyes, what will you see? Tell me, in opioid overdose, what will you find in the eyes? Remember it is meiosis, pinpoint pupil, very, very important. And the treatment is, we will give short acting, antagonist. It is opioid antagonist, usually IV it is given. It is short acting opioid mu antagonist. Remember this, okay? Please remember this, very, very important. I hope this is clear to everyone. Yes, this question has been repeated again and again. A surgeon is doing a surgery, he is giving morphine. Morphine, again it's an opioid, but sometimes we use it also for medicinal purposes. Patient has developed respiratory depression. Again they are trying to tell you it's an overdose. So what is the next step? Then we'll give again naloxone. I hope this is clear to everyone now. Very good. Answer this question. 30-year-old male, symptoms of abdominal pain, yawning is there, diarrhea, rhinorrhea, sweating, lacrimation. So all the body outlets are, leaking. When you see the pupillary size, it is pupillary dilatation. There is also piloerection. Can you tell me which substance withdrawal is causing it? Which substance withdrawal? But just let me, give me 20 minutes more, I'll finish. I'll just finish, don't worry. Because I want, we don't miss out on some of the important topics. But ये कौन सा withdrawal है? ये opioid withdrawal है. In fact, last year finally opioid withdrawal का treatment पूछा था. Again in opioid withdrawal, just like we discussed in alcohol, we can treat in two phases. One is detoxification and another is maintenance. I'll tell you the question. देखो detoxification में I will treat the withdrawals with drugs like methadone. No, patient is taking impure opioid, I will give pure opioid. I can also use buprenorphine. देखो कैसे याद रखना है buprenorphine, it is rhyming with morphine ना. It is a partial agonist of mu. Sometimes I can also treat symptomatically by giving clonidine. Patient कह रहे नहीं sir, don't give me opioid. I can also manage the symptom by giving symptomatic treatment by clonidine and other drugs. Maintenance, again we can use one strategy known as OST, opioid substitution therapy. We tell the patient, I'll give you one tablet of methadone or buprenorphine every day. So this also can be done. So I'm substituting the impure opioid with a pure opioid. And lastly, I can also use naltrexone. Here I am using the antagonistic property of naltrexone. देखो ये question आया था last year in the exam. Which of the following drugs is used in the management of opioid maintenance? And one of the option was buprenorphine. So please remember, sometimes when they've asked one question from a table, it becomes, high chances that they may ask a similar question from the, in other exams also. I hope this is clear to everyone now. See this next topic. So now I'll talk about stimulant, a very important topic. We'll talk about stimulant, a very short topic, but many questions have been asked. A mother reported that her daughter ingested a substance in an unknown dose. Okay, so there is, again overdose is there and the child has hypertension, tachycardia, hyperthermia. So can I say that there is increase in the sympathetic activity? Also there is mydriasis. Mydriasis. Can you tell me? But first of all, I have removed heroin, morphine because they are opioids. They will cause meiosis. Which substance I am talking about here? It is cocaine. Very good. Cocaine is a stimulant. So let me just give you a trick to remember. Remember TCA? When I'll talk about mydriasis, again you'll talk about even in forensic, in pharma, you know, so many drugs associated with meiosis, mydriasis. Just, you know, few drugs we can discuss here, which we have discussed in psychiatry. One is already we have talked about TCA toxicity has mydriasis. I have talked about cocaine here, and even amphetamine, which is also a stimulant, will also cause mydriasis. Remember this. So again and again they are asking patient has meiosis, mydriasis. So one should know that in intoxication which is causing meiosis, which is causing mydriasis. I hope this is clear to everyone. Let's talk about this table. You know, finally cocaine, a very small topic, but repeatedly they are asking question. Cocaine is derived from the leaves of Erythroxylum coca. It is derived from the leaves of Erythroxylum coca. It's a stimulant. So remember, it will cause hypertension, tachycardia, tachypnea, cardiac arrhythmia, seizures can occur, even hyperthermia, and remember mydriasis. This question was once asked. In fact, I'll come to this question. Answer this question. Because sometimes if you know the concept now, you will be able to solve those questions. It's not seen in patient who have heavy dose of cocaine. Tell me the answer. Sometimes yes, patient may develop such symptoms. Very good. So यहाँ पे answer, better answer is bradycardia. Very good. Okay, we have already covered this. Patient may also develop cocaine bugs or magnum bugs, है ना? Patient may report. So patient, I'll repeat that question. Patient को tachycardia, tachypnea और scratch marks हैं. Which substance he is consuming? You will say sir he is consuming substance like cocaine. Very good. What is speedball? This is again a very old question. Speedball is when somebody, very good. Yes, it may mimic sometimes the symptoms. Yes. Tell me, patient may develop, yes. Tell me, it is cocaine plus heroin. Very good. And also remember, when the patient sometimes, you know, snort it, it's a stimulant, it will cause vasoconstriction. In the nose, what finding you may find? It may cause nasal septal perforation. They may give an image of nasal septal perforation, skin is blackened around, which substance? It may be cocaine. And when you see the tongue, remember, it can cause jet black pigmentation of the tongue. So again, a very small table, but very important. So many questions have been asked. Very good. So many questions have been asked. Last substance we'll discuss is tobacco. Tell me, what is the psychoactive agent? What is the psychoactive agent in tobacco? Remember, it is nicotine. Nicotine. Now in the treatment, now please remember also, if they ask you most common substance in India, remember it is tobacco followed by alcohol. If they ask in India, remember, if they ask you most common illicit substance, can anybody tell me? Illicit means illegal substance both in India and the world. Answer will be what? It will be cannabis. It will be cannabis. Please remember, it will be cannabis. But please remember, if in the option now they ask you most common substance, but if this new substance is in the option, which substance I am talking about? Remember, caffeine. But even caffeine is now considered as a substance use disorder. If they ask you now which is the most common substance India and world, again now the answer will be, it will be caffeine. Otherwise India may, then if caffeine is not there, it is tobacco. Please remember this point, you know. Again, even ICD-11 also says caffeine is now the most common psychoactive substance. So please remember, now it is caffeine. Let's come back to tobacco. Again, we have two strategies. One is nicotine replacement therapy, that patient is, along with, you know, tobacco is consuming so many harmful substances, we replace it with pure nicotine. So we can give nicotine gums, lozenges, patches. Also there are two important anti-craving agents. देखो alcohol में भी दो anti-craving agents थे, यहाँ पे भी दो हैं. One is Wernicke. See the name, Nick is coming in between na. So it's a partial agonist of alpha 4 beta 2. Remember, 4 is coming first, beta 2. N-acetylcholine receptor, N, nicotinic acetylcholine receptor, and another is bupropion, that is NDRI. This question was asked, देखो, antidepressant used for smoking cessation, you will say sir it is bupropion, right? Now recently the question was asked, a female wants to stop tobacco. Both options were mentioned, Wernicke भी था और bupropion भी था. But then answer कौन सा choose करोगे? Remember, alpha 4 beta 2, 2 है. Tell me then what will you choose? Remember which is written first here. Remember, Wernicke is most effective. Please be very careful. Very good. ठीक है. अच्छा, if I want to ask a new question, ना, see this question. I'll say, let us say a 22-year-old male has depression, has ADHD, and he smokes cigarettes. Again, which drug can I use? Can I say bupropion will be used in all the three conditions? Depression maybe, ADHD maybe, and even for smoking cessation. So there also I can use bupropion. So please be ready with such question. Try to apply some logic and you will see you will be able to solve the question. Let's now discuss some miscellaneous topics. Again, eating disorder is a topic you will see many questions have been asked. Answer this question. A 16-year-old female patient was referred to psychiatrist by physician for having irresistible urge to eat. Craving for food was there. Excessive eating followed by episodes of self-induced vomiting. She also is using appetite suppressant drug. Diagnosis. Dekho, this was slightly tricky question. You are thinking of bulimia nervosa, you are also thinking of anorexia. Very good. Why the answer is bulimia nervosa here? Can anybody tell me? देखो यहाँ पे एनोरेक्सिया नर्वोसा भी हो सकता था, बिकॉज एनोरेक्सिया नर्वोसा में भी बिंज ईटिंग पर्जिंग मिलता है, एंड पेशेंट इन द हिस्ट्री दे आर सेइंग दैट इज यूजिंग अ एपेटाइट सप्रेसेंट ड्रग. कैन एनीबडी टेल मी व्हाई? हाँ, वेरी गुड, बिकॉज एनोरेक्सिया नर्वोसा में वी नो वेट या BMI should be low. That is not mentioned in the question. So by default the answer will become bulimia nervosa. Very good. I'm very happy you have answered this. Now see this, let's discuss. So anorexia nervosa, remember all the three eating disorders which we'll discuss: anorexia nervosa, bulimia and binge eating disorder. They are more common in females than males. Very important point, remember anorexia nervosa mein BMI should be low, less than 18.5 kg per meter square, or the weight is low. Okay. Again, there are two subtypes. One is restricting type, which is most common, मतलब patient is not eating much, eating less. Even binge eating, purging. देखो binge eating क्या होता है? Eating large amount of food in less time. Purging means patient is now compensating by behaviors like vomiting. तो यहाँ पे भी हो सकता है. How will you differentiate binge eating purging in bulimia versus anorexia nervosa का binge eating purging type? You will say, sir, weight. Very important. Patient को लगता है, patient perceive themselves to be fat, there is a distorted body image, okay, patient has fear of gaining weight and patient eats less, so there is decrease in weight or BMI. Very important point. देखो, just an extra point, especially those who are giving INI-CET, suicide rate is more in binge eating purging type as compared to the restricting type. Now coming to the management, this is again very important. Two questions have been asked from this table. One, I will tell you, one new question may be asked. Admission criteria. देखो, many times patient with anorexia nervosa, their weight BMI is very low, but they are still not ready to eat. So many times we have to admit the patient. This was asked once in FMGE exam, indication of admission for anorexia. So patient may have complications, जैसे कि there can be electrolyte imbalance can be there. There can be dehydration, so that is an indication. Also, if the weight by height reduces by 20%, so this again was asked in FMG once. So remember, that is also an indication. Now the question which was asked in AIMS, I have admitted the patient. देखो, treatment में my main goal is to increase the weight, restore the weight and deficiencies. So I am giving a patient adequate calories for a week, but there is no increase in weight. Can you tell me what you will do? Will you increase the calories, or you will observe the patient 2 hours after each meal? A or B? Increase weight or observe for 2 hours after each meal? Tell me, what will you do? Very good. This question was asked in AIMS. Yes, because patient, what if patient is doing purging? So I'll observe, I'll try to rule out whether it is because of purging. In the management also remember, treatment is CBT is done, CBT is preferred. Also we can use drugs like SSRI. Now I'll discuss a new question which can come in the exam. A patient who was diagnosed with anorexia nervosa comes, we start giving calories, patient develops low phosphate, potassium and magnesium. There may also be cardiac arrhythmia history, they may tell you rhabdomyolysis is happening, deficiency of thiamine or seizure. What are you thinking of? Again, this may be correlated with surgery also. Sometimes, so we are refeeding this patient, but sometimes if we give the calories too fast, what can occur? Very good. This is refeeding syndrome. Please be careful. This may come as an integrated question with other subjects, so such new question may also be asked. I hope this is clear to everyone. Yes. Let's now talk about bulimia nervosa. Now bulimia nervosa is again more common in females than males. Here patient is having episodes of binge eating, patient eats a lot in less time. Now the patient realizes, oh my god, I've eaten a lot, so patient compensate. Remember, patient can do purging in the form of vomiting, but patient can also use various drugs like emetic drugs or laxatives. Also patient can do compensation by other methods. For example, patient is exercising or patient diets for a few days, eats a lot, binge eating, then patient diets for a few days. So that can also be used as a compensation. So don't think कि हमेशा सिर्फ self induced vomiting मिलेगा. Again beta, when I ask weight or BMI, it will be, remember, normal or it may be at a higher side. Very very important. Okay. Now complications of purging. देखो, finally a question was asked this January only in the FMGE exam from this also. देखो, patient is doing self-induced vomiting, so repeatedly the HCl from the stomach is coming in the oral cavity, going out. So there can be some complications of purging. Like there can be dental caries, patient may develop parotitis, there is inflammation of the parotid gland. Can you appreciate, can you see these? There is callus on the knuckles. Because of repeated trauma, there may be injury. What is this sign known as? Very good. This is known as Russell sign can occur. देखो, HCl is going out, patient may develop hypokalemic, hypochloremic, even sodium ions are reduced. Tell me, metabolic alkalosis or metabolic acidosis? HCl is going out, remember it is metabolic alkalosis. Again this was asked in January 2025 FMG exam. So again they will frame such new question, please be very careful. Chalo, let me ask you one more question. Patient has dental caries, patient has parotitis, patient has Russell sign, patient has metabolic alkalosis. Tell me the diagnosis. Tell me the diagnosis. So I have given you patient is having these symptoms, okay, and these findings are there. Can you tell me the diagnosis? You're very good. You're thinking of bulimia, but suppose bulimia nervosa is not there in the option. Can these be seen in anorexia nervosa also? Yes, you will say, sir, these are complication of purging, and we know even in anorexia nervosa there is a binge eating purging subtype. How will you differentiate? Again, weight becomes very important. Okay, I hope this is clear now. So this may come as a tricky question also, ki you are thinking of bulimia but that is not in the option. So even in anorexia it can occur. And again this is version X we have launched. So again I've taken this question also from this. Again now I'm sure you can solve this question. A young girl is brought to you for assessment by the mother for depression. On assessment she is diagnosed with MDD by the psychiatrist. On further inquiry, patient has episodes of binge eating followed by self-induced vomiting. So you're thinking also in terms of bulimia nervosa. Which drug should be avoided? Now can you answer this question? I hope we have integrated a lot of knowledge from pharma also, from psychiatry also, so that we can answer. Again very good. We discussed now. Bupropion we discussed has a side effect of seizure even in bulimia nervosa and anorexia nervosa. Because of electrolyte imbalance, seizure risk can increase. So again we'll avoid drugs like bupropion. Very good. Okay. So this is how such questions can be framed. Lastly, binge eating disorder is as the name suggests, here there is only binge eating. Patient is just eating and there is no compensation. No compensation. This is a new diagnosis and in fact it is now the most common eating disorder. Here again the weight or the BMI may be normal or may be at a higher side. Okay. यहाँ पे सिर्फ binge eating हो रहा है. Okay. I hope this is clear to everyone. Very good. Now let me just touch upon some more topics. Narcolepsy, again it's a sleep disorder topic. It is a REM disorder. It is a REM disorder. So here what are the symptoms? There are the 4 tetrad of symptoms. क्या symptoms हैं in narcolepsy? Sleep attacks. This is the most common. Patient says, sir, I am sleeping a lot. There are strong urge of daytime sleepiness. Patient office जा रहा है, suddenly patient sleeps on the street. Cataplexy. Can you appreciate? ये है cataplexy. Narcolepsy में you don't have catalepsy, you have cataplexy. So what is cataplexy? Now we know in REM there is muscle tone paralysis. We know in REM there is muscle tone paralysis. So cataplexy is there is sudden loss of muscle tone. Sudden loss of muscle tone. Patient is awake. He is sitting, suddenly he falls. sudden loss of muscle tone, if REM has entered the body. हाँ. Sleep paralysis का मतलब है patient wakes up from sleep but he realizes he is not able to move the body, as if REM has entered the wakeful state. Hypnagogic means hallucination occurring while going to sleep, and hypnopompic means hallucinations occurring while coming out of sleep. Okay, so please remember gogic and hypnopompic. Okay, and treatment. Now cause, one of the important causes, there is deficiency of hypocretin or orexin. It is required for alertness. So ये deficient है. Now in the treatment again we can use strategies like forceful daytime naps we tell the patient to take. In drugs, one drug you can remember we discussed this drug even in CNS stimulant है ना. We want to keep the patient awake. So yes, modafinil. It's a alpha 1 agonist. Very good. Very good. I hope this is clear to everyone. Answer this question. So answer this question. A male patient comes with a history. Again in sexual disorders, now this is a topic which is being repeated again and again. With a history of marital conflicts, complains of early ejaculation. So what is the diagnosis you are making? Ejaculation is occurring early. You are thinking of PME, premature ejaculation. Again and again they are asking, some of the non-pharmacological matlab some important, therapy or psychosocial interventions we can use, psychological interventions we can use. So what is the answer here? Very good. I am very happy all of you have answered correctly. It is squeeze technique. Very good. It is squeeze technique. So just see this table. So we will discuss two important disorders. One is erectile dysfunction and another is PME. This question was once asked in a NEET PG exam. So remember, E for erectile dysfunction, E for it's a problem of excitement phase. So there are 4 stages of sexual response cycle. No? So there is, you can remember it with the mnemonic DOR: desire, excitement, orgasm and resolution. So erection is occurring in excitement, so we say it's a problem of excitement phase. And PME is a disorder of orgasm. See, ejaculation is occurring in the orgasm phase, so any problem related with ejaculation will be a problem of orgasm. This was asked in NEET PG. Now coming to the treatment in erectile dysfunction, the erection is not satisfactory. So again in the drugs, in the therapy we can use sensate focus technique, remember. In fact, for any sexual disorder we use dual sex therapy. This may be asked as a question. Dual therapy is used for which disorders? Sexual disorders. For ED, the therapy, remember, is sensate focus technique. And what are the techniques we used for PME? Very important. Again and again repeatedly asked in the exams. One is squeeze technique, another is stop start technique. Drugs, I am sure in pharma you must have read. These PDE5 inhibitors, all the drugs with fill, sildenafil, tadalafil, vardenafil and avanafil. Tell me one drug which you can use for PME. We have talked about this drug when we were discussing antidepressant. Side effect of one drug we are using here. Can anybody tell me which drug I am talking about? I am talking about which drug? Yes, SSRIs we discussed has side effects. So it has a side effect of delayed ejaculation. Very good. So we are using side effect of this drug in the management. Okay. So please be very careful, especially in FMG. In NEET PG also. Please remember some of these questions can be asked. Very, very careful, as we have just discussed this question. Now again, image based questions you will see a lot of times. Especially these questions have been asked in NEET PG and INI-CET, and now we can also expect these questions in even the FMG exam. Now when we do EEG, I will discuss some important findings in different phases of sleep. So please remember, especially, so we know that sleep is divided into NREM and REM, isn't it? NREM is further divided into N1, N2 and N3. Now in N2, remember N2, there are two important EEG findings, very, very important. I'll just show you these findings. Please be very careful. On EEG, N2 you will get two findings. One is this. Can you appreciate there is sudden burst of activity? These are sleep spindles. These are sleep spindles, or can you appreciate these sharp positive and negative wave? These are K complex. Dekho, earlier in even FMG they have asked names. NEET PG, INI-CET they have also given the images. So please be very careful. Also when we see EEG on REM, remember on EEG we get beta and alpha waves. Dekho, beta alpha waves tab milti hai when we are awake. But this is the paradox कि we are in REM but हमारा brain is showing waves when we are awake, beta alpha. So that is why REM is known as paradoxical sleep. Can you appreciate these high frequency wave but the height is very less? What is this appearance known as? Can anybody tell me? This is known as sawtooth appearance. Very good. This is known as sawtooth appearance. Okay, so please be very careful. I'll show you one more question in the end I'll discuss. Before this, let's touch upon this topic of personality disorder. देखो 24-year-old male presented for evaluation. He appears very calm and charming. He behaves well in front of the psychiatrist. However, gets into fight with friends, bunk classes, break traffic rules, involved in multiple police cases. This was asked in the previous year question. Previous year exam mein this was asked. Tell me, can you appreciate patient is showing antisocial behavior? He's showing antisocial behavior. The diagnosis is antisocial personality disorder. But a narcissistic, again remember, so we have three clusters, cluster A, B and C. So let's see this personality disorder. Dekho, what do you mean by personality disorder? All of us are 18 and above, we say, generally personality ka matlab hai the way we deal with day-to-day situation. Usually personality develops during the 17, 18, 19 years of age. So hum sabki ek personality hai. So remember, all of us have a personality which develops by this time and it remains stable through time. If somebody has problem in personality, so personality disorder, but it will also develop during this time. So personality disorder will also remain, develop during this time of late adolescence, early adulthood, and it will remain stable through time. So in personality disorder, family members or the question will be asked that patient is having a long standing history of symptoms. Then you will think of personality disorders. So personality disorders, again there are three clusters: paranoid, schizoid, schizotypal in cluster A. Cluster B mein there are 4. Remember, antisocial we have just discussed. Patient is having antisocial behavior. He is violating rights of others. Borderline I'll discuss, very important. Histrionic mein patient wants to be the center of attention. Narcissistic personality disorder, patient has heightened self-importance, that I am more important. In cluster C, we have avoidant anxious personality, dependent personality, patient is dependent on small things on others, and OCPD, patient wants to do everything perfectly, follows all the rules and regulation. So these are the three clusters. You can remember with very simple W. Remember W, A personality may remember weird, 1W for B remember wild, and remember for C worried. Okay, so these are the three clusters. Again, they are asking recently, many exam questions have been asked on personality, so please be careful if they ask question. I'm sure you will be able to answer such question. Na? So here the patient is having antisocial personality. See this, borderline personality. Very important. The treatment of all these personality disorders is therapy. We'll talk about specific therapy for borderline. Now, it is more common in females than males. Patient has unstable relationships. One day they'll say, oh my God, you are the best person, you are my angel. The second day, they may say you are the worst person I know. So the interpersonal relationships are unstable. Patient may have impulsivity. There may be recurrent suicidal behavior or they may threaten. Sometimes you may see a lot of cut marks may be there. Mood may be unstable. You are thinking of borderline personality disorder. Again, one important therapy. Can you name one therapy for borderline personality disorder? Anyone? One important therapy. Can you name? There can be comorbid certain other conditions also may be there. Very good. It is dialectical behavior therapy, DBT. Very good. So I hope this is clear now. Lithium is one drug which we always cover. So again, I'll share this PDF. You will get the notes of lithium. This is one drug which I always say, please read it. Don't let go of lithium. Lithium is one topic which you should definitely revise before the exam. You'll see many questions on lithium. One person you can remember, John F.J. Cade. He did a lot of studies to establish the role of lithium as a mood stabilizer. I'll give you this list. Again, we know it has a narrow therapeutic index 0.5 to 1.5. Acute mania mein it is 1 to 1.5 milliequivalent per liter. Maintenance mein it is 0.6 to 1.2. Toxicity would occur when it is more than 1.5. Okay. and this is a mood stabilizer which has anti-suicidal property. Coming to the side effects, again very simple, you can remember it with the mnemonic lithium. Loss of hair, loss of appetite, increase in the leukocyte counts, it can do tremors. What is the treatment of lithium induced tremors? Remember, in side effect it is usually fine tremors. Toxicity mein usually you will see a lot of coarse tremors. So what is the treatment of lithium induced tremors? Propranolol. Treatment is with propranolol. It can also cause endocrinal abnormality like hypothyroidism, hyperthyroidism. Even remember, it can cause hyperparathyroidism. It can increase urine intake, it can increase the urine output, and it can cause diabetes insipidus. What is the treatment of lithium induced diabetes insipidus? Anybody? Remember, we can use thiazide or potassium sparing diuretics. Now very important, you should remember one important interaction. Thiazide diuretics, remember, they decrease lithium clearance. So very important. If I am treating a patient with lithium induced diabetes insipidus और मैं उसको thiazide diuretics दे रहा हूँ, so lithium toxicity can occur. So I will reduce the dose of lithium, and one we have already discussed, maternal में Epstein anomaly can occur. Tell me, lithium causes, देखो, although I am saying it causes decrease in appetite, but overall we say that it may increase even the weight. So weight gain can occur with lithium. So these are some important side effects which you should remember. Now again, two important points when we are checking the lithium levels. Remember, suppose if I am starting patient on lithium today or I am increasing the dose today, when will I check the lithium levels? Remember, after 5 days, that is on the 6th day, I will take the sample. When I am taking the sample, what is the ideal time to monitor the blood levels related to the last dose? देखो, दो different questions हैं, remember, then the answer will be 12 hours plus minus 30 minutes. I hope this is clear. Two different questions, different answers. I hope this is clear to everyone. Toxicity, again remember, mild may patient may have symptoms like ataxia, nystagmus. Moderate may patient may have convulsions, stupor, coma. Severe may patient may have renal failure, oliguria, and even death can occur. So these are again some of the signs and symptoms you should remember. We have always been discussing na ki our body treats sodium, lithium like sodium. देखो, very important, हमारी body lithium को sodium की तरह treats. So suppose a patient is having dehydration, suppose a patient is having vomiting, diarrhea, what the body will do? It will reabsorb sodium, it will reabsorb lithium. So toxicity can occur. So again, please be very careful. Dehydration, vomiting, diarrhea, that can cause lithium toxicity. One has to be careful. Okay, right? I hope this is clear. In the treatment, again, we'll stop lithium, correct hydration. If there any unabsorbed lithium beta from GI tract, we will use polyethylene glycol, sodium polystyrene sulfonate. Severe cases में please see yes. Hemodialysis has a role. One specific question for INI-CET I will discuss, which may have chances of getting repeat. This question was that a patient is pregnant, now is in 3rd trimester. She is on lithium and she is stable. What will you do? देखो, it is slightly a tricky question. If a patient is on lithium and she is stable, rather than increasing or decreasing, I will monitor. Better answer is monitor the levels. But that was not there in the option. One option was increase the dose, one option was decrease the dose. So the answer here is, again, it is slightly controversial, just try to hear me out. So see, I will, we know because of the changes which occur in pregnancy in the 3rd trimester, the lithium levels may decrease. But here nowhere they have mentioned that the symptoms, the patient has again developed symptoms. So better answer is I will monitor. But also we know that, before the delivery, we have to, again decrease the lithium dose, or we have to stop. And then again after, the birth, we will again start lithium. So again, then I can go with decrease in the lithium level. So please remember, I will increase, if the monitoring, the levels are low, or if the patient has developed symptoms again. Because again, we know lithium toxicity can also occur. So here again, such questions may get repeated. Remember this question, patient was stable. So this is how we can answer. Tell me this, a patient on mood stabilizer has developed hyperammonemia, hepatitis, there is raised hepatic enzymes. What is the drug which is most likely responsible? Just few slides, I think 3-4 slides, and lastly I'll just show you the slides which I will be sharing with you. 3-4 slides are left, and lastly I will just show the slides, especially those who are planning for INI-CET exam. Just 3-4 slides are left. Okay, tell me which is the drug. Yes, it is valproate. Very good. So remember, adverse effect for valproate you can remember with the mnemonic valproate, especially in this you can remember the mnemonic plate. Okay, remember P for pancreatitis, even decreased platelet counts are there, thrombocytopenia can occur, liver toxicity can occur, hyperammonemia, increase in the ammonia levels, it can cause teratogenicity, we know, excessive sedation in elderly. So remember the drug here is valproate. So I have just given you a mnemonic also, you can remember. Answer this question. Because this was asked in last year exam. So can you appreciate, see this, they have asked what is this stage representing. They have mentioned EEG, EMG and EOG. Can you see that EEG here is fast, here it is slow, here also it is fast. So let me just say 1, 2 and 3, I have to identify 2. Yes, EMG, muscular activity, here it is present, here also it is present, but here it seems to be absent. EOG, here it is fast, it is also fast here, it is slow here. Very good. This is REM. देखो REM में we discussed ना कि EEG is beta alpha, it is REM rapid eye movement na, so EOG is also fast, and we discussed that muscle is in a state of paralysis. While 3 is here EEG slow, here movements are present, and also EOG it is NREM. NREM especially it is N3. We can see delta waves. So this is 3 and this is awake state. Everything is increased. So this is awake. So the answer here is REM. I hope you will be able to counter such question. Second last slide, then last slide, then I'll just show you some slide which I'll be sharing with all of you. Okay, tell me transference is what? Sometimes patient develops feelings which are unconscious or conscious towards the doctor, towards the therapist. These can be positive feelings, these can be negative feelings. इनको कहते हैं transference. Counter transference क्या है? Opposite. Sometimes doctor or the therapist can also develop feelings towards the patient. Conscious भी हो सकते हैं, मतलब patient is aware, doctor is aware. Unconscious means the person is unaware. Okay. Now last slide, and then I'll just show you the slide which I'll be sharing. Dekho, this is a topic which you will also read in forensic. Even in the psychiatry videos you will see this topic. This is a topic you will see again and again they are repeating. Paraphilias. So please remember what is fraudeurism. What is fraudeurism? Okay. Now na please remember, पहले हम stage 1, 2, 3, 4 कहते थे in NREM. Now stage 1 is known as N1, stage 2 is known as N2, 3 and 4 now are known as N3. So N3 means stage 3 and 4, जो previously 3 and 4 था. Fraudeurism is T for remember touching, rubbing of private parts. Very good. What is ionism? It is another term for transvestism. Transvestism. देखो, trans means opposite, vestism means clothes. So here wearing clothes of opposite gender patient is getting sexual gratification. Necrophilia is what? Necrophilia, necro means dead, sexual intercourse with dead body. Algolagnia is basically sadomasochism. Okay, that is sexual gratification by pain. So answer is this. So please remember this. देखो, one more point, there is something known as gender identity disorder. That there is problem in the gender identity. There is one disorder there, transsexualism. Transsexualism. Just see this. How will you differentiate transsexualism from transvestism? देखो, transsexualism means opposite gender. Patient wants to live, wants to be accepted like a person of a opposite gender. So let us say a female says, sir, I have a wish to live like a male. So here also patient may wear clothes of opposite gender. How will you differentiate? In transvestism, patient is getting sexual gratification by wearing the clothes. Here there is no sexual gratification. Patient wants to live like the opposite gender. Please remember this. I hope this is clear to everyone. In transsexualism, we can give hormonal therapy to make the person as close as possible to the desired gender. Hormonal therapy we can use, and also we can do surgeries so that the person may look like the opposite gender, like the desired gender. Okay, so these were some points. I'll just show you the slides which I'll be sharing, especially for INI-CET. I'll give you some criterias, like SCOF criteria is used for eating disorder. Confusion assessment method was once even asked in NEET PG. Remember confusion, है ना? confusion is seen in delirium. So even if a new question comes, now please be prepared. Just see the name, sometimes just reading the name you will get the answer. MMSE is for dementia, and PANS is positive and negative syndrome scale. So remember, it is for schizophrenia. We know positive and negative symptoms are there in schizophrenia. For alcohol use disorder, we have CAGE and audit. Okay. Now again, I'll also give you this slide. This is again, you'll read in forensic also, Mental Health Care Act. Please, read important points. What is advance directive? In advance, we can write a directive. Nominated representative, we can nominate someone to take a decision for us if we are not in the capacity. There is decriminalization of suicide. Also, this question was asked, although not a very clear question. Maximum duration of admission in a mental health establishment 30 days. Of course, it can be extended, but at one go, it is 30 days. Remember this. I'll share this table also, this slide also, where I've discussed some important disorders which are more in female, more in males. Equal may remember schizophrenia, bipolar 1, and also social phobia. I'll give you some data also. Okay, so read these data again. You can, especially for INI-CET, they are asking a lot of epidemiology questions. Now, rate of suicide in India, this all of us can remember. In the 2022 latest data we have of NCRB, it is 12.4 per 1 lakh population. Also in suicide, remember one point, what is paradoxical suicide? Paradoxical suicide is when the patient in the initial stage of treatment or recovery, patient attempts suicide. This is known as paradoxical suicide, which was asked in NEET PG once. देखो, हमने ट्रीट करना शुरू किया और पैराडॉक्सिकली पेशेंट ने सुसाइड अटेम्प्ट कर लिया. दिस में अकर बिकॉज देर इज गेन ऑफ एनर्जी. पेशेंट से सर मुझे गेन ऑफ एनर्जी तो है बट अभी भी सुसाइडल थॉट्स हैं. So this is paradoxical suicide. So I'll share these important data slide. You can just go through them. I'll also share some most common comorbidities. For agoraphobia, it is panic disorder. Remember, OCD, it is depression. This has been asked in INI-CET. Okay, and then I'll share some of these acronyms. They have talked about HEADS assessment is used for adolescent. When we are assessing adolescent, we take care of these areas. Also, there are certain acronyms for breaking bad news. You should know SPIKES protocol. Again, this has been asked in INI-CET. For building rapport, you can remember the mnemonic PEARLS. Again, I'll talk about frames. I'll share these frames when we are doing active, brief intervention. So we follow, we take a feedback. We make the patient, you should be responsible for your behavior. Like person, we wants to stop his alcohol. We give advice, we give a menu of options, we show empathy and also self-efficacy. For motivational interviewing, you can remember the mnemonic DARES. Especially remember, E for empathy, self-efficacy, these may be asked. Stages of change may remember the mnemonic PCPAM. A person, let us say he wants to quit alcohol, he may pass through these stages. P is pre-contemplation, then contemplation, then PCPAM, preparation, action and maintenance. Okay, so these are PYQs actually, so I've just added them so that you get an idea. Okay, I'll share one more. There is a dementia which again has been added in the newer edition. Remember, late, limbic predominant, age related, more than 80 years में मिलता है, TD, P43 encephalopathy. Just remember the mnemonic, late. So new questions if come, they may ask. I'll share some drugs also. Yeah, so I think this was it. I'll add more. I've added more slides. I'll share them. So lastly, again, I always say this. Again, a very important quote by Charles Darwin: "It is not the strongest nor the most intelligent of species that survive, but the one that is most adaptable to change." So again, in these upcoming weeks or months before the exam, make the use of the day to the best of your ability. Think positively. You will be able to get a good rank if you utilize these days the best of your ability. That is what we want. You do your best so that when you come out of the exam, you say, I have done my best, and you will see the result will be in your side. Okay, so get up in the morning with the hope I'm going to have a good day. In the night when you're sleeping, no matter how the day went, be happy, be grateful. Apply this every day. Take one day at a time. And again, I'm waiting to listen to your success story. All of us, in fact, at PrepLadder are waiting eagerly to listen to your success story. So take one day at a time, take one session at a time, and always I say, keep smiling, keep a smile every day. Smiling will not change the circumstances, but it will change the way you are handling things. Keep moving forward. Take one day at a time. Thank you so much. Thank you everyone. May God bless you always. Thank you. ठीक है? Thank you.